To the distinguished heads of medical of the steel fraternity, esteemed judges, delegates, ladies and gentlemen, myself Dr. S. Sinha, CMIC Banpur, along with Madam Dr. Pushpa, AISMOC.RSP, welcome you to this session, MBBS paper. As you can see, it has been a very exciting ambience over here. And I would like to thank the organizers for arranging such a wonderful venue for AISMOC 2025. We'll begin this competitive section with the MBBS paper. We'll have 6 speakers. Dr. Madhavi will not be able to join from Vizag. So we have Dr. P.J. Roy, RSP, Dr. Jagannath Acharya, Tata Steel, Dr. Shiva Martha from Bhilai, Dr. Gargi Bayan from Burnpur, Dr. Urvi Banerjee from Bokaro, and Dr. Rohit Rai Chaudhary from Durgapur. The duration of your presentation will be of 6 minutes. There will be a buzzer at the end of 5 minutes, which is to be considered as a warning bell. And you will have a long buzzer at the end of 6 minutes. That is where you stop your presentation. Following that, as the speaker. Now I would like to hand over the mic to Dr. Pushpa.
There shall be a negative mark for the who will overshoot the time. So be careful about your time. So you have to finish your topic within time. Thank you. Start.
I may now request Dr. P.J. Roy, Rottler Steel Plant, to present his topic, Cannulation of the Internal Jugular Vein, Landmark versus Ultrasound Guided Approach, a Comparative Study. Thank you.
esteemed dignitaries, warm greetings from the fraternity of Ispat General Hospital, Rourkela. I will be comparing two approaches that we have been using while cannulating the internal jugular vein. Central venous catheterization is a widely performed procedure in critically ill patients. In our ICU, it is used as an IV access for infusion of blood products, irritant substances like TPN, vasopressors, and renal replacement therapy and volume replacement. Being an invasive procedure, it has a learning curve for the operator and is associated with known complications which increases the morbidity. Based upon the success rates, low risk of complications, internal jugular vein is the most commonly cannulated vein, and amongst the two sides, the right IJV is preferred over the left as it has a straighter path to the superior vena cava, usually is larger in diameter and avoids injury to the thoracic duct. Most importantly, more operators are experienced in cannulating the right IJV as compared to the left. Classically, the landmark approach using surface anatomy has been used for venipuncture. However, the approach is limited by non-availability of ultrasound due to the anatomical variations and blind nature of the procedure. Presently, the ultrasound-guided approach is considered to be the gold standard, and it improves the improves the procedural outcome. However, it is limited by non-availability of dedicated ultrasound devices and lack of trained manpower. The aim of our study was to compare the catheterization of right internal jugular vein using the landmark approach versus the ultrasound-guided approach in the ICU patients, with respect to the ease of insertion and the related complications. The study was done as a prospective comparative observational study in our hospital from July 2022 to January 2024. After approval of the hospital ethical committee, consenting adult patients of either sex requiring cannulation of the right IJV were selected. Patients who failed to consent or had recent cannulation of the IJV or with anatomical deformities or local pathologies were excluded from the study. Moreover, those requiring cannulation in an emergency basis were also not included in the study. Based upon the inclusion and exclusion criteria, a total of 140 candidates were selected and 150 candidates were selected and divided into two groups: A, for those who underwent cannulation in the landmark approach, and B, who underwent cannulation with the ultrasound-guided approach. The procedure was done by and had hands-on training. The parameters observed were under the following heading: ease of access, wherein the operators were timed from the point they held the introducer needle to the skin and successfully placed the guide wire. The number of attempts for significant in our study. In 4 cases, we had to change the approach from the landmark to the ultrasound-guided approach, as we had failed to cannulate even after repeated attempts. We also had to revert back to the landmark approach in 1 case due to the malfunction of the ultrasound device. To summarize, the results in our study, we found that using the ultrasound approach, the time taken for catheterization and the incidences of hematoma formation was less and was statistically significant. In our study was comparable to other required and the complication rates using the ultrasound-guided approach. Moreover, the use of ultrasound is considered to be a gold standard and has been incorporated in various practice guidelines. However, the use of ultrasound is always been limited by logistic issues like absence of dedicated and trained manpower. Moreover, relying overtly on the approach may lead to downskilling of the landmark technique, which is required in the situation and when the device is not available. be used in cases requiring planned cannulation and where difficulty in cannulation is anticipated. It is the gold standard and improves the procedural outcome. However, we must keep in mind that there are times the landmark technique and the skill set required for the same should be preserved by the operator. Thank you. These are my references.
So now session is open for the question. So please introduce yourself, then ask question.
Yeah, I'm Dr. Abhijit Dam from Bokaro General Hospital. So based on your study, do you recommend an ultrasound guided approach as a routine for all steel medical units all over the country? Would you recommend that based on your study, based on the safety standards which you have shown?
So the ultrasound guided approach is the gold standard. It is the way to be.
Would you
But
recommend?
however, in the steel medical setup, we are having various people doing the central venous catheterization, like anesthetists, medical specialists, or nephrologists. So it is a mixed group of people. All of them may not be comfortable with ultrasound machine. So
But you said that this is the gold standard.
it is the gold standard,
This
sir.
is the way forward.
It is the way forward, sir.
So don't you think that we should now be shifting to what is the gold standard for the?
Sir, it is the gold standard, and it is there in all the standard practice guidelines. We should, wherever possible, use the ultrasound machine. However, in emergency situations, yes, sir. The topic of my presentation was to reflect that the ultrasound is the gold.
Was it or how?
So after the selection criteria, the patients were randomized 1:1, one into the group A group and the other.
What I mean is, you may not have similar type of patients in the two groups. Have you checked for that?
Coagulation disorders were also excluded. They were cannulated. Not included in the study,
So
sir.
that I understand from your exclusion criteria.
Good morning all, respected delegates. Critical illness associated mental health outcome is an emerging challenge. The psychic strain patients experience in an ICU is a global burden. Which is of three types: hyperactive, hypoactive, and a mixed variety. The prevalence of delirium is as high as 40 to 60%. Hyperactive delirium has host prognosis with increased mortality. Effects of delirium being extended ICU and hospital stay, lower 6 month survival, and long-term mental health impairments as highlighted by World Mental Health Care Association. Following delirium, post-intensive care syndrome is a combination of physical, mental, and emotional symptoms that continues to persist in the post-ICU period. With the above background, we undertake a study to understand the impact of ICU stay and associated parameters on mental health outcome and its long-term effects. This was a prospective study conducted in intensive care unit Tata Main Hospital, Jamshedpur, of 18 months from 1st April 2023 to 30th September 2024. Patient details and subsequent follow-up data are taken as a data source. Patients above 18 years of age and positive result on screening tests were included, where pre-existing neuropsychiatric diseases and patients not willing for study or follow-up and lost to follow-up were excluded. The delirium was assessed by a method that is known as confusion assessment method or CAM-ICU score, where acute onset of mental state and inattention, disorganized thinking, and altered level of consciousness were considered as parameters. Similarly, post-intensive care syndrome is diagnosed by a standardized tool where a weightage or score of more than 2 is considered to be PICS positive. Before the study, informed consent were taken from the relatives, daily evaluation done during preferably sedation holiday if the patient was on sedation, then treatment provided as per the protocol. We include evaluation and treatment of delirium during ICU stay, post-ICU stay, and post-discharge for 3 months. A fortnightly questionnaire over phone was asked to assess the PICS scoring. The parameters included are prevalence and types of delirium, demography, associated comorbidities, associated organ failure, respiratory and vasopressor support, quality performance and outcome, and severity of PICS. Out of total 1834 patients admitted to intensive care unit during this period, 592 patients were found to have delirium, out of which 368 patients were included in our study and 224 excluded due to various reasons. Out of which 251 patients were found to have presented with PICS, 70 patients improved during that period, and 47 patients lost to follow-up. During critical care follow-up, 43.2% patients were found to have hypoactive delirium. The mean duration of onset of delirium was 3 days. This was a study based on female predominance and age predominance, that is, elderly person with more than 70 years of age are found to be having more delirium. Type 2 diabetes and hypertension are found to be associated with more risk factors associated with delirium. 66.8% patients are found to be have presented with respiratory failure. 2 organ failure was common. Out of 368 patients, 246 patients were presented with respiratory failure, where 53.5% patients were on invasive ventilator support. 174 patients required vasopressor support, out of which 57.8% patients were on single vasopressor. The quality performance indicators like reintubation, readmission, length of stay, and mortality were significantly high in patients with delirium in comparison to patients without delirium. Post-critical care follow-up, we found 251, that is 68.2% patients of total patients of delirium presented with post-intensive care syndrome or PICS, out of which 44% patients were found to have severe scoring. Out of the entire 251 patients, 147 patients improved and 47% died during the 3 months period, and 30% were still on treatment and 27% lost to follow-up. Our study indicates prevalence of delirium is around 37.73% and female to male ratio is 57.43%, which also coincides with other national and international publications. Length of stay and mortality in case of delirium was 1.5 times higher, which also corresponds to other national and international publications. The mortality in post-intensive care syndrome within 3 months was 18.7% in our study, and other studies ranges between 15 to 45%. To conclude, 1/3 of ICU patients experience delirium and hypoactive were more common. Diabetes and hypertension were identified as the primary risk factors. High incidence of delirium noted among females and elderly patients. Patients with delirium have extended hospital stay, ICU stay, and increased mortality. Delirium has significant negative short-term impact and long-term effect on mental health. Post-intensive care syndrome was significantly high in patients with delirium. As a take-home message, delirium is a concern in seriously ill patients admitted to the ICU. Elderly and early identification and corrective measures can circumvent this event to a great extent. These are my references. Thank you.
Now it is open for the questions.
I am Dr. Avijit Dam from Bokaro General Hospital. Well, your study, I believe, was finished last year in September, something like that, September 24?
April 20.
Okay.
Sir, April 2023.
Okay. And since that time, what steps did your ICU take to reduce the incidence of delirium? You showed an incidence of 37%. So after this study, what steps did your ICU actually take to actively reduce the incidence of delirium further?
Sir, we are actually finding the etiology of different factors, just like
That you already showed.
Yeah.
So now, what steps did your ICU actually take proactively to reduce this incidence?
Sir, one treatment as per the etiology, just like pain management and the physical restraint part, and also correction of metabolic factors, and also quality improvement in sedation. For example, we are using dexmedetomidine in place of benzodiazepines.
Did you use any non-pharmacological modalities?
Sir, at present we are not using, but for some patients we also consult with our psychiatrist so that they can.
I said non-pharmacological.
Non-pharmacological, sir, we are not using.
So
we are just patient
I
counseling.
think is the first step towards preventing delirium in such
Sir,
settings.
sir, we are counseling those patients, and
No,
also
you cannot counsel a critically ill patient always, right? But the non-pharmacological approaches like changing the environment, having a conducive environment.
no, that sir we are following during the discharge, post-discharge phase, during peaks.
Second, please give mic.
Hello, I am Dr. Jayant from AISMOC General Hospital. I just want to know, in one slide you showed delirium was in day 3. So when is your follow-up? When was your first follow-up after discharge? When was your follow-up schedule? What was your follow-up schedule? What was the first follow-up after discharge? When?
Sir, as I have mentioned, that was actually diagnosis of delirium from the day of admission. On the day 1, we actually evaluate whether the patient was having a chronic history of delirium, delirium tremens, or other periods. Then every 24 hourly, if the patient is also even sedated, we took that sedation holiday phase to assess delirium. Post-discharge, we follow that peaks, post-intensive care syndrome.
When?
That
When
fortnightly. Sir, I have mentioned already.
When?
Fortnightly. Every fortnightly via a questionnaire. That I have mentioned. Good. Sir, your mic is not audible.
Hello.
Yes.
I'm Dr. Uday Kumar Das from Banpur Hospital.
Well,
Yeah. My question is that what are the factors which affects the delirium in patient admitted in ICU? Was there any age and gender correlations?
Sir, as I have mentioned, this is female predominance is there, and age, mostly the elderly patient, particularly beyond 70 years of age, are associated with this patient. But some of the etiology which I have not considered, because this is a very long study and this is a chronic study, some of the factors may be pain, just like physical restraint, and also metabolic disorders, pattern of sedation. They have already been considered in our study.
Sir, good morning. I'm Dr. Shovik Chatterjee from Banpur Hospital. You have mentioned as a cause.
Please be seated. Okay.
Thank you.
You should not discuss. Only ask question. It is not a discussion.
I may now request Dr. Shiva Martha, Bhilai Steel Plant, to present his topic, Study of Bone Mineral Density in Patients of Hemoglobinopathies.
Kasi? Dr. Kasi, please turn.
may we please request all the delegates to submit their presentations at the preview room that is adjacent to the parallel session room. Thank you.
Okay. Respected Chairperson and judges and distinguished delegates. Myself, Dr. Shiva Mathas, Senior Medical Officer, Bhilai Steel Plant. Today I am going to present a study of bone mineral density in patients of hemoglobinopathy. Sickle cell disease and thalassemia are two major hemoglobinopathies, and this map shows you sickle thalassemia belt, which includes some part of Madhya Pradesh, Maharashtra and or Chhattisgarh. So the pain in the sickle cell disease patients in acute phase it might be due to vaso-occlusive crisis. In chronic phase it due to the sickle bone disease. Apart from that, osteoporotic pain also common in sickle cell disease, because sickle cell disease is an independent risk factor for osteoporosis. Even in well-treated beta thalassemia patient, the prevalence is about 13.6 to 50% of osteoporosis, which increases the risk of fracture about 44% more frequently in upper extremities. The pathogenesis of sickle osteoporosis in hemoglobinopathies, which include chronic inflammation due to vaso-occlusive crisis and irregular RBC production in the thalassemia, which increases the rank ligand cytokine, which increases osteoclastic activity. And another mechanism which includes chronic anemia, which causes bone marrow hyperplasia, which causes bone marrow expansion and cortical thinning and decreases the bone osteoblastic activity. The imbalance between the osteoblastic and clastic activity finally results in the osteoporosis. Other causes of osteoporosis, which includes advanced age, long-term corticosteroid usage, post-menopausal status for women, and heavy smoking, alcohol consumption, vitamin D deficiency, and parathyroid-related disorders. The paucity of published data on this topic encourages us to conduct this study. Aim of our study is to evaluate the incidence of osteoporosis in patients of hemoglobinopathies and the incidence separately in different hemoglobinopathies. We have included sickle cell trait, sickle cell disease and thalassemia major patients in the study, and we have excluded less than 18 years and more than 40 years of age. Our study is a prospective observational study conducted over a period of 1 year in JLN Hospital and Research Center. After taking detailed history from the patient, routine investigation which includes CBC, serum calcium and DIXA scan was performed. We have taken two groups with a sample size of 59 according to the reference study and statistical formulations. 59 participants in study group who are having hemoglobinopathies, and in control group 59 individuals with normal. Bone marrow BMD is calculated by using DEXA scan, mainly by using two scoring system which includes T-score and Z-score. T-score which compares the BMD with to a healthy individual of 30 years. The normal T-score is -1 higher, and -1 to -2.5 which suggests of osteopenia, and -2 and lower considered as osteoporosis. The Z-score which compares the BMD of same age, sex and ethnicity, the less than 2 standard deviation of the Z-score considered as severe osteoporosis. This is a DEXA scan we commonly using. There are two major body part focus, which is hip and spine. These are the sample reports. Coming to the result, the mean hemoglobin and serum calcium levels in the study group is 9 and 8. In the control group, it is 13 and 10. So this mean hemoglobin and calcium levels suggesting of low serum calcium levels in the study group. Coming to the BMD results, in the mean T-score and Z-score in the BMD hip analysis, it is -1 and 1 in the compared to the control group, and the BMD spine T-score and Z-score mean values is -2 compared to 0 in the control group. So this suggesting of low BMD levels in the study group. Out of 59 individuals, 8 patients had thalassemia, 32 patients had sickle cell disease, and 19 had sickle cell trait. The BMD hip results analysis revealed that 75% of thalassemia patients had osteoporosis, and for 34% of sickle cell disease, and 15% of sickle cell trait patient had osteoporosis. In the BMD spine analysis, 100% of thalassemia patient had osteoporosis, and 40% of sickle cell disease, and 15% of trait patient had osteoporosis. So our study concludes that the study group showed the prevalence of 33% of osteoporosis and osteopenia in hip analysis in the study group, and 48%, 28% respectively in the spine analysis. In the control group, these are 15% and 5% in both analyses. So this highlights the risk osteoporosis caused by the hemoglobinopathies. And the risk of osteoporosis highest in thalassemia, followed by sickle cell disease, and least in sickle cell trait. These findings highlight the importance of monitoring of bone health in hemoglobinopathy patients. Our study had concordant results with other international studies. And the take-home message is early diagnosis and management, which prevents the osteoporotic related fractures in hemoglobinopathies. So the main treatment modalities, which include bisphosphonates and denosumab, rank ligand gated, which is a newer rank ligand gated inhibitor, and teriparatide, calcium and vitamin D and bone strengthening exercise, which improves the quality of life of the patient by preventing the fracture. And annual DEXA scanning should be performed in high risk individuals. That means who are having regular blood transfusion and severe iron overload and hypogonadism due to iron overload in various parts of the body. So the annual DEXA scan, which prevents the and low risk individuals who are having low risk individual, which is 2 to 3 yearly DEXA scan should be performed. And our study has some limitation. Vitamin D is a compounding factor, and our study has had some sample size small. And these are some references, and thank you.
Thank you. Now it is open for the question.
Dr. Sundar from Tata Main Hospital, Jamshedpur. Just wanted to know, I actually never knew that, in sicklers and thalassemics, that these subset of patients are prone to osteoporosis. Generally, we treat them with, bisphosphonates and calcium for a period of 6 months, and then we repeat the DEXA to see how the scores have improved. So, how long did you treat your patients? Do you advocate it for 6 months, 1 year, or for a lifetime, since they are going to be prone to the disease?
So the treatment usually, if we are not studied the results of management, after management, but in routinely,
I'm just asking the duration.
We will also perform DEXA scan after 6 months of treatment.
That's what I'm asking. And
Yes.
how long do you recommend the treatment? 6 months, 1 year, or for a lifetime?
Depends on the DEXA scan reports. Yes, sir. Sir?
Any particular reason for not choosing children in your study?
Sir?
Any particular reason for not choosing children in your study?
No, sir. Actually, there is no such reason, sir. But from medicine department, we have actually exposed it to only adult age group. So that is why.
I mean, you didn't involve the pediatricians in your hospital. You did not involve the pediatricians
No,
in
sir.
your hospital.
No, sir. Actually, we have not included.
Good morning.
2 questions are allowed. Please bear with us. You ask next.
I may now request Dr. Gargi Bain, ISCO Burnpur Steel Plant, to present her topic, a study of probiotics in children with atopic wheezing.
Should I start? Good morning, respected chairperson, judges and delegates. Today I am going to present a study of probiotics in children with atopic wheezing. So what is atopic wheezing? It's a symptom associated with IgE sensitization triggered by atopy, which is a genetic predisposition. By the age of 3, 25 to 30% children, and by age of 6, 40% of children had at least one episode of atopic wheezing. Serum IgE levels more than 200 international unit per milliliter has a sensitivity of 70 to 80% and specificity of 80 to 90% for predicting recurrence in atopic wheezers. Absolute eosinophil count more than 350 cells per microliter of blood has significant positive predictive value in atopic wheezing. This is a schematic of gut-lung axis, which is mainly a communication between these two organs, which facilitates the transmission of microbiota, metabolites, and signal between these two organs. Probiotics acts on this axis in case of allergy by modulation of T helper cell response and increasing the T regulatory cells and T helper cells and decreasing the inflammatory T helper 2 cytokines. To sum it up, it regulates the dynamic balance between immunoregulatory and pro-inflammatory cytokines. This study aims to evaluate the efficacy of probiotics as an adjunctive therapy in children with atopic wheezing. This is a prospective double-blinded randomized control study which started in June 2023 and ended in May 2024. Both ethics committee clearance and consent of the parents of the children were taken. Analysis was done using unpaired t-test and Wilcoxon sign rank test. The inclusion criteria consist of children aged 2 to 12 years, a positive family history of atopy, more than one hospitalization required for acute exacerbation, 3 or more episodes of recurrent wheezing, serum energy levels more than 200 international units per milliliter, and absolute eosinophil count more than 350 cells per microliter of blood. The exclusion criteria consist of immunodeficient and malnourished children, children with congenital anomalies like cystic fibrosis, congenital heart diseases, inborn metabolic disorders, parasitic infection, HIV cancer, children on oral corticosteroid therapy. The children were assessed for eligibility, a number of 60 patients, which were then randomizedly allocated in study group and control group. In the study group, study therapy was given along with probiotics containing Lactobacillus fermentum and Lactobacillus paracesi. Control group got only the standard therapy. Loss to follow-up in both the groups was nil, and both the groups were analyzed the following parameters, that is, serum energy level, absolute eosinophil count, number of hospitalization, number of episodes requiring rescue medication. In each visit, all the parameters were assessed along with clinical as well as adverse effect measures at 3 months and at 12 months. This is a diagram for serum energy level at the start of the study in both, where column indicates the level below 500, the yellow column indicates the level from 500 to 1000, and the grey column indicates the value more than 1000. This is the serum energy level of both the groups at 3 months, and this is the serum energy level at 12 months. After computing all the data, we can see that there is a decreasing value in the higher and mid-range group and increasing in the lowest range group in both the control and study group. But in comparison, there is a more prominent in the study group. Next, we come to the serum AC level at the start of the study of both the group, where the red column indicates the value less than 500, the yellow column indicates the value 500 to 1500, and the grey column indicates value more than 1500. This is the value of serum AC after 3 months of adjuvant therapy. And this is the serum AC level at 12 months, where we can again see that there is a gradual decrease in the higher and mid-range group and increase in the lowest range group. After doing the analysis, we can see that both the parameters have got the 0.01, which is statistically significant. Diagram showing the number of hospitalization in 1 year, where we can see in comparison to control group, the group has value range. In the next bar, see the number of episodes of rescue medication in a year, where we can see the number of study mean value is lesser than the control group. Analysis by Wilcoxon's line rank test, we get the mean value of control group and the study group, and the p-value of both the tests is less than 0.01, which is statistically significant. This result shows that if probiotics is given as a therapy, it gives us an edge in recurrence as well as maintaining the exacerbation of severity. This study also shows the effect of probiotics is not short-lived and continues even after the initial therapy. The limitation of study are small sample size, limited time frame, limited resources, and single-center study. In conclusion, combination of Lactobacillus paracesi and fermentum as an adjuvant to standard therapy appears to be more effective in reducing recurrence of wheezing attacks, severity of exacerbation, and eventually improving overall quality of life. Take-home message is, it usually involves learning to recognize the triggers and steps to avoid it. These are my references. This is my acknowledgement. On a note, I'd like to say, your study is not ours to recover, but tomorrow is ours to win or lose. Thank you.
So now session is open for question.
I am Dr. Ramanu Sharma from BGH Bokaro. Why you excluded the malnourished patient and immunodeficient patient, baby?
A very good morning, sir. Thank you for your question. Well, in malnourished children, the gut microbiota of the babies are already immunocompromised. So if we give them probiotics, it won't give us the necessary result that we expect from this study.
Okay.
Good morning, a nice presentation. I am Dr. Indranil Chaudhary from Bokaro General Hospital. Are you,
Sir,
have you started prescribing these probiotics to your...
Excuse me, sir, please be louder. You are not audible at all.
I am Dr. Indranil Chaudhary from Bokaro General Hospital. Have you started prescribing probiotics to your pediatric patients of atopic wheezing?
Thank you, sir, for your question. Yes, absolutely, we have started it. Actually, when we started prescribing this medication, it was for experimental basis, but now after seeing the results, we are doing it regularly.
So your this formulation is available in your formulary, in your over there in the pharmacy?
No, there is already a formulation in commercialization process, and it has a brand name, but I can't take the name here.
I get that, but I mean, it is available in your pharmacy over there.
No, sir, it's not. But almost all the patients, they have agreed to take that from on their own.
Okay, thank you.
Thank you, everyone, for your time and patience. Have a nice day.
I may now request Dr. Urvi Banerjee, Bokaro Steel Plant, to present her topic, Evaluation of Abnormal Uterine Bleeding in the Women of Reproductive Age Group.
Good morning, honorable judges, respected chairperson, esteemed seniors and my distinguished colleagues. Today, I, Dr. Urvi Banerjee from Bokaro General Hospital, am here to present on the evaluation of abnormal uterine bleeding in women of reproductive age group. Any uterine bleeding outside the normal value or duration or frequency is termed as abnormal uterine bleeding. It can be acute or chronic. It is a significant cause for almost 2/3 of all hysterectomies. In 2011, the International Federation of Gynecology and Obstetrics classified the structural and non-structural causes of abnormal uterine bleeding with the acronyms SPAM and COIN respectively. Our aim is to categorize the different causes of abnormal uterine bleeding in women of reproductive age group according to the FIGO-PALM-COIN classification and to find out its clinical relevance in day-to-day practice. And our objectives are to clinically evaluate the different causes of AUB with the help of transvaginal ultrasound, saline infusion sonography, hysteroscopy and histopathology, and to establish the prevalence of different causes of abnormal uterine bleeding. This study was conducted on all non-graded patients of reproductive age group, that is 15 to 49 years, attending the obstetrics and gynecology OPD of Bokaro General Hospital. This was a cross-sectional study over a period of 12 months from January 2024 to December 24. This was duly approved by the ethical committee of our hospital. The sample size was 138 and was calculated using the Cochrane sample size formulae. This study included women aged 15 to 49 years with the complaints of abnormal uterine bleeding, acute or chronic, that is menstrual cycle less than 24 days or more than 38 days, irregularity of menses, cycle to cycle variation of more than 20 days, duration of flow less than 4 days or more than 8 days. The signed informed consent to participate in the study was taken from each and every patient. Pregnancy and pregnancy-related factors were always ruled out first in the cases of abnormal uterine bleeding. Vaginal bleeding caused by vaginitis, cervical diseases were excluded from this study. This study adopted a questionnaire-based investigation method following the principle of informed consent. The basic information was collected from each and every patient, a detailed menstrual history, including the age of menarche, last menstrual period, length of cycle, amount of flow was taken, history of fever, fatigue, passage of fleshy mass, medical and surgical history was taken. Family history of bleeding disorders was essentially ruled out in all the cases. Urgent blood grouping and cross-matching was done in cases of severe anemia or if vitals were unstable. Relevant imaging and examination was done. All the routine investigations were sent. A formal standardized questionnaire method based on the PBAC was used for quantitative estimation of blood loss. Clinically, passage of clots of more than 1 inch diameter or changing pads in less than 3 hours is termed as heavy menstrual bleeding. The chronic AUB patients are asked to maintain a menstrual calendar using the pictorial blood assessment chart. In our study, we found that over 50% of the patients belong to the perimenopausal age group and almost 80% patients were from rural background. Around 40% patients had a parity of 2. Over 80% patients had a normal BMI. The chief complaint with which the patients presented was heavy menstrual bleeding, followed by irregular bleeding and frequent menstrual bleeding. Associated complaint was the abdominal pain, common associated complaint. Most patients had a normal frequency of menses and a regular cycle. Most patients had a normal duration of cycle with heavy menstrual bleeding. Most patients had no associated comorbidity associated with them. Transvaginal ultrasound is the first investigation and the investigation of choice done in patients of AUB. In our study, 39% patients were found to have leiomyoma. In our study, 21 patients underwent hysteroscopy, in which 11 were found to have fibroids and 7 had polyp. Saline infusion sonography was done for 10 patients and they were found to have polyp. In the histopathological examination sent for 116 patients, 27% were found to have leiomyoma and 26% had secretory endometrium. As we can see, patients of anemia presented with heavy menstrual bleeding. When we checked that most of the patients had underwent total abdominal hysterectomy and with bilateral salpingo oophorectomy. When classified as per the FIGO classification, most patients fell in the PALM category, that is 62%, and rest were in COIN category. When classified as the FIGO PALM COIN classification, we found that leiomyoma was the most common cause of abnormal uterine bleeding in women of reproductive age group. This was in coherence with the studies Sabre et al., Qureshi, Yusuf and Ratnani et al. Hence, I would like to conclude that the FIGO PALM COIN classification helps to ascertain the cause of abnormal uterine bleeding and thereby effectively adopt and plan for focused treatment of patients. The standardized terminology enhances communication among the healthcare providers for improving care and coordination of patients. I would also like to add that several women do not report AUB to their healthcare providers, so it is extremely important to foster an environment where we talk about menstruation openly. Patients of AUB should be educated on the pertinent lifestyle changes, treatment options, and when to seek emergency care. Thank you. These are my references. Thank you for your time and patience.
Thank you. Now session is open for the questions. Only 2 questions are allowed, and be specific in your question.
You said that most of your patients fell into leiomyoma group. So, for how much duration the medical treatment was given before getting them hysterectomized?
Thank you for your question. Depended upon the severity of their problem. It was extremely severe. We asked them to undergo the first the intrauterine device Mirena and then hysterectomy, and if it was less severe, we asked them to go under progesterone only pills and then Mirena and then hysterectomy.
So you are saying that for medical management of leiomyoma, you people use, in your hospital you use COCs?
Yes, ma'am. We
And
use
other than
progesterone
that-
only pills if the symptoms are not that severe and if the patient is not severely anemic.
No, I was asking about combined oral contraceptives. COCs, do you use COCs for medical management of leiomyoma patients?
Yes, ma'am. For medical management of leiomyoma patients.
And what was the average duration of treatment before this patients landed up into hysterectomy?
Ma'am, for 6 to 9 months, we try the patient to, we give the medical trial 6 to 9 months before they finally land up in hysterectomies or myomectomies.
Okay, thank you.
Dr. Vinita Singh here from here, this side, Tata Steel. You know, you mentioned total abdominal hysterectomy and bilateral salpingoophorectomy. Age group of patient was 15 to 49. Could you explain, you know, what proportion of patients ended up in that treatment?
Ma'am, 22% patients ended up in that treatment. And ma'am, mostly the patients whose family was complete ended up in total abdominal hysterectomy with bilateral salpingoophorectomy. And at times, intraoperatively, we saw that the ovaries were cystic and there were some pathologies in the ovaries. Then we did the bilateral salpingoophorectomy on the table.
Yeah, so I think bilateral salpingectomy would have been a better choice. And I hope you follow the guidelines of government where less than 40, it has to go through a approval group before. Did you follow that?
Yes, ma'am. Most of the patients who underwent this were in the perimenopausal age group.
Yeah.
That is 40 to 49 years. They only went for TH with BSO.
Okay, thank you.
Thank you for your time and patience. Have a good day.
Madam, may I ask one question? Hello? I said,
I may now request Dr. Rohit Roy Chaudhary, Durgapur Steel Plant, to present his topic, the role of intra-articular injection therapy in case of knee osteoarthritis.
So may I start? A very good morning to all honorable chairpersons, respected judges and respected delegates. The topic of discussion today is knee osteoarthritis and the role of intra-articular injection therapy in the management of knee osteoarthritis. Moving to what is knee osteoarthritis, it is generally a progressive chronic disease which severely affects the joint and patient's mobility. The etiology behind the disease can be attributed to aging, anatomical factors, obesity, and previous history of trauma. It is a progressive disease affecting the joint resulting in irregular joint space, periarticular fibrosis, osteophytic development, and calcified cartilages. The chief complaints that we encountered between OPD patients were pain and stiffness, especially morning stiffness, swelling and puffiness in the knee, a crackling or grinding sound when moving the knee, knees feeling. Physiology can be attributed to cartilage degradation, bone swelling, joint inflammation, ligament and menisci degeneration, and joint capsule hypertrophy, leading to immobility of the joint. The aim of this study is to compare the outcomes of articular injection steroids, hyaluronic acid versus saline placebo in patients with arthritis of the knee. This was a prospective single-blinded placebo-controlled trial study. In this study, we randomly assigned ratio 1:1:1 to steroids, 1.5% sodium hyaluronic and saline placebo. The study was conducted for 2 years between December 2021 to December 2023 at minor OT of orthopedic OPD of DSP main hospital. The patients who were included in the study were radiographically confirmed knee osteoarthritic patient according to Kellgren-Lawrence grade 1 to 3, knee pain or knee swelling persisting for at least 3 months, and informed consent to study trial. Patients excluded include individuals less than 18 years, end-stage osteoarthritis, that is Kellgren-Lawrence grade 4, any patient undergoing an anticoagulant therapy or had a previous history of coagulation disorder, any inflammatory diseases like rheumatoids, spondyloarthritis were discarded, immunosuppressive therapy or any patient having an immunocompromising diseases were excluded, or any previous history of allergic reaction to hyaluronic acid or steroids were excluded from the study. The radiographic pictorial depiction shows the Kellgren-Lawrence grades, the grade 1 having minute osteophytes, Grade 2 showing definite osteophytes with no diminution of joint space. Grade 3 showing adequate diminution of joint space, and grade 4 eventually moving to a severe disease. There is sclerosis of the subchondral bone. A proper ethical committee approval and informed consent was taken. In total, we assessed 150 patients for eligibility, among whom 33 patients were excluded for not meeting the inclusion criteria. 42 patients declined to participate. In total, we assessed 90 knees among 75 patients. 30 knees were placed in each group, and the results were assessed at the end of 3, 9, and 24 months with BMI assessment. These are the materials and methods that we followed along with the minor OT of our hospital. 1.5% sodium hyaluronate on the left side of the screen and 40 milligram of triamcinolone. Total 75 patients with painful knees were assessed. The mean age was found out to be 64 years. The mean BMI of the study population was 29.56, with 37% being severely overweight. Visual analog scale was used at 3, 9, and 24 months. The significant reduction of VAS score was found initially with the steroid group at 3 and 9 months, but eventually with sodium hyaluronate at the end of 24 months follow-up, the patient had a better compliance and prognosis. We did a statistical analysis wherein we found a p-value of 0.22537, which is statistically significant. The pain score on initial follow-up, where we found was moderate to severe pain, that was 7. In the steroid group, the VAS score reduced down to 2 at 3 months, 3 at 9 months, and 4 at 24 months. In the viscosupplementation with 1.5% sodium hyaluronate group, it moved down to 4 at 3, 3 at 9 months, and 2 at 24 months. In the placebo group, though initially a reduction of pain was found, but eventually at the end of 24 months, it moved up to the initial levels. The study concluded with showing that intra-articular therapy had a superior short to long-term effects. With the sodium hyaluronate group, we found out that there were more than 2 or more years of therapy, a therapeutic good outcome was found out, but for severe cases, that is grade 4, surgical therapy is the ultimate therapy of choice. There were certain drawbacks, like a few patients had aversion to steroid therapy. That's why we lost a lot of patients who refused to participate. The cost of therapy with viscosupplementation was quite high. New modalities of treatment like PRP therapy, that platelet-rich plasma and stem cell therapy could not be tested with our setup, and few patients wanted to move on to surgery that was beneficial in the long run. Certain recommendations are there for mild cases. We recommend knee bending exercises, IFT therapy, use of kneecap. Moderate cases, intra-articular therapy can be tried out with glucosamine and chondroitin sulfate tablets, ice compression, knee braces. For severe cases, we suggest surgery. The take-home message is that the majority of the world, either today or in the long run, is going to face osteoarthritis. There are ways to avoid it or delay it. That can be balanced diet, keep body weight in check, regular physical exercises. Intra-articular therapy can also be tried. These are my references. Thank you.
For completing before time. So now session is open for question.
I'm Dr. Abhijit Dham from Bokaro General Hospital. I am a bit concerned about the placebo group. You showed that they had a pain reduction also at 3 months. So first thing is, how do you account for that? But then their pain again went up at 6 months and so on and so forth. So based on these results, why did you choose to pursue with the placebo group when clearly there was no benefit?
So thank you for your question. Actually, sir, if we go into my study, the only thing is that we are not only giving intra-articular therapy. It was a multimodal approach wherein after therapy, we were sending the patients to physiotherapy along with the oral tablets. So in the long run, patients who were not willing to do anything just due to pain, they could be sent to physiotherapy after the injection. So it initially showed reduction in levels, but this is only applicable for mild to moderate cases 1 and 2. Actually, in grade unable to go to physiotherapy, adding to the pain. That's why in the placebo group, we had an initial reduction to the patient compliance, that they were willing to participate in exercises, physiotherapy, even willing to take the medications, which is not possible in the long run, sir.
No, but then don't you think that is, the placebo group, that means the reduction in pain which you showed at 3 months was not attributed to the saline injection?
No, sir, not at all, not at all, not at all, sir.
Are you sure of that?
Yes, sir.
Or maybe the saline itself could have reduced some additional It could have diluted the inflammatory mediators out there.
So,
or maybe the very act of injection could have, given some acupuncture sort of therapy out there.
so there was no conclusive evidence of that from my study.
But you didn't look into it very specifically.
No, sir, not in.
Excuse me, sir, we can discuss during the lunch hour. Only questions are to be asked and the answers are to be given. No discussion, please.
Hello.
In steroid injectable group, what was the longest duration of pain-free period that the patient had?
Yes, ma'am. Thank you for your question. Ma'am, it was around 3 months. To be, now that the study has concluded, ma'am, after December 2023, there has been 1.5 years that has passed. So from our study group, initially we had 150 patients, but in the last 1 year, we have given more than 3,000 injections. And max majority of those are viscous supplementation group, but for the steroid therapy, we found an initial pain-free interval level of around 3 months. And as suggested by my consultants, we can push in steroids, as is written in literature also, that 3 to 4 times in a year it can be given. And patients are showing good compliance to it, sir. But madam, there are certain drawbacks to it also. Steroid therapy leads to the degradation of the cartilage around the joint also.
So those mild cases, grade 1 and grade 2, even those cases you were injecting steroid?
Yes, ma'am. Because we did a randomized trial, ma'am. We couldn't, after
So since it was having that kind of side effect, these side effects were seen after how much of injections and all?
Ma'am, to correlate, to see the side effects, we have to get in an MRI done so as to see the cartilage degradation or the amount of it happening. But it was not possible in our study or in our setup. So this is a base for a new study, ma'am.
Okay, thank you.
Thank you.
So we have covered all papers.
Thank you, ma'am. This brings to the end of our MBBS paper session. And with this, I may now request our judge, Dr. Sanghamitra Satpathy ma'am, to please come on the dais. I may now request Dr. Sushant Sinha sir, CMO in charge, ISCO, to present a token of gratitude to Sanghamitra Satpathy ma'am. I may now request Dr. Sabyasachi Patnaik sir to please come on the desk. Madam. Now request Pushpa Kumari, additional RSP, to present a token of appreciation to Dr. Sabyasachi Patnaik sir. I may now request Dr. Sanghamitra ma'am to please come on the dais for the photograph. I may now request Dr. Pushpa Kumari ma'am to present a token of appreciation to Dr. Sushant Sinha sir, CMO in charge, ISCO Banpur. Thank you, ma'am. I may now request Dr. Sushant Sinha sir to kindly present a token of appreciation to Dr. Pushpa Kumari ma'am. Thank you, sir and ma'am. Thank you everyone for this MBBS paper session. And with this, we come to our second session for this noon, that is Pro-Con Debate 2. I would like to request Dr. Snehal to take over the session.
A very good morning and welcome to all. Now we have this debate session. We have two eminent chairpersons for this, Dr. Vinita Singh, GM Medical Services, Tata Steel, and Dr. Pratibha Sarangi, Additional CMO, RSP Rourkela. Now I invite Dr. Vinita Singh and Dr. Pratibha Sarangi to the dais.
This pen drive, does it belongs to anybody? This was found over there, this pen drive.
Thank you, ma'am. We have interesting topic for debate, that is gut is the new brain, in which Dr. Jayant Kumar Acharya, CMO in charge Rourkela Steel Plant, is for the debate. Dr. Vibhuti Bhushan Karunamai, CMO in charge Bhilai Steel Plant, is against the topic. The time duration for topic is 15 minutes, out of which 4 minutes is for the topic, 4 minutes against the topic, 2 minutes rebuttal for the topic, 2 minutes rebuttal against the topic, and 1 minute verdicts. So let's start the debate, that is gut is the new brain.
I just want to check, you have a timer or we have, here, chairperson. What is our role? We have to look at the time or control the times?
We do have a timer, madam. It will be displayed here.
Yeah, so we stop.
And when the same timer rules follow, madam, buzzer will be before 1 minute of the presentation.
Yeah.
It is 4 minutes initial presentation from both the presenters, followed by 2 minutes for rebuttal, and followed by 2 minutes for...
So I've heard that. So just because debate has to be some fun activity and not too serious, so can we have a vote to see who is pro in the audience? If you can raise your hand to say you support the motion. And then we can see if the speaker can change your thought. Gut is the new brain. What's the topic? No opinions. Gut is the new brain is supporting, look at the numbers. Right. So Dr. Acharya, anyway, he supports that, whether the opponent. Thank you.
Good afternoon, chairpersons and my dear friends. We don't need a degree in neuroscience to suspect that the gut and the brain are continuously communicating with each other. A simple example, I can say that I had a feeling of butterflies moving in my stomach just before I came here for my presentation. So similar experiences all must be having. So today we'll be discussing some of the reasons of this phenomena. So this gut is a bidirectional communication between the neural network of the brain and the gut and the cells which are gut microbiota. What is the gut microbiota? It is a basket of all the organisms which are present in the GI tract, starting from bacteria to virus to fungus, etc., which remain in sync with the host cells. And it is very interesting to know that we have 10 to the power 14 bacteria in the gut, which is more than the total number of cells in the body. And the gut microbiota has 3.3 million genes, but our body is only 23,000 genes. So 10% of our DNA is human and 90% of our DNA is bacterial. Hence it is not wrong if we say we are 10% human. But the good news is that we live in complete harmony with these bacteria. But there are certain factors which can affect this harmony, like the diet, genetics, the antibiotics, environment, exercise, lifestyle, stress, etc. Now what this stress does? See, there is a cortisol, increased cortisol level. Normally we are not in direct contact with these gut microbiomes, But during stress, there is increased cortisol production, and this disturbs the barrier. There are two barriers which protects us. One is a mucosal layer over the intestinal epithelium, and the second is the tight junctions between these epithelial cells. So the cortisol disturbs this barrier, and these microbiomes come in direct contact with the immune cells of the body and set in a inflammatory cascade, leading to a pro-inflammatory state in the gut and the brain. Next is the diet. I am not against any particular diet, but it has been reported that once you start a Mediterranean diet, that is a plant-based diet with high fibers and fruits, nuts, vegetables, the gut microbes change in your favor in 2 weeks, which revert back to the previous state once you restart the non-vegetarian diet. And this is the multimodal image, how you can see in the last slide, you can see how the gut changes the epithelial damage. It does apoptosis of the epithelial cells, and there is epithelial gaps. So next is the antibiotics. Multiple evidences have confirmed that this virus is caused by chronic antibiotic use like beta-lactams, macrolides, etc. But the most important thing is that the damage they do may persist for 2 years even after the antibiotics are stopped, and they mainly affect the diversity of the gut microbiota. Other effects are sugar, alcohol, antacids, pesticides, smoking, sedentary lifestyle, etc. One thing I would like to say, metformin, opiates, they have some beneficial effect on these gut microorganisms. So how does the gut feel when these stresses are produced in the environment of the gut? They change, they lead a leaky gut, there is an immune activation leading to inflammatory cytokine production, cross the blood-brain barrier, alteration in the neurotransmitter levels, and thus mood, etc. So this is in fact reflected in the pathogenesis of the various diseases like obesity, IBD, autism, depression, Parkinsonism, Alzheimer's. Name any organism, name any system, this affects. So what should be done? So the most easiest thing is to protect ourselves from this dysbiosis, and the most easiest thing is the Mediterranean diet with high fiber vegetarian diet with lot of fruits, nuts, green peas, etc. We should be away from red meat, and it has been documented that such type of diet, it decreases the risk of Alzheimer's. So the other advantages are you should take a lot of fermented food, you should stay away from artificial sweeteners, you should take probiotics, etc. So high fiber, polyunsaturated fatty acids, etc. should be there in your diet. We should have good sleep, good exercise. So in conclusion, there is a complex bidirectional interaction between gut and the gut microbes, the disturbance of which can lead to various diseases. So if we adopt a good lifestyle, do regular exercise, eat a healthy diet, we can protect microbes and dominate over our genetic predisposition to diseases and thus stay out of the risk zone. Thank you.
Now I request Dr. Vibhuti Bhushan Karunamai to the dais.
Good morning, respected judges, the dignitaries, all my friends. My colleague very nicely given the role of diet and microbes to our health. But the topic is gut is the brain, new brain. My job is to debunk the misconception about the gut. And as all you know, the gut is gut. It acts for our absorption, digestion, the elimination, but brain as a whole, it is the body's control room. But the two organs of the gut and brain are very well communicated, and through the metabolism, neurotransmitters and the hormones as a very perfection way. But is the brain? Really, it's a misleading and oversimplified interpretation. Is brain replaceable? Can we replace our brain? Can we replace our brain like this for me? Solution for any complex situations. If our gut is strong, then all of, I think we know it causes a dissolution. Then, as having a so much neurological system of its own inherent impulse, generation and progression. Likewise, when heart and brain fights, the liver always suffers. Interaction with the central nervous system. Likewise, my colleague said about the microbes. So, effectively contributing overall, can say liver is a brain. Restrains our eyes, talks about a great deal. So, is it our eyes a brain? Kidneys, the great endocrine system, excretory waste greatly impact the brain. So the big concern is every organ is brain. No, it cannot be like that. Women rule animals. A microbiome system having a 70% around immune system. The pig, the gut is similar to human. No, the brain is required to rule the world. So the misrepresentation of science is, the research shows, guts has an impact on health, but does not equate to its brain. Can we imagine the handling the brain similar to a gut? Can we resect like hemicolectomy, the total colectomy, the sleeve reduction? The answer is a big no. Why? Because the phrase, the gut is new brain, suggests that the gut can perform functions similar to the brain. It is due to popular research, the gut-brain axis and the enteric nervous system is a misleading and oversimplified. Friends, the brain is unique. It processes information, stores memory, enables our consciousness. The gut lacks the capability of higher order thinking and emotional reasoning. So brain is brain and gut is gut. So to conclude, the gut supports the brain but cannot replace its function. Misleading metaphors risk oversimplifying of our research and complex health system. Acknowledge the gut's importance and the while respecting the brain's unique role. Friends, your brain is the best weapon you have. So use your brain or else you will lose your brain. Thank you.
Dr. Acharya, if you want to counter him.
You said correct, sir. Nowadays, the research has proven that the answer to whether gut is a new brain or not is oversimplified, but not misleading. The Harvard School says that the gut, although can't compose poetry, but it has several reasons why it should be nicknamed as a new brain. Because there are 3-4 reasons. It can operate independently of the brain and spinal cord. Even it has been shown, if we cut the vagus nerve, the gut keeps on operating. It has efferent, and interneurons, so it can carry out reflexes, hence act as an integrity center in the absence of CNS input. It has sensory inputs, motor inputs, mechanical and chemical inputs. It has over more than 30 neurotransmitters which it can secrete, identical to the central nervous system like acetylcholine, dopamine, serotonin. And it contains support cells like the astroglia in the brain and a diffusion barrier system like a blood-brain barrier. So these are the some reasons why gut has been nicknamed as a second brain. Now, if you say there are various organisms are affected, but the master stroke is there in the microbes. What you feed the microbes, they will help you to keep out of the risk zone for those diseases which you are already genetically predisposed. Thank you.
Thank you. If you could, yeah.
respected chairpersons and my friends, what I got from the talk that there is axis, gut-brain axis. But I think you might be knowing there are so many axes in our body, external, internal, gut, brain. Just in the morning, we heard about the gut, lung, the other axes. So if we combine even all the axes, we cannot form a new brain. So never be any organ be a brain. The highlighting of the microbes, the microbiota we have, of course, the microbiota has an impact in overall health, but brain is a composed of highly specialized neurological tissues and the supporting tissues. The bacteria, whether it is micro and macro, cannot form a new brain. Dysbiosis again, it affects from the skin to bone and all organs. So not only the implicated to the brain. What my friends told about the feelings, the butterfly feelings, the gut feeling only is influenced to the brain. It gives an important input, but gut cannot be a brain to analyze and assess it. Mental disorder, whether it is mood or anxiety, of course, but solely cannot be treated with the gut intervention. So gut supports the brain through its metabolic, neuroendocrine, and the immune mechanism for a healthy functioning of our body, but gut is gut and brain is brain. Thank you.
Hello. Both the speakers have done their job properly. It is always easy to tell anything for, and always very difficult to argue for in a contrast position. But both of them has done their job. I think both of them done their job very nicely. Thank you both.
Yeah, thank you. I'll just, we had a vote for the motion prior to the debate. So just want to see the count post-debate for the motion, that is gut is the new brain. Who supports that? Right. Happy time for you. Oh, yes. Yes. So congratulations. Thank you. Very exciting. Okay, it's open to questions as well. So anybody has any question, you can ask.
Good morning, all of you. I'm Dr. Sujata from RANL Visakhapatnam. Sir, you said metformin and opioids are beneficial to gut. In what way? That is my question.
Yes. I expected somebody to ask this question. I was also very much surprised when I reviewed the literature. In fact, there is a debate going on this, but by 2-3 mechanisms, postulations have been made. One is they help to increase the diversity of the gut microbes. So the more diverse the gut microbiota, the better protection it gives. That is number one. Second, it also, these gut microbes, they also act on L cells of the intestine, and with metformin, this GLP production, through GLP production, they help in glucose homeostasis. So metformin helps this mechanism. That is second. And third is, it is supposed to decrease the, it improves the serotonin level, which improves the barrier, intestinal barrier, by which it is postulated that it helps to improve the gut microbiome and thus helps in better glucose homeostasis.
And what about opioids, sir? Opioid.
Similar mechanisms. Similar mechanism.
But the side effect of metformin is diarrhea.
Yeah, I know that.
Yes.
I know that side effect is diarrhea, but still it has got it helps the gut microbes.
Yes. Thank you.
So we conclude with this. Thank you.
Thank you, Dr. Jayan Kumar Acharya sir and Dr. Vibhuti Bhushan Karunamai sir. Let's start with second debate session. The topic of this session is good clinician can also be a good researcher in PSU, in which Dr. Vinita Dwivedi, CMO Bhilai Steel Plant is for the topic, and Dr. Raj Ranjan Kumar, CMO in charge DSP Durgapur Steel Plant is against the topic. I invite Dr. Vinita Dwivedi, CMO Bhilai Steel Plant, to have a talk.
So while you get ready, if you can have a vote on good clinician can also be a good researcher for the motion. Majority. Right. So you have the major vote. Let's see again.
Can we have the presentation now? Presentation. Can I see the next slide in it? Somewhere you have a... Okay, AISMOC. Present. Yes. Good morning, everyone. Respected ED Medical and Health Services, Bhilai Steel Plant, Dr. Ravindra, CMOs of all steel plants, Dr. Karunamai, Dr. Jayant Acharya, and others, CMOs of other steel plants. I welcome you all on this occasion of the debate whether the good clinicians can also be good researchers in public sector units. How to go? Research is to see what everybody else has seen and to think what nobody else has thought, by Albert Sens Gorgui. Now I'd like to go back to the history of Indian history and world history too, that how good clinicians were good researchers during those times also. Two Sanskrit medical texts which some people in Ayurveda and other medical practices are still following in Indian history, medical dating early centuries of Christian era, Charak Samhita and Shrusu Samhita, and Vagbhatta's Ashtankara dated 7th century CE, also have texts related to the clinicians doing research and in the benefit of the patient. Now coming to the world history, we have many clinicians like James Lind who considered the first to conduct a controlled clinical trial studying scurvy on sailors, as we all know, due to vitamin C deficiency. Sir Robin Ross, who discovered the vector Anopheles mosquito in malaria disease, which has helped us to eradicate some of the malaria from many places in modern epidemiology. Sir Royal Calne, first liver transplant in Europe and first intestinal transplant in England in as late as 1990s. In 1994, he successfully combined the liver, stomach, kidney and pancreas transplant, introduced cyclosporin and immunosuppressant in clinical care, replacing the often fatal whole body radiation. First double-blind comparative trial, the Medical Research Council UK carried out a trial in 1943 and 44 to investigate patulin treatment for an extract of penicillin patulinum, the common cold. 1946, the first randomized curative trial of streptomycin, Sir Geoffrey Marshall, and he used a statistician also, Sir Rod Orson Bradford Hill and Philip Hart. These are successful clinical researchers. Now I'll present some case studies. In 1929, Wessner Forsman, 25-year-old intern, whom I am still very thankful for successfully passing a urethral tube through a large antecubital vein into the right atrium and confirmed this historical success with a chest X-ray, began the era of intravascular catheterization, a procedure now taken so much for granted. In 1959, Victor Herbert was a 32-year-old hematologist who discovered that dietary deficiency alone can result in severe anemia and megaloblastic anemia, confirming cause and effect. Barry J. Marshall and Robin Warren of Perth, Western Australia, discovered Helicobacter pylori in the stomach of patients with gastritis and stomach ulcers, as we all know. Warren and Marshall were also awarded the Nobel Prize in the medicine in 2005, just 20 years back, for their work on H. pylori. Santo Shinshui, father of 6-year-old daughter, he saw a small growth in her teeth, and he developed the theory of stem cells from human exfoliated deciduous teeth. Thankful to him. So now the clinical as researchers in our units, that is public sector units. They are good researchers because they have an access to diverse patient population. They serve diverse patients from various backgrounds, conduct research addressing specific health needs. Public sector settings often care for underrepresented populations, providing insights into neglected healthcare areas. They focus on health equity and public health. They're motivated by the needs to improve health outcome for entire communities rather than individual patients. Better poised to address systemic issues like access to care, preventive measures, and health disparities. They have a good collaboration between various disciplines. As we all know, we all actually go by the teamwork. The public sector clinicians often work in multidisciplinary teams, epidemiologists, public health officials, researchers, and policymakers, along with a wide range of medical disciplines. This fosters a collaborative environment, the exchange of knowledge and ideas, making it easier for clinicians to engage in research projects that span various domains of healthcare. Such collaborations are crucial for tackling complex health challenges like infectious disease outbreaks, chronic disease management, social determinants of health. They are in alignment of policy and community needs, direct understanding of the needs and priorities of the communities. This knowledge makes them well positioned into design research, which are scientifically sound, aligned with public health policies, the need of the population. Their involvement in research ensures studies are relevant, directly from health policies, interventions, and resource allocation. Now, research in the real-world settings. Clinicians in the public sector conduct research in real-world settings where external factors like poverty, limited access to care, coexisting health conditions can influence patient outcomes. This experience allows for research that better reflects the challenges of actual clinical practice and can lead to more pragmatic, scalable, and effective interventions for the public.
They have low barriers to recruitment and data collection. Clinicians in the public sector have easy access to patient populations within their care settings, including hospitals, clinics, and community health centers. The public sector often has established patient registries, economic health, electronic health records, and ongoing public health initiatives that can be leveraged for research purposes, reducing the time and cost involved in patient recruitment and data collection. Many clinicians in the public sector are directly involved in the implementation of health policies and government initiatives. This experience provides them with valuable insights into how healthcare system works, how policies are developed and enacted, how research can influence public health decisions. Clinicians are therefore in a strong position to conduct research that can be translated into policy recommendations or interventions that have a broad public impact. They have a longitudinal data access. Clinicians in public health hospitals or clinics often care for patients over long periods, offering opportunities for longitudinal studies examining the long-term effects of disease treatment and interventions. This is particularly useful for chronic diseases, infectious diseases, or public health interventions, providing rich data for evidence-based research. Public trust in research. Public sector clinicians often enjoy a high level of trust from the communities they serve, which can make it easier to engage patients in research. This trust can often help to overcome barriers to participation in clinical studies, particularly in marginalized and underserved population. Clinicians' familiarity with patients' cultural, social, and economic backgrounds allows them to design studies that are sensitive to these factors.
Madam, please, time is over.
Areas. Okay. So now they focus on preventive health also, their ability to influence large-scale health interventions, and to conclude, clinicians being valuable first-hand knowledge of the healthcare system, the communities they serve, the practical challenges faced in patient care. Their unique position allows them to conduct research that is directly relevant to public health needs, accessible to the wide range patient population, and focused on improved healthcare delivery. This makes them highly effective researchers, capable of bridging the gap between clinical practice, policy, and the overall public health strategy. Innovation is the key to the future, but basic research is the key to future innovation. Jerome Isaac Friedman said. Thank you.
I request Dr. Raj Ranjan Kumar, CMO in charge DSP, Raur, to have a talk.
Good morning to all, respected HOMs, chairpersons, and colleagues. I will speak in the against of the motion. Clinician has to face overwhelming workload due to high patient-doctor ratio, and he has to see hundreds of patients daily, leaving little time for the research activities. Demand of patient care can overshadow any efforts to engage in meaningful research. Research is an intensive process requiring careful planning, data collection and analysis. For the clinician in the PSU, finding the dedicated time for the research activities is a significant challenge. Balancing the clinical responsibilities with the research can lead to compromise in both areas, potentially affecting the patient care and quality of the research output. Lack of the training. Most of the clinicians trained in the medical practice only, with a limited exposure to research methodology, data collection, analysis, and scientific writing during their education. Clinicians can excel in diagnosing and treating the patient only. Conducting rigorous research requires specialized skills that is not part of his training. Additional qualifications like master's degree and PhD are in the research field to pursue the research work. Time and resource are required for such qualifications, which may not be feasible in the clinical setting of high demanding environment of the PSU. Thus, this lack of the formal training can limit the ability to conduct the high quality research. Many PSU are facing the problem of significant infrastructure and resource constraints. Research requires access to advanced laboratories, high quality diagnostic tools, and skilled technical staffs, which may not be readily available in the public sector healthcare system. Furthermore, the bureaucratic hurdles, delay in obtaining funds, and ethical approvals further discourage the clinician to engage in research. Without adequate infrastructure and streamlined process and administrative support, conducting the research becomes a daunting task for the motivated clinicians. Balancing the dual roles of the clinician and the research can lead to conflict of interest. For example, the pressure to publish the research may tempt clinician to prioritize research work over the patient care. And on the other hand, immediate demand of patient care might take precedence, causing delay and compromise in research activities. Risks of burnout. Dual demand of clinical practice and research can affect clinicians' physical and mental health. Clinicians in PS are already facing long working hours, higher patient loads, and administrative responsibilities. Adding research to this mix increases the risk of professional burnout, which negatively impact both the performance and well-being of the physician. Burnout not only affects the individual clinicians but also have bad and broader implications on whole healthcare system. Overworked and fatigued clinicians are more prone to errors and compromising the patient safety. So expecting the clinician to excel in both the roles may lead to adverse outcome. Thank you.
Do we have time for the 2-minute session? Yes, okay. Do you want to counter him? Madam Vinita Dwivedi, do you want to counter him?
I think as clinicians in public sectors, we have had Diplomate National Board students coming to study in our institute, which is equivalent to MD or MS degree, and for which we are doing research work like thesis, and many papers are still published from our institutes. So I think that research is an ongoing process. We can't let go of that and become good clinicians. And how can we update ourselves if we do not have research going on in our hospital? So I think that is one argument which I can't accept, that we do not have time to go into clinical research. We definitely can take out time and not ignoring our patients and still do clinical research, as the number of theses that come out and so many students working in our hospitals who have done their thesis and presented papers in various national and international conferences. So this argument, I do not think that stands true. And regarding the resources and how to get instruments, I think we are quite sufficiently compared to the government hospitals. I think we are quite well equipped to conduct researches in our various departments and hospitals. Thank you.
Dr. Kumar, you.
Clinician has become a good researcher. It is very complex and the controversial issues. For the research, we should have dedicated, robust institutional supports, which are not getting, and we have to obtain the streamlined processes, which are not possible in our demanding environment of the public sector. Also, clinicians in the public sector has to do additional responsibilities, which will hamper the research works. We also deprived of the adequate funding there. And there are some hurdles also. We have no advanced labs there to undergo the research. And we have also no additional qualification like PhD or master degree in the research. So we cannot do the research work properly. We need advanced labs, high diagnostic tools, and the skilled technical staffs for the research work. In the demanding environment of the PSU, we deprive of it. Thank you.
Hello, any questions from audience?
I strongly feel that it is a very cynical view to say that a good clinician cannot be a good researcher. I'm saying in a negative sense. A good clinician cannot be a good researcher is a very cynical view. Sometimes born out of envy that one clinician, my colleague clinician is having lot of papers and I am unable to produce one paper. Therefore, you pass on the blame to saying that he is not a good clinician. So this is the argument that I have to say for the motion, that a good clinician is also a good researcher.
Hello. Good morning. Myself, Dr. R.K. Gautam from Bokaro General Hospital. My question is from Dr. Vinita Dwivedi, madam. Ma'am, this is the era of evidence-based medicine. And most of the research work coming from the Western country, that is in our country also, that is in the hand of big pharmaceutical companies. So what challenges, especially in developing countries, you face? This is my question.
I did not get your question fully. Like in developing country like ours?
Yeah. We are living in the era of this evidence-based medicine. And most of the...
I think the collection of data is not a problem in our country. We have such a diverse population and we cater to such a population and such a big, we have a data bank in terms of patients that there is no dearth of research work in our country if we are totally dedicated to it also. So that question doesn't arise that how we do not have those kind of modules to do research in our country. I think we are well equipped to do any kind. I mean, a person can do a research as simple as a drug of deficiency like vitamin C deficiency and can do on sailors. Any kind of research can be helpful to the patient. So that question doesn't arise that we do not have equipments, we do not have patients, we cater to a big number of population where we can do research.
Research on a bigger scale, that is in hand of
Thank you, madam and sirs, for their elaborate talk. This debate will be going on and going on. If we do not conclude, then this debate will continue for day long. Thank you, madam and sir.
Thank you. Thank you, Dr. Vinita Dwivedi, CMO Bhilai Steel Plant, and Dr. Raj Ranjan Kumar, CMO in charge, Durgapur Steel Plant. I now request debatement participants, Dr. Jayant Kumar Acharya and Dr. Vibhuti Bhushan Karuname to grace the dais. I now request Dr. Vinita Singh, GM Medical Services, Tata Steel, to kindly present a token of appreciation to Dr. Jayant Kumar Acharya and Dr. Vibhuti Bhushan Karunamai. Now I request debate two participants, Dr. Vinita Dwivedi and Dr. Raj Ranjan Kumar, to grace the dais. I now request Dr. Pratibha Sarangi, Additional CMO RSP Rourkela, to present the token of appreciation to Dr. Vinita Dwivedi and Dr. Raj Ranjan Kumar. Thank you, ma'am. I now request Dr. Pratibha Sarangi, Additional CMO RSP, to present token of appreciation to Dr. Vinita Singh, GM Medical Services, Tata Steel. I may now request Dr. Vinita Singh, GM Medical Services, Tata Steel, to kindly present a token of appreciation to Dr. Pratibha Sarangi, Additional CMO RSP Rourkela. Thank you, ma'am. Thank you everyone for this session.
Now comes the time for the chai break. We'll reconvene after 15 minutes. So surely have a grab of chai, recharge for the next session.
Hi, my name is Dr. Arvind Chabda. I am 28 years old.
Our next session will be the guest lecture 1 after the tea break. So all the chairpersons and speakers be ready after 15 minutes for the guest lecture 1.
Rashiri Medical Research Institute.
That is the adult vaccination.
I grew up as an animal. My symptoms started in class 8 or 9. I was getting heat and cold intolerance. My joints also started paining so much, so I couldn't go out to play with my friends. Then I just went for a general body checkup and I was diagnosed with proteinuria in my urine. After that I went to a nephrologist for my kidney checkup and he prescribed me some medication which was not suitable during that time, so eventually treatment relapsed. When I was in my medical school, my brother was diagnosed with CKD, that is called chronic kidney disease, and then his doctor recommended our whole family to go for kidney testing. And after that we went for genetic testing also, in which we come to know that we are suffering from a rare genetic disorder that is called Fabry's disease. Even after getting diagnosed with Fabry's, I was trying to live as healthy as possible, but my symptoms kept getting worse. I was having extreme joint pains. I couldn't focus neither on my studies nor on myself. Because of the disease taking toll on me, I fainted many times out of nowhere. It was extremely a painful condition for me and my family. The hospital in Gurgaon where my disease was diagnosed started my treatment. In 2018, therapy started and it showed some positive results. The initial days of the therapy was good and my symptoms kept decreasing. Because of the therapy, I was feeling a lot better and healthier. I wish my diagnosis could
I request all the delegates to make it a bit fast because we will be starting our guest lecture 1. I request everyone to please come in. We'll be starting our guest lecture 1. Please carry your tea along with yourself.
My name is आकाश प्रसाद. My date of birth 20 December 2002. मैं अपने मम्मी पापा के साथ रहता हूँ. साथ में मेरा पूरा ज्वाइंट फैमिली है. मैं अभी B.Ed LB कर रहा हूँ, सेमेस्टर 3rd में हूँ. मेरा कॉलेज वही 45 किलोमीटर के दूरी पर है. मैं वही हॉस्टल पर रहकर पढ़ाई करता हूँ. जब मैं 1.5 साल था उस समय मेरा ऑपरेशन हुआ था हार्निया अपेंडिक्स का.
एक दिन इसके पेट में काफी दर्द हुआ तो रात भर ये उस पेन को बर्दाश्त किया. उसके बाद सुबह में इसके पापा और इसके दादाजी इसको लेकर हॉस्पिटल गए. तो वहाँ जब टेस्ट वगैरह हुआ देखा गया तो वहाँ पे पता चला कि इसको हार्निया है और अर्जेंटली ऐसा कंडीशन हो गया कि एट ए टाइम उसका ऑपरेशन करना पड़ा. उसके बाद हम लोग अपनी कंपनी के हॉस्पिटल में इसको दिखवाएं तो वहाँ पे मैडम डिसीजन ली कि इसको गलौर में लेकर के डायग्नोसिस किया जाए और लास्ट कंडीशन में जब डायग्नोसिस इसका कंप्लीट हुआ तब पता चला कि इसको MPS 1 है.
मुझे MPS 1 है. मेरा ये डिजीज सबसे पहले गलौर में देखा गया था 2009 में. हाथ में स्टिफनेस आया, बॉडी पेन हुआ, ज्वाइंट पेन होता था. मतलब हाइट ग्रोथ नहीं किया. नॉर्मल जैसे होता था सबका ग्रोथ कर रहा है, मतलब मेरा नहीं हो रहा था उस समय. तो धीरे धीरे हमने फिर ट्रीटमेंट अपना स्टार्ट किया.
अभी जब से दवा मिला है तब से मैं समझ रहा हूँ कि मेरा बच्चा बहुत स्वस्थ है. पहले ट्यूशन भी ले जाना है, कुछ भी करना है तो हमको करना पड़ता था. अब जो है ये अपने खुद को करता है. अब जो है सो जिम भी जाता है, फुटबॉल भी खेलता है, क्रिकेट भी खेलता है. तो अब हमको थोड़ा खुशी महसूस होता है. अब हम इसको देख करके मुझे गर्व महसूस होता है. अभी लॉ का तैयारी कर रहा है. अब हम लोग का टारगेट यही है कब इसको दवा भी चलते रहे और इसके बाद इसका लॉ भी कंप्लीट करे और दिल्ली हाई कोर्ट से इसका प्रैक्टिस करवाए.
उस समय फिर पता चला कि MPS 1 का प्रॉब्लम है. तब मुझे 2015 से ये मेडिसिन लगना स्टार्ट हुआ. तब से मैं नॉर्मल लाइफ पे जैसे जी रहा हूँ और हर तरह का काम कर रहा हूँ. मैं जिम जाता हूँ, बाइक वगैरह चलाता हूँ, हर तरफ से खेलना कूदना. एक नॉर्मल बच्चा जैसे जो करता है, जो नॉर्मल आदमी जो करता है, मैं आज के डेट में कर रहा हूँ. और मैं पढ़ाई लिखाई के साथ कर रहा हूँ, बहुत अच्छे से कर रहा हूँ.
Gaucher is a rare genetic disorder that causes enlargement of the liver or spleen, bone abnormalities and blood disorders.
My name is Vanita Huluraya. We are from Bangalore.
Please, I request everyone to come on to
My
the hall.
son Prajwal is 13 years old. He has Gaucher disease. When my child was 5 months, baby only, he got loose stools and fever. And once we got to hospital, the doctor told the spleen has enlarged. You have to admit the child. His stomach was too large.
I welcome everyone after a mini relaxation with a cup of chai. Now we'll have a first guest lecture session. The guest lecture session has a total time duration of 30 minutes. There are 25 minutes for the presentation, out of which after 20 minutes the first buzzer, then again after 5 minutes second buzzer to mark the end of the presentation. 5 minutes for the interactive session. I may now request Dr. Archana Behra, Additional CMO, RSP Rourkela, and Dr. Sushil Kumar, Deputy CMO, RSP Rourkela, to kindly chair the session and to kindly grace the dais. I may now request our speaker, Dr. Professor Sunil Kumar Agarwala, sir, Pediatrics, to please come up onto the stage. And Dr. Archana ma'am to please introduce sir.
Hello. Good afternoon to all. Respected seniors and my dear friends and all the delegates. It is my proud privilege to introduce Professor Sunil Kumar Agarwal, who is a pediatrician. Now he will deliver the guest lecture on adult vaccination. He is a dynamic person. Being a pediatrician, he has gained numerous accolades, including the prestigious award like Chikitsak Ratan Award in 2006 and the Pioneer Award in 2009 for his exceptional contributions to medicines. And his expertise extends to pediatric neurology, vaccinology, infectious diseases, and HIV areas, where his person truly shines. As a prolific scholar, he has enriched medical literature with over 50 publications in esteemed Indian journals and more than 35 in renowned international journals. So let's welcome to Dr. Sunil Agarwal. Please start your session.
So thank you very much, Dr. Archana ma'am and co-chairperson. Good morning all. I am a pediatrician. I have seen all steel doctors of India. But I'll tell you, I am silver doctor from Cuttack, because Cuttack is famous for silver filigree work. So a session from silver doctor to all gathering of steel doctors of India. That is the first line. Second, I must acknowledge that a public sector conference to this magnitude can happen, and where the host being RSL, I mean Rourkela Steel Plant, a big round of applause for the organizers, and they have done the wonderful job. With this note, I will say always that life is such a journey. Many times we know that we are busy in our clinics. All patients come and they usually go, but there is a small time is kept for ourselves. Suppose somebody will tell, why you became a doctor? I must tell, it is because of not my passion, it is my parents' passion, that they wanted that to all of us to be a doctor. But always the doctors are neglecting themselves. It has been seen, acute AMI, depression, and there was a paper 2 days back in Times of India that in undergraduate, near about 25%, in postgraduate 50%, they are having mental illness. There is a pressure. You must be knowing that in Kota Institute, whether they produce so many doctors, so many engineers, and every month there is a case of suicide. So this degree of mental illness is available in our brain of our doctors. How to curtail that? The main way is that attend conferences, get away from your day-to-day job, meet your friends, and enjoy 2 or 3 days whatever you are getting from your day-to-day practice. So that is the only way. So now I will tell why I have given this topic. Being a pediatrician, we must know we are preventive. Like I will say, breastfeeding, complementary feeding, all those things can decline under 5 mortality. And similarly, the vaccination, the immunization is the best gift to a child. Being Agarwal, I will say, on Ekusia Dina, on a 21st day, there is a mega ceremony in Cuttack. they spend lakhs and lakhs as per their economical standard. But on 30th day, the baby will come with a lethargy, not feeding well. So that means sepsis, and I have to admit the baby, and finally there is a difficulty between all of us and the immune system of the baby, whether the baby is going to survive or not. So this is the challenge. So that's why let's put our hand together that no one should die as of now on this planet because of vaccine preventable disease. Now everybody knows that vaccine means it is kids, but I will tell you no. Vaccine can be given to a 99-year-old as well. So that means vaccine is a life cycle approach. Starting from the neonate till any age, vaccine is not a bar. Everybody knows at birth we are giving BCG, oral polio and hepatitis B. They are known as birth dose vaccine. Now I will tell you what are the vaccine they are needed for the adults and why adults we all need vaccine. Here a couple of faculties are there, delegates from cell are available here. Either you need or your adolescent boy or a girl of your son or daughter, they may need this vaccination. So always we remember in India to go for vaccination, we need two immunization guidelines. One is Government of India guideline, that is NIP, National Immunization Schedule, and it is being updated every year. Just like we are changing our SAT every day, the guideline changes every year. Whatever the guideline last year, that may not be true for this year. Second, we are following IAP guideline. What is IAP? Indian Academy of Pediatrics guideline. And this is again a recent guideline. So that means everyone should know, even if you are a surgeon, even if you are an anesthetist, even if you are an anatomist, doesn't matter. We must know what vaccines are available. We never know the importance of vaccine before COVID era. This COVID has taught us how human life can be at threat by an invisible virus that is known as coronavirus disease, that is COVID-19. And many a time, these few days back, I had been called by so many, TV industries, that what is human metapneumovirus? Is it coming in that way where the COVID virus has done? Yes or no? So, with this introduction, let me go fast. Why the Raukela people are chosen today as a CME day? You know, today is the #1 day of Valentine week. This Valentine week is starting and today is #1, and today is, whenever I was reaching by Tapaswini from Cuttack to this, I have seen somewhere some girl is standing with a rose, someone is some color of rose. Today is Valentine Rose Day. Then so many days will come, hugging day, kissing day, so you know much better than all of us that this day is celebrated in India as Happy Rose Day, February 7. So from me, again, Silver Doctor, to all steel doctors, Happy Rose Day to you all. And this session is celebrated, sponsored by Zydus Cadila people, and they are the vaccine people in industry in India, and they are sponsoring this topic. Dear gentlemen, ladies and gentlemen, vaccines do not save lives. It is the vaccination. If I am having a lot of vaccine in my ILR, that doesn't mean that the children of my locality is saved. You have to go for the vaccination. What are the current guidelines? I have already told. The guidelines #1 is your national immunization guideline. And I will tell you one line. What is the mega change has been done? Mega change has been done that IPV. What is the full form of IPV? Inactivated polio vaccine. Now this inactivated polio vaccine is given in fractional dose in 6 weeks, not 10 weeks, 14 weeks and 9 months. And 9 months, everybody knows, it is not measles, it is MR. 9 months, the measles vaccine has been converted to MR. And now the global trend is that you have to tell bye-bye to rubella. So that's why MR is going to be MMR in very, very shortly. In a year or two, the Government of India is providing that MR should be converted to triple antigen. Then coming to IAP guideline, this IAP guideline, the difference is that whenever a patient comes to us, to a pediatrician, to a doctor, they are going for vaccine for themselves. It is for individual perspective, but NIP is community perspective. If you are interested to save the community, then the vaccine should be there in the National Immunization Schedule. But if you are protecting individual basis, then IAP schedule is the best schedule. So many are not aware of adult vaccines. So let's see, adults, they need vaccines too. These are the adult series where vaccination is needed. And all we know that vaccination matters in adult age group. Why? Because you have taken some vaccine in your childhood, that is DPD. Now you are 10, 20 years old. That vaccine antibody has gone down. So you have to boost it. So for the boosting the past immunity, you need a vaccine, number one. Number two, the old age is gifted by God chronic diseases like chronic artery, chronic coronary disease, chronic kidney disease, diabetes, so on and so forth. So you need vaccination to prevent a lot of diseases. Then third comes the most important part, immunosenescence. As you grow older, the immunity goes down. Two extremes of the human life. One is on this side neonatal or infancy, another is geriatric age. Both are equal. That means immune immaturity one side, immunosenescence one side. So you need vaccination for survival in this planet. New vaccines, just like I will tell, each one who has crossed 50 years, the global data says, or the CDC guidelines says, WHO says, you must be immunized with pneumococcal vaccine for survival in this planet. So that is one guideline. Second, you must immunize annual flu. It may not be recommended for India because we are not a cold country, but if you are staying in Europe or any cold country like China or US, the annual flu shot is a must. Then last comes herpes zoster. Herpes zoster is a vaccine which is to be given 50 beyond, because as the age advances, the chances of herpes zoster increases. So this is the reason we are interested. So let's fast forward basis. I will tell you, coming to one or two individual vaccines, almost all in a fast mode. Hepatitis B vaccine. What is the base schedule? 0, 1, 6. Is that clear? So if you want to give me, I am not taking hepatitis B vaccine. The schedule must be today, 1 month, then 6 months. 0, 1 are known as priming dose, and 6 months is known as boosting dose. Always remember, less than 18 years, the amount of antigen is 0.5 ml. But if the age is more than 18 years, then the quantum of antigen will be 1 ml. It is the double. Pneumococcal vaccine is already there. What is PCV? Pneumococcal conjugate vaccine. Any vaccine which is polysaccharide cannot be given beyond 2 years of, less than 2 years of age, because they are smaller in size. They are not antigen. They are hapten. So you have to make it bigger by adding conjugation protein. So pneumococcal conjugate vaccine is one vaccine which has already rolled on into the NIP since 2013 since 2023. Now it is there 3-dose schedule. Government is giving 3-dose schedule. In office practice we are giving 2+1 schedule. So now I will tell you that what is the indication of pneumococcal conjugate vaccine. This is more than 5 years any child with comorbid. Below 5 years every child in India is indicated. You have to go for each and everyone to get pneumococcal conjugate vaccine. But beyond 5 with comorbid, for an example, sickle cell anemia, cochlear implant, all those cases should get pneumococcal prevention. More than 50 years, this is the guideline I am here to say all of you. Those who are crossed 50, if you have not taken only single dose till your last breath, you need pneumococcal conjugate vaccine, and it will give you good protection, prevention from pneumococcal diseases, invasive pneumococcal disease. More than 65, there is a caveat. You take one conjugate, but 8 weeks later, one polysaccharide vaccine will be given. So this is the guideline. Now comes MMR. Any woman, any girl before pregnancy must be immunized with MMR, because we want to decline the percentage, the number of CRS, congenital rubella syndrome, in the community. So before pregnancy, she must be immunized with one MMR triple antigen, which is a must. If a girl or a boy, now it is not a gender specific vaccine. This vaccine can be given to the boy and girl. If anybody comes to me, I am 30 years old, I am going to marry next year. So what vaccine is indicated? I will tell one vaccine is indicated, very important. Your child cannot be a CP child. I will give you guarantee, but not due to rubella, but maybe due to some other cause, that is different. So 2 doses of MMR to be given in adolescent. This is the schedule. Now coming further, I have brought this brand, that is Zyvac MMR. Why? Because this is available by Zydus Cadila, and the program is sponsored today now by Zydus, so it is their brand. Coming to flu shot. Now in office practice, flu has to be given from 6 months to 5 years. It is a recommended vaccine. But beyond 5 years, it is not recommended. In all special situations, you have to go for flu. So now anybody, suppose you are going to America now, tomorrow, you have to get a flu shot. If you have not taken, then you have to go to US, and US people will give you one shot. Otherwise, you can't stay there. So that means this is the policy. Every year, one vaccine has to be given. If I ask you which vaccine can be given annually, this is famous to known as annual vaccine. This is the flu vaccine. And it is a quadrivalent vaccine, and now it contains influenza A2, influenza B2. Means 4 strain of influenza virus is there, so it is a quadrivalent vaccine. And this is the brand Vaccine Flu 4. Now JE, Japanese encephalitis vaccine, is indicated in now 15 districts across Odisha. And there are 356 districts across India, those who are declared as JE endemic district in Indian scenario. So how you are going to give? National immunization schedule 2 JE, 9 months and 18 months. But in office practice, we are giving 2 doses of JE beyond 1 year, 1 month apart. Then comes TDAP, DPT. Always remember, full DPT, I mean full dose, full antigen. But after 7 years, that full D will be small d. Look at. And full P will be small p, because antigen will be lesser. If you give full P, full D, there will be high amount of local reactogenicity. There will be induration, there will be fever, there will be so much of pain at the local site, so you have to decline the quantum. But immunologically it has been seen, the T cannot be small. Throughout all vaccine, whatever T is there, that has to be capital. That antigen cannot be small. So the name will be TDAP. So TDAP vaccine is famous beyond 7 years. So now comes 1 dose of TDAP to be given as 10-year vaccine. And this has to be given every 10 years. So it is popularly known as decennial vaccine. So what is the difference between NIS and IAP? IAP says we have to give TDAP, but government gives TD. All must remember now, as of now, nowhere in the world TT is recommended. TT is obsolete. Whenever you get a TT, tetanus toxoid, that is obsolete. You have to go for TD, T and small d, because CDC, WHO says the diphtheria is another disease to be eradicated from this globe. Typhoid vaccine, the age group has recently, I mean 2 to 3 months back, upper age limit has gone from 45 years to 65 years. Single dose, whatever may be the age, minimum age is 6 months. If you are interested to take Pani Puri or whatever you say, Gupchup, Dahi Bada Aludam, then definitely one sort of TCB can protect you from typhoid disease. That is, no booster is recommended. And this is the brand Zyvac TCB. Varicella, because all of us know, varicella in a older age group, in a bigger age group can be lethal. It can cause complicated varicella encephalitis. So that's the reason in a naive child or a naive adult, if he has not had varicella in the past, you have to go for 2 varicella vaccine, I mean 2 live vaccine, at least 1 month apart. Hepatitis A vaccine, we know now India is entering into the intermediate intermediate endemic zone as per WHO. Now every one of us should have hepatitis A vaccine, because the most common cause of fulminant hepatic failure in India is hepatitis A. But we never know, even if it is less than 1%, that 1% may be your child, me or anybody. Nobody can give guarantee that I will not die from a vaccine preventable disease. So if you are interested, your child is going to US, mandate. If your child is going to Europe, Australia, it is a mandate that you have to say your child is protected from hepatitis A. If it is a live vaccine, single dose, kill vaccine, 0 and 6. So this is all about whatever I have told. Sometimes meningococcal is a necessity vaccine in many parts of Africa. Because Africa, the middle belt is known as meningococcal belt. So you have to take meningococcal vaccine. Single dose is good enough. Now coming the most important vaccine, which our government of India, Modi government has declared that 1 dose of HPV is going to be given particularly girls. Now you say the woman or a girl is having a uterus and a cervix, then why it is to be given to the boys? Dear ladies and gentlemen, I will tell you now, it is not a gender specific vaccine. The vaccine should be given to boys as well. Why? It is not going to prevent only cervical cancer, but also penile, but also scrotal, but also oropharyngeal cancer. Number 1, who gives HPV to the woman? It is the boy. So you have to protect the boy. So that's the reason it is a gender neutral vaccine, irrespective of boy and girl. Less than 15 years, 2 doses, more than 15 years, 3 doses to be given, but the upper limit is 45 years. Now this is the brand is going to be allocated in our national immunization schedule. It is made from Serum Institute of India. Now Serum Institute of India is the largest manufacturer of antigen in the global scenario, and that lies in India. And that is a Pune based company, and many people say that Pune, other wala Pune, whatever, so they are coming with this. MSD, now they have come up with Gardasil 9 or Gardasil 4, whatever may be the brand. Cervical cancer, as of now, below 14 years, above 9 years, 2 doses. 0 and 6, and above 15 years it is 3 doses, 0 to 6. So this much we have to remember. And this has been advocated by Foxy. Those who are gynecologists, yes, they say also the same thing, 9 to 14 years 2 doses and 14 years above 3 doses. Now Foxy tell what vaccine to be given in pregnancy. I'll tell you a big thing here. Finally, pregnancy, always remember, whoever comes to us having pregnancy positive today, you give T containing vaccine, that is TD. But towards the end of the third trimester, towards the third trimester, you have to go for Tdap in office practice. But in government scenario, 2 doses of TD. Now TT is obsolete. No TT is there. So remember, in pregnancy, you have to know TD in government sector. But in public sector or bought in office practice or in nursing home or in wherever you are giving a woman who is going to be or who is pregnant, 2 doses of TT. That means one is TD, another is Tdap, not the reverse. Start with TD, end with Tdap, because more nearer to the delivery, the pertussis antibody will be traversing via placenta and it is going to prevent neonate from the neonatal pertussis, because the first time pertussis containing vaccine is given by 6 weeks. So let's see some answers. Now I'll ask you, I have told all the vaccines whatever is available in Indian planet. So vaccines for adults, what are they? Annual flu shot, is it needed for us? I'll say no. But if you tell, I am having a chronic lung disease, I am having bronchiectasis, I am having emphysema, I am having chronic bronchitis, then definitely it will be an answer. You have to take annual flu shot. Why? Because flu will enter, it will make the area vulnerable for the secondary bacterial pneumonia by the pneumococcal. So that's the reason pneumococcal vaccination to be given. Tdap, always remember any T containing vaccine is protected for 10 years. If I have taken one T containing vaccine T, then I will not take any TT booster in coming 10 years. It is valid for 10 years. Then comes TD booster in government sector. Singles is otherwise known as herpes zoster. Now herpes zoster vaccine, I request all of you, those who have crossed 50, because herpes zoster is a very troublesome, dangerous thing, because the post-herpetic neuralgia, sometimes like Salman Khan, he was suffering like anything, and 5 years later he went to UK for surgery, and surgery has been done, facial nerve, whatever you say, the toxin mediated damage has been done to that. So pneumococcal age, every human beyond 65, one PCV and another pneumococcal, but beyond 50, one PCV is enough. So that's the way. When I crossed 50, at that point of time, I and my wife has already taken, and my parents, 1 dose of PCV, because that is a mandate. You never know at any point of time, you will be admitted with a pneumococcal pneumonia. So national immunization schedule, that's a only TD that is there in the national immunization schedule. So now onwards, you must know whenever you are writing in surgery or whatever, T prophylaxis, that must be written, not TT, it is to be written as TD. Now TD is already a decennial vaccine, and I have already told that is a adolescent vaccine. What vaccine is adolescent? One is TD, another is HPV. Now HPV has not come in Government of India schedule. It will come towards the end of this year. They are interested to come with single dose, because single dose HPV can prevent 95% cervical cancer. So that's why government is not interested 2 doses, because they say single dose and another dose can be given to another girl, so that 2 girls can be prevented from cervical cancer by giving HPV vaccine single dose. So WHO has already approved 33 countries as of now has single dose vaccine in their immunization schedule. So if I am asking MMR2, yes, 2 doses, hepatitis B, 016, but remember 18 year plus 2 doses, I mean double dose, hepatitis A, typhoid single dose, everything. So meningococcal single dose, this is the singles vaccine, and already told above 50 year 2 doses of herpes zoster vaccine to be given. Now last immunization, it is a question to any one of you. A 20-year boy came to you who has taken only 2 doses of hepatitis B, 6 weeks and 10 weeks in the infancy. Is it clear? 20 years now. He has not taken the 3rd dose. Now my question to all of you is that anyone, now what to do? Should I start again 016, or I will go for only 1 and finish the chapter here? Anyone? In immunization, always remember, do not start the schedule again. You might have forgotten, but the body immune system will never forget, because he has taken 6 weeks and 10 weeks, 2 doses of hepatitis B given. Even in his 20 year, 30 year, 40 year, now you give 1 single dose, and now age is more than 18 years, so I'll go for 1 ml of hepatitis B, and that will be the final dose. Do not restart the schedule in vaccine. So that is all about all vaccine to be given, and girls must take the 2 vaccine. MMR and HPV. Because in India, 70,000 women, they die every year because of cervical cancer. And only way you can prevent cervical cancer by pap smear screening beyond 35 years, and this is the way HPV vaccine. Now Foxy has endorsed into that. So during pregnancy in office practice, remember TD to start, end with Tdap, not the reverse. Then 1 dose of flu has to be given. Why it has been given importance? Because the flu vaccine is not only protect the flu from the mother, I mean it will transfer anti-flu antibodies to the baby, and baby will be protected from flu till age of 6 months, because we are giving flu vaccine at the age of 6 months. Traveler vaccine. Now suppose one of you get up and tell, tomorrow I will go to Pakistan. Then Pakistan you cannot enter unless and until you take a polio immunization. So because Pakistan, Afghanistan are 2 polio endemic countries. So that's the reason traveler vaccine. If anyone is interested to enter into Africa, yellow fever vaccine is mandated. Without yellow fever vaccine, you cannot enter into Africa. Now this is my last few slides. No vaccine talk cannot be complete without kutta. So this is the dog. So if I say dog vaccine, this is the WHO category, cat 1, 2, 3. Any dog bite, cat bite, any mammalian bite, except human bite. If your wife bites, don't take ARV. So that's the only answer. So cat 1, no anti-rabies vaccine. Cat 2, yes. Cleaning of the wound is important. What I am saying here, this is the lesson I want to give you, that wash the wound by under the running water with soap and water, because this virus, rabies virus, the lipid layer will be saponified, will be disintegrated by soap and water. And that's the reason, if you wash under the running water for at least 10 to 15 minutes, then you can decline the burden of rabies to the extent of 50%. Now WHO has told, and what we have endorsed, 4 doses. In office practice, 4 doses of anti-rabies vaccine is enough. 0, 3, 7, 14. 14 to 28 is 1 dose. But in Government of India, they do not allow, they do not agree with 4 doses. They say, no, rabies is a 100% fatal disease, you go with 5 doses. So that is the only difference. Never ever give any vaccine in the gluteal zone. Any vaccine given in the gluteal zone is invalid. You have to repeat the dose, because gluteal zone, no vaccine to be given. Either it could be given in deltoid or it could be given anterolateral aspect of the mid-thigh. Now there are many women are coming up in Bollywood, Hollywood. They do not love human beings. They love kuttas, pets, kutta, billy, because that is this what a symbol of aristocracy. And these elite people, they love billy and kutta. So that's why if anyone is loving billy or kutta, you have to be take pre-exposure prophylaxis. Why pre-exposure prophylaxis? 2 doses will be enough. 0 and 7. 0 and 7. Why? Because if you have taken 0 and 7 whole family members, then if at all there is a bite, then you have to go for 2 doses of re-exposure. 0 and 3. No anti-rabies vaccine, I mean immunoglobulin will be needed. Now, vaccinating dog. Sometimes you enter into a house, be aware of dog, but you have not read. Because of something. Now you entered and the kutta aa gaya and aapko kaat diya. What? Then the malik will come. I have immunized this kutta. Don't go by that version, is obsolete now. Kutta is given, dog is given vaccine to prevent rabies for the kutta, not for human. So that's the reason, even if he has vaccinated, you are not going to do the antibody titer of the dog. So you don't know what is what. So even if he has vaccinated well, you have to go for the category protocol, and cat 1, 2, 3 you have to go for. Yes, I request 3-4 minutes. Dog vaccinated or not, doesn't matter. Go with category management. This is the message. So now I will tell you, ARV not needed. What are the bites where ARV not needed? Every day and all in OPD of CC1 I get. Sir, mo pila soithala alu bhabi ki musa kamudi dela. Kaku na 3 वर्ष छोरा अंगूठी. तामने 3 साल का बच्चे को एक उंगली को एक domestic rat. Now many many delegates they ask me, how do you know the rat is domestic or wild? I will tell the answer. If the rat is found in your house, that is domestic. If the same rat found in the wild place, then that is wild rat. So that is the answer. Usually wild rats are big. They are very big in size and they transmit rabies. So that's the reason domestic rat, rabbit, Indian bats. You have seen Chinese bats, they transmit rabies. There are many African bats, they transmit. Not a single bat in India, they transmit rabies. So you have to remember, rat, domestic, rabbit, Indian bats don't transmit. And this is the vaccine, ARV, yes. Government of India endorsed 5 doses, I have already told. And now we have read in those days, 20-30 years back, that human rabies immunoglobulin gone down. Now you have to remember antibodies, monoclonal antibody. So monoclonal antibody to interrupt, that is you have to go. One pointer you remember, no anti-rabies immunoglobulin to be given intramuscular, no. because rabies do not cause viremia. So that's why it has to be given in and around the womb, no intramuscular. Even if it is left out, don't give, because smaller wound, they need smaller amount of antibody. If it is a bigger wound, that amount of antibody can be diluted with normal saline, can be infiltrated in and around the wound. So few sickle cell anemia adult coming to us, how will you protect them from capsulated sepsis? Already I told, PCV13 followed by pneumovax. Those who are pulmonologists, those who are medicine people, I request all of you, never ever give pneumovax as a solo vaccine. It is never given in the world. Only way you have to go for PCV13. That is the way. If you go to America now, they have converted PCV13 to PCV20. So now PCV20 will come to us in a later way. But as of now in India, it is PCV13. One dose of PCV13 to be given each and every asthmatic or chronic lung disease. But if you are interested to give pneumovax, 8 weeks later you can give that. But never ever give solo pneumovax. Polysaccharide is never recommended in any chronic lung disease. Meningococcal, yes, meningococcal septicemia is common. Typhoid, 1 dose, and Hep single dose. 50 years plus, many of us, including me, are 50 years plus. What are the things to be given as an adult? PCV13 single dose, if you are having no comorbid. Tdap, that will protect you for tetanus, pertussis for coming 10 years. Herpes zoster, this is the new addition. If you are taking herpes zoster, 2 doses to be given. Now 50 plus with comorbid. Now you can ask me, what is the comorbid? Diabetes, hypertension, coronary artery disease, hyperlipidemia, metabolic syndrome, whatever. Same PCV, Tdap, herpes, but annual flu is added. Now summary, adults continue to be adversely affected by vaccine preventable disease. Recommend vaccine to your patients and patients' parents. Because sometimes I see a very good lady comes with a very beautiful small kid. I will treat the kid, look at the mother and tell, have you taken HP vaccine? No doctor, nobody has told. Then for any point of view, you tell, we earn for our bread and butter, that means for our belly, but still then ethical practice is important. Influenza, already I told annual, Tdap, varicella, mumps, and all girls before pregnancy should be getting at least 1 dose or 2 doses of this. There is a book published few months back, Adult Immunization in India. You can download that book from net, Adult Immunization in India, and all whatever I have told, that has been updated into that. And finally, all dear Steel Doctors of India Limited, I can say, SAIL, thank you very much for inviting me to this platform. And always being a pediatrician, I believe that the vaccination can minimize the burden of death, particularly under 5 death and adult death and geriatric death because of many diseases. Oh, it is a life course approach. From the neonate till the geriatric, you need vaccine. Now gone those days where people used to say, polio means vaccination. That day has gone. Now this day, any human need vaccine. What vaccine and what you have to read and you have to follow accordingly. So immunizations are for everyone. So I request all of you, please be a brand ambassador for vaccines. If you are not practicing vaccine in your locality, in your public sector, whoever knows about the vaccine, you can refer the child or refer the person to them. So your job is that no one on earth are going to die because of vaccine preventable disease. So thank you very much. And this is the preventive aspect. And we love that know what is better than prevention is better than cure. Again, I will tell Happy Rose Day to all of you. Thank you very much. Yes, ma'am.
Thank you, Dr. Agarwal, for nice and informative presentation. At last, we can say that get vaccinated, encourage your family and colleagues, and spread awareness in your community for adult vaccination. Thank you very much.
So thank you very much. I think I have done my job. Again, I have to catch Vande Bharat to go back to my place because I have to go evening round after reaching there. So this is the life of, not me, every one of you. Madam अर्चना मैडम बस कहले सकाले दौड़ी दौड़ी आसिक राउंड देखिए पशिगली ताने ये हूँ तेणु राउंड देवाटा भी इंपोर्टाट काले से किसी तेणु दिस इज आवर लाइफ बट व्हाट एवर निज काम निजे करवा जय जगन्नाथ थैंक यू वेरी मच
Thank you, sir. I may now request Dr. Archana Behra, Additional CMO, RSP Raurkela, to present a token of appreciation to Dr. Professor Sunil Kumar Agarwala. Sir. Thank you, ma'am. I may now request Dr. Sushil Kumar, Deputy CMO, RSP Rourkela, to kindly present a token of appreciation to Dr. Archana Behra, Additional CMO, RSP Rourkela. And I now request Dr. Archana ma'am to please present a token of appreciation to Dr. Sushil sir. Group photo. Thank you everyone for this session. After a few minutes, inauguration of AISMOC 2020-25 will start. So please kindly be in your seats.
सर बुला रहे हैं। सर आइए। हाँ सर।
Hello.
देश की आजादी से लेकर आज तक देश को मजबूत बना रहा है इस्पात। ये कभी देश के सबसे बड़े रेल रोड ब्रिज बोगीबील का आधार है, तो कभी दुनिया की सबसे लंबी रोड टनल की मजबूती में भागीदार है। ये कभी रूप बदल दुनिया की सबसे ऊंची प्रतिमा में ढल जाता है, तो कभी आंखों में सपने सजाता है। रूप चाहे कितने भी हों इसके, पर इसके कण कण में सिर्फ भारत है। और जब बात इस्पात की हो तो भारत के पहले पब्लिक सेक्टर स्टील प्लांट राउरकेला स्टील प्लांट यानी आरएसपी की बात कैसे ना हो। तो आइए जानते हैं आरएसपी के बारे में। राउरकेला स्टील प्लांट, इस्पाती इरादों संग आत्मनिर्भर भारत की ओर। सेल यानी स्टील अथॉरिटी ऑफ इंडिया लिमिटेड का यह अत्याधुनिक प्लांट ओडिशा के सबसे बड़े उद्योगों में से एक है। सेल जो कि तब से लेकर अब तक पिन से लेकर पाइप, बर्तन से लेकर जहाज, पटरी से लेकर टैंक, स्पेस शिप से लेकर गगनचुंबी इमारतों और ब्रिज हर जगह अपनी छाप छोड़ चुका है। वो आज आरएसपी और अन्य प्लांट्स के साथ प्रधानमंत्री जी के आत्मनिर्भर भारत के विजन को साकार करने की दिशा में तेजी से अपने कदम बढ़ा रहा है।
अब एक नई प्राण शक्ति, नई संकल्प शक्ति, उसे लेकर के हमें आगे बढ़ना है। हम भारत को आत्मनिर्भर भारत बना सकते हैं। हम भारत को आत्मनिर्भर बनाकर रहेंगे।
वैसे तो सेल के इस प्लांट ने कई कीर्तिमान रचे हैं, पर आज जब सारी दुनिया कोरोना महामारी से जूझ रही है, तब यह प्लांट इस्पाती इरादों, दूरदर्शी नेतृत्व और कर्मचारियों के बुलंद हौसलों से एक नया इतिहास रच रहा है। अत्याधुनिक तकनीक से लैस आरएसपी के स्टील बनाने की पूरी प्रोसेस में एक महत्वपूर्ण अंश है ऑक्सीजन ब्लोइंग, जो कि लिक्विड आयरन को स्टील में परिवर्तित करने में मुख्य भूमिका निभाता है। जितने ज्यादा ब्लोज होते हैं, उतनी ही अधिक मात्रा में स्टील बनता है। आरएसपी ने 2 जुलाई को स्टील मेल्टिंग शॉप 2 में पहले के 30 से 35 ब्लोज एवरेज के मुकाबले सिंगल कन्वर्टर से 48 ब्लोज का आंकड़ा छूकर एक नया राष्ट्रीय कीर्तिमान बनाया है।
राउरकेला में कुछ भी होता है, हिंदुस्तान पूरे कोने में उसका तुरंत वाइब्रेशन पहुंच जाता है।
ये कीर्तिमान है अभूतपूर्व संभावनाओं का, मेक इन इंडिया के तहत कम लागत में बेहतर क्वालिटी के इस्पात उत्पादन का, नई उम्मीदों के सृजन का और ओडिशा के औद्योगिक कायापलट का। तो चलिए सेल के राउरकेला स्टील प्लांट के साथ कदम बढ़ाते हैं आत्मनिर्भर भारत की ओर। राउरकेला स्टील प्लांट, इस्पाती इरादों संग आत्मनिर्भर भारत की ओर।
Namaskar, a very good afternoon. In the line with our rich Indian culture and tradition, let me owe the privilege to chant a sloka from the great epic Rig Veda to mark the auspicious beginning of this prestigious event in which we renew our pledge for the sake of preserving and ensuring health, happiness, wealth, and existence of mankind. मधुवाता ऋतायते मधुख्यरन्ति सिन्धव माधुर्नो संतोषदी मधुनक्ता उतोससो मधुमत् प्रतिभं रज मधुद्वरस्तु नरपिता मधुमान्नो वनस्पति Madhumat astu sujya, Madhir garvo bhavantu naha, Mahanarayano panisata. In our actions, we must take all the possible measures to protect the sanity, serenity, and purity of all the components of Mother Earth through maintaining a clean and green environment. To quote the Greek god of medicine Hippocrates, where the art of medicine is loved, there is also love for the humanity. The idea of convening this type of conference originated at Rourkela by Dr. T.K. Bose in 1980 and was held for the first time in Rourkela. Dr. T.K. Bose was an eminent physician par excellence and became the first ED in 1976. He conceptualized the first AISMOC in 1980, which is the unique to any public sector undertaking. AISMOC is organized by all the steel plants in rotation since its inception. During its long journey, it has achieved great heights comparable to any national or international conferences. AISMOC over the years have become the opportunity for medical professionals of steel industry to exchange ideas, scientific deliberations, and showcasing their work. Such conferences help us to compile experiences and academic activities of all the steel plant hospitals and thus create a spirit of competition to improve and achieve further excellence. It requires a cycle of dreaming, planning, execution, and review to make the process a continuous phenomenon. Thus, the competitive spirit has played a pivotal role to provide a platform and achieve high standard of medical care in the steel industry. We are here to interact the next 2 days to provide a balanced and acceptable way of facing these challenges. In the next few days, we have guest lectures by eminent speakers across the country, panel discussions, symposium, debates, and the competitive sessions include the paper and poster presentations, and the much awaited entertaining highlight of AISMOC is the MediQuiz. The objective of this conference was to bring together medical officers of all the established steel industry in our country for the achievements of ideal standards of preventive, promotive, rehabilitative, and curative health care for the personnel working in the industries and for their entitled dependents. This step will further improve the quality of Medicare of all the employees and the population at large. With this brief backdrop, I, Dr. Lisa Deo, heartily welcome the galaxy of doctors from various steel plants and the dignitaries to this green steel city of Rourkela for 44th Indian Steel Medical Officers Association. Thank you. I may now request our DIC, Shri Alok Verma Sir Ji, to kindly grace the dais. I request our CMO in charge, Dr. Jayant Acharya, to kindly escort Sir to the dais and be seated. I request our guest of honor, Dr. Uma Maheshwar Rao Karanam Sir, to kindly grace the dais. I request our organizing secretary, Dr. Manoranjan Samantrai, to kindly escort Sir to the dais. Thank you, sir. I may now request our young doctors to present a small gesture of appreciation, the beautiful plant saplings to the dignitaries. I may now request Dr. Madhumita ma'am to kindly present the saplings to our EDs who are seated off the dais. Just as these saplings, we too require nurturing and care to grow. Our healthcare system requires the dedication, the expertise, and the compassion of these professionals like yourselves. We hope that these saplings will bring to serve as a reminder for the importance of our collective efforts in promoting health, wellness, and sustainability. Thank you. Lamp is a symbol of knowledge, awareness, peace, progress, and prosperity. As per Indian tradition, we light the sacred lamp to mark the auspicious beginning. I may now request Sri Alok Verma sir, along with the dignitaries, to kindly light the sacred lamp of AISMOC 2025 and enlighten us. Thank you, sir. मंगल दीप आज जलता रहे, स्वस्थ और तंदुरुस्ती आज भरता रहे, अस्पताल का आंगन हो या इस्पात की संयंत्रण हो, घर हो या द्वार हो, हर जगह स्वस्थ और समृद्धि का श्रृंगार हो. I may now request our CMO in charge, Dr. Jayant Acharya sir, to kindly present his welcome address.
Good afternoon all. It is my absolute honor and privilege to welcome you all to the All India Steel Medical Officers Conference. This prestigious gathering brings together esteemed medical professionals, industry leaders, researchers, and experts dedicated to enhancing healthcare in steel industry. The steel sector is one of the backbone industries of our nation, employing thousands of workers who operate in challenging environments. As medical professionals, our role is not just to provide treatment, but to proactively ensure the well-being, safety, and occupational health of these workers. This conference serves as a crucial platform for sharing knowledge, discussing best practices, and exploring innovative solutions to improve health services in the industry in a low and cost during challenging times. We are truly honored to have with us today our esteemed Chief Guest, respected Honorable Director in charge, Sri Alok Verma sir, whose leadership and vision have significantly contributed to the advancement of healthcare in the industry. We warmly welcome you and look forward to your valuable insights, sir. I also extend a heartfelt welcome to the guest of honor, Mr. K. Uma Maheshwar Rao, for sparing his time to grace us. I also extend a heartfelt welcome to our distinguished guest, Mr. Tarun Misra, ED, HR, Mr. Anil Kumar, ED, MM, Mr. Biswaranjan Palai, ED Works, all the CGMs and the senior officials of the steel sector, and eminent speakers who have taken the time to join us. Your presence enriches this event, and we eagerly anticipate the knowledge and the experiences you will share with us. This conference aims to address key challenges in occupational health and industrial medicine. Second is discuss advancement in medical technology and healthcare policies relevant to the steel industry. Third is foster collaboration between medical professionals and industry stakeholders to improve health and safety standards. Over the next 2 days, we will engage in insightful discussions, panel sessions, and networking opportunities that will help us collectively enhance medical care in our industry. Once again, I extend a warm welcome to each of you. Let us make this conference a fruitful and inspiring experience by sharing ideas, learning from each other, and working towards a healthier future for our workforce. Again, wishing you all a productive and enriching conference. Thank you.
Thank you, sir, very much. Professor Uma Maheshwar Rao Karanam, who is the guest of honor today. Sir has graduated in the mining engineering from Osmania University, Hyderabad in the year 1983. After working in various mining industries for a total period of 3 years, he joined the technology of Banaras Hindu Universities for Masters in the Engineering program. He acquired his M.Tech in mining engineering in 1987. Professor Rao started his teaching career as a lecturer. Thank you, sir. I may now request sir to kindly address the gathering.
Thank you very much. To introduce myself, I'm Uma Maheshwar Rao. I'm from Hyderabad. Currently, I'm the director of NIT Rourkela. Nothing more, nothing less. And the most distinguished dignitaries on as the chief guest of today's conference, Sri Alok Verma, Director in charge of Rourkela Steel Plant of Steel Authority of India Limited, and Dr. Jayant Kumar Acharya, CMO of our hospital, IGH, and other dignitaries on DAS, Manoranjan Samantare, Dr. Manoranjan Samantare, and other officers from Rourkela Steel Plant, SAIL, and all the doctors. Very good afternoon to all of you. Amongst a group of doctors from various steel industries, I'm definitely an odd man out, and all, I think, other dignitaries are also the odd men out here. The reason is that we are technocrats. Rather, to put it simply in a medical jingo, we are just the subjects for the doctors here. And I'm really happy to be present here for this conference of the doctors from all over the India connected with the steel. When I really want to make my address related to the present context, what I feel today is that health is one thing which is very, very important for everyone. Having said this one, and then today, in whatever the conditions in which we are living, in an advanced state of condition, in a digital era, and I believe that a lot has improved in the medical science. As far as our country is concerned, if you look at the statistics, I'm just only trying to recollect the statistics, the average life expectancy of Indians at the time of independence was just about 30 years or plus. And today we are no less to any advanced countries. We are almost, the life expectancy in our country is around 70 years, where 72 years is the life expectancy in United States of America. That means, as far as medical field is concerned, or the ability of the medicine in our country is concerned, in a country like this where 1.4 billion population is there existing, in that the life expectancy has improved to 70 years. It is a tremendous improvement that is there in the field of medical sciences. Okay. And having said this one, there is no exaggeration that though I am from Hyderabad, and during my childhood in Hyderabad, there was only 2 hospitals in the entire city. That is, one is Osmania Hospital, General Hospital, and then the other general hospital is Gandhi Medical College, associated with the Gandhi Hospital. And today you find that every corner in the city, I think there are, I am not exaggerating that one, there are many multi-speciality hospitals, and you name the type of the medical requirement that you have, right, it is there in Hyderabad. And in fact, it has become the medical hub in the country, and then there are many foreign the subjects coming from all over the world for typically for the Asian Institute of Gastroenterology. Right. So now there are some marvelous medical facilities that have improved in the city. Not only that, not just Hyderabad, I think Bangalore is also one, and then Chennai is also another one. Likewise, every city, you name the city, there is a different mode of medical the facilities that have come up in the country. Having said this one, I recently read at some place that today 1 in every 10 people are vulnerable to cancer, is what I have really read. You only will be knowing very well whether it is true or not, but then things have really changed. I'm just trying to digress from the medical science to the other conditions which is really impending us to this type of the vulnerabilities. There are certain things which we have never heard about, only heard or really memorized or remembered in the textbooks, but then we have really witnessed that one during 2019 and 20. That is all about the COVID. COVID was there in the books, right? And then it was there in the books as only a statement, quote unquote as a statement. But then when we had to witness that one in 2019 and 20, and that was nothing like any pandemic you can ever think of. Okay, it has given shiver in the spines of everyone, particularly this pandemic, the phase 2. Okay, and then the silver lining here, which I just would like to acknowledge, taking this dais as a platform, is that the people associated with the medicine and then the paramedicals have done an exceptional work, and then they have really proved that India is no less to any advanced country. Rather, Indians have really come out to be the best country which has handled this COVID-19 and during 19 and 20 effectively. And then that's where the phrase has come. Atmanirbharata, Atmanirbhar Bharat. Just now we have heard from our Honorable Prime Minister stated that it has been coined during that time when the country was hit by this COVID-19 and 20. Okay. And then I really take this platform to acknowledge all the medical fraternity, that the exceptional works that you have done, and then given a hope and then assurance to the entire population of the country. And second thing is that, incidentally, my own brother is also a doctor, and then he is a professor in urology in the Osmania Medical College. And then my sister-in-law, right, she's also a doctor, she's a gynecologist in Gandhi. My niece is their doctor, she is also medical graduate, she's a practicing pediatrician. So that having said that one, I really do not have much of a knowledge than approaching them as a subject, and then I have problem here, I have a problem there, and then this is what exactly is the Google narrative is. Okay. Why I am really stating is that today medical knowledge, whether you are a doctor, MBBS or not, this artificial intelligence has given us so much of an access to the information, and then we really do not know how to decipher how much of that particular thing is really true to yourself or not, we really do not know. But then when we read everything there, when we read them, we feel that every single aspect said in that Google information is applying to me, and then I am going to really be there, that only. If I really try to type my symptoms in now this AI and then Meta, and then it will really scroll down the information that you are 90% liable to cancer. This is what exactly is the information that we have. Why I am saying is that today we are in a digital era. As a technocrat, I feel proud that we are in a digital era, and then each one of us, I have 2 smartphones, and then DIG is also having 2 smartphones, and then one of them is Apple. I'm also carrying Apple, and then Sir is also carrying Apple. So now, the question is that a smartphone, why I'm saying is that a smartphone is the phone which is really very, very smart, and it is connected to the globe, entire globe, right? And then you ask for an information, within no time it gives you this information in no time, okay? And then this one, not only that, it is not just limiting that one. And today we are able to conduct classes on a mobile, and then attend to video conferences on a mobile, India and abroad, or even people are able to watch, right? People are able to watch India versus England match, right? Online at the real time. This is the time. What I am trying to really emphasize here is that there cannot be a better time than the time in which we are all living in. But then, having said this one, the only challenge that we have is that new varieties of, new forms of medical challenges are coming up on the surface, okay? And then artificial intelligence, when we say that one, it is in terms of the machine language, right? And it is in terms of the various other tools that are there, IoTs and then ChatGPT, and then today we have the deep learning, and not only that, Chinese have come out with the DeepSeek also, right? These are all the tools which are helping the medical graduates. Today we have come to a point where all the divergent fields are converging back again, right? What I mean to say is that it is just not medical sciences all alone existing. Rather, there is technology converging to medical sciences. There is humanities which is converging into medical sciences. There is any other field you just try to see, everything is converging into the medical stream, and then it is just not the medicine standing alone independently. In fact, at NIT Rourkela, we have the biotechnology and medical sciences which is combined together, it is being offered. And then there are so many the faculty members with the computer sciences, with the electronics and communication are working on the cardiac related the projects and researches. What I mean to say is that with that, now the machines which are nearly come up for the diagnostics, these are all the machines which require some bit of a technology, and deciphering the information, this is where artificial intelligence is going to really help the medical fraternity, right, in the diagnosis, in the treatment, as well as in the monitoring of the patients, right, or the subjects. Artificial intelligence is going to make a greatest contribution to the medical fraternity. And then I think I have said more than what I can say right here this afternoon, and then I'm really happy to be present here amongst the doctors. When I really look at the doctors, right, we only feel reassured that nothing is going to go wrong for any one of us because they are here. They are here, and then you are all like, in India at least, we consider, we the non-medical people consider that doctors are nothing less than the gods on the earth, right? You go to any doctor, you go with any ailment, we just want that tap on our shoulders and then say that we are there, we will take care of you. With these few words of assurance from my medical fraternity, I take this opportunity to thank you once again for giving me this occasion to speak some words with you. Thank you very much.
Thank you, sir, very much. You have made this event very special by your inspirational speech, sir. Literature is the living memory of nation. Souvenir is that of a celebration. To keep the memory afresh of this conference, I may now request Sri Alok Verma sir to kindly do the honor of releasing the souvenir. I request other dignitaries to kindly assist sir.
Fourth All India Steel Medical Officers Conference, a proud tradition that continues to unite.
Thank you, sir. Let's have a brief look at the presentation of our AISMOC souvenir.
Welcome to the 44th All India Steel Medical Officers Conference, a proud tradition that continues to unite healthcare professionals from hospitals across the steel plant sector. Over the years, this conference has evolved into a cornerstone for knowledge sharing, collaboration, and innovation, with a steadfast commitment to the well-being of employees and their families. At its heart, this event is more than just a gathering. It's a celebration of our collective mission to provide exceptional, patient-centric care. By fostering dialogue and exchanging insights, the conference has played a pivotal role in enhancing the healthcare services delivered to those who are the backbone of the steel industry. In a rapidly advancing medical landscape, this conference ensures that our practitioners stay ahead of the curve. Through engaging sessions, workshops, and discussions led by esteemed experts, we delve into the latest advancements in medical science, technology, and patient care practices. This ongoing effort equips our hospitals with cutting-edge knowledge and tools to address both current challenges and future needs. Rooted in compassion and driven by innovation, the conference reflects our shared dedication to improving healthcare outcomes and enriching lives. Together, we strengthen our commitment to excellence in service, ensuring the health and happiness of the workforce that drives the nation's progress. Let us join hands to inspire, learn, and contribute to a brighter future in healthcare. Here's to another enriching and impactful year together.
Mr. Alok Verma Sarji completed his B.Tech in Mechanical Engineering from BIT Sindri. Mr. Verma commenced his career at Bokaro Steel Plant in the year 1991 as management trainee. Over his 32 years long tenure at Bokaro, Mr. Verma played a crucial role in the timely project's completion of rolling mills in 1997, 2007, 2015, and 2023. As a certified Six Sigma Black Belt, he completed many key assignments other than operation of mills. These include ERP implementation, Six Sigma certification, patent of technical design of hot rolling coiling operation, and invention of 3 new projects. In July 2023, Mr. Verma was promoted as Executive Director and was assigned the responsibility for the mine's RSP. He played a crucial role in seamlessly integrating the systems of the newly formed Odisha Group of Mines with RSP. In the fiscal year 2023 to 24, the Odisha Group of Mines record iron ore production of 14.30 million ton. In September 2024, Mr. Verma assumed the additional responsibility of ED Works RSP. He then served as ED in charge Works of RSP from November 15, 2024 until he took over Director in Charge, and ultimately Mr. Alok Verma has assumed the Director in Charge SAIL RSP on 13 January 2025. Mr. Verma's unwavering commitment to excellence and his dedication to flawless execution have earned a reputation as a leader who sets the bar high and brings in cultural of continual improvements. I may now request Sri Alok Verma sir to kindly address the gathering.
Good afternoon. Good afternoon, dignitaries on the dais, Professor Rao, Dr. Acharya, Organizing Secretary for this conference, Dr. Samantre, Head of Medical Units from steel plants, all other sister steel plants also from Tata Steel. Welcome to this green and clean city of Rourkela. I'm very happy to be, in fact, this is the first conference where I am invited as chief guest for a medical conference. So I don't know what to speak. And many of the things regarding technology and other things were covered by Dr. Rao. So I was, in fact, had an opportunity to listen to him on many occasions, and his deep insights are really very technology driven. Whereas I will just tell you a small story. When I was in college, and that was way back in 1987, I had a friend who became very sick in college days. It was a government college in Dhanbad, near Dhanbad, BIT Sindri. And that time, we had a government clinic, a doctor who was posted in the hospital, and his timings were from 4 to 6:30 in the evening. And there was one room in which there were 2 beds, and there was the pharmacy was also in that same room, and there was a compounder, and the doctor had only a stethoscope. He only had a stethoscope and a thermometer just to know the temperature, although I rarely used thermometer. I just wanted to share this story because it has a bit of humor also, and also it shows that from 1988 to this day, where people are working on stem cell therapy and finding out ways to treat cancer, medicine has really traveled a long way. Then I took my friend to the doctor. My friend was very, very sick, and we had to virtually carry him to that hospital, that room where the doctor was there. And he had 4 or 5 jars of medicine. There were one red medicine, then one blue tablet, one white tablet, and there was one cough syrup tablet, cough syrup jar, which was very big. And for getting that cough syrup, you had to bring your own bottle. That was the way you have to do that. So he said, and then he examined my friend, and he said, "अच्छा ठीक है, ये टाइफाइड है, something like this, so ठीक हो जाएगा. ये दवाई खा लीजिए सवेरे, ये दोपहर में, ये शाम को." And then he started talking to me about other things like what are you doing these days, and about the weather and things like that. Then I said, "Sir, I am also not feeling that well these days, or I am having slight headache." He said, "इसमें से आप भी एक दो खा लीजिएगा." So from that day to this day, where I am standing in Apollo Auditorium, for me it is a big long journey. Doctors, they are so important. Like, there is a quote I read somewhere that God cannot be physically present everywhere, so he made doctors. So this is what said about doctors. So it is one step nearer to the fact that the job is very difficult. You are meeting people who are not in the best of their senses, not in the best of their health, and treating them and giving them that confidence that you will be okay. Itself is a huge job, It is really very, very, it touched lives in such different ways, and it is so rewarding also sometimes that I know you must be feeling that every day you are achieving something. In my family, I have an uncle who is a doctor and he's a surgeon, but anybody in the extended family, up to 100 members, they call him any time of the day and any time of the night. And he always lifts the phone. And even if 2 o'clock, somebody is not sick, somebody is not well, they will call him and he will pick up the phone and say, ye khana chahiye, ye test kara lo, and things like that. So that is the support system doctors provide to the families, to the society, and so important part of our daily life. Also, the other aspect I want to say that medical tourism in India, it's a very rewarding profession. A lot of people from all over the world come to India for getting treatment here and getting themselves operated and replacement and cancer treatment and neurological issues and a lot of things. I think our hospitals, Steel City hospitals, also need to work on those lines, because the support, the revenue generated from our hospitals and the cost to run those hospitals is becoming wider day by day. Doctors need to control this. Either they should try to increase their earnings, or they should try to decrease their costs. Because I just wanted to tell you that this is also going to be very important, because steel business is getting very squeezed up and margins are very less. So this is one aspect which every steel plant, hospital needs to. We have huge establishments. I think we have more than 3,500 beds. I think more than. Dr. Vibhuti, I think 900 we have already got in Bokaro. Yeah. So we have got huge capacities, and we need to fully utilize them. We need to attend our patients and also not refer them as per their wish. So this area we need to work. Either we have to increase our revenues, or we have to decrease our costs, because the gap is really very huge. This is one area I wanted to bring to your attention. Other than that, this conference, I wish you all the best. I think it is one of the best things to happen, having a conference of like-minded people working in the same profession. That way, steel and being a steel plant doctor, you have a unique experience attending people in the middle of the night with a lot of pain, some industrial problems like burns, gas. So you are so important in the whole process, in the whole system. So this conference, I wish you all the best. I wish all the young people and all the people from this medical fraternity that this 44th conference becomes a success, and you all share knowledge and share your experiences, and be happy and be contented. So there is a saying in English that an apple a day keeps the doctor away, but the doctor is good, so don't eat apples. So I don't eat apples. Thank you so much.
Thank you, sir, very much. As per the mark of our love, respect, and regards, we would like to present a token of gratitude on behalf of AISMOC to our honorable guest of honor, Dr. Uma Maheshwar Rao Karanam, sir. I may now request Sri Alok Verma, sir, to kindly do this honor. Thank you, sir, very much. I may now request our CMO in charge, Dr. Jayant Acharya, sir, to kindly present a token of gratitude to Sri Alok Verma, sir. Thank you so very much. The man behind the show. I would request our very articulate, energetic organizing secretary, Dr. Manoranjan Samantrai sir, to kindly propose the vote of thanks.
Good afternoon, respected dignitaries, our chief guest, Honorable Director in charge, Sri Alok Verma sir, our guest of honor, Professor K. Umamaswar Rao, Director NIT Raurkela, Dr. Jayant Kumar Acharya, CMO in charge, IGH Raurkela, and all other dignitaries of the dais, esteemed guests, distinguished speakers, and dear colleagues. It is both an honor and privilege to stand before you today to deliver this vote of thanks for this meeting of All India Medical Officers Conference. This conference will be an incredible platform for learning, collaboration, and exchange of ideas that will shape the future of medical services in the steel industry. First and foremost, I extend my heartfelt gratitude to our chief guest, Honorable Director in charge, Sri Alok Verma sir, for gracing this occasion with his presence, sharing their valuable insights. Your inspiring words have truly motivated us to strive for excellence in our profession. A special thanks to Professor K. Umamaswar Rao, Director NIT Raurkela, for sparing his valuable time and enlightened us with his vast knowledge and experience. A special thanks to all the esteemed dignitaries, Mr. Tarun Mishra, EDHR, Mr. A.K. Behuria, ED Finance, Mr. V. Palai, ED Works, Mr. MP Singh, ED Mines, Mr. Sudeep Pal Chaudhary, ED Projects, Mr. Anil Kumar, EDMM, and the senior leaders from the steel industry and the medical fraternity for their support and guidance. Your contributions will be instrumental in making this conference a success. I sincerely thank all the distinguished speakers, panelists who have shared their expertise and will share their expertise and their innovative approaches. A big round of applause and appreciation goes to also my helping organizing committee, support staff, PR department, horticulture department, fire department, finance department, and other departments for their tireless efforts in planning this event. Without your dedication and hard work, this conference would not have been possible. We are also immensely grateful to our sponsors, partners for their generous support. A heartfelt thanks to all delegates, medical officers, professionals for participating with this enthusiasm. Your presence, engagement, and discussions have made this conference truly meaningful and impactful. As we conclude this meeting, let us take forward this knowledge, collaborations, and new ideas what we will gain to continue to work together towards the betterment of healthcare in the steel industry, ensuring the well-being of all workers and communities. And lastly, I'd like to thank Apollo Hospitals for their valuable support and their continuous support in running this event. Thank you and have a wonderful day.
Thank you, sir. By this, we come to the end of our inaugural session. I may request Sri Alok Verma sir, Dr. Rao sir, Jayantacharya sir, and Manoj sir, and our CGMs of RSP to kindly proceed for a high tea. And all our EDs too. And the rest, I would request them to proceed for the stall inauguration, which will be inaugurated by Dr. Ravindranath M, EDMNHS, followed with lunch. The lunch buffet is a first floor auditorium. Our next long paper session will start at sharp 2 p.m. I request everyone to be in the hall by sharp time. Our poster session will be at Hall B. I request everyone to proceed for the stall inauguration.
देश की रगों में हम खुले कदम सदे न पे तुले कदम दौड़ते हैं देश की रगों में हम खुले कदम सदे न पे तुले कदम सीने की आग से रोशनी है कि हमने उन्नति की रास्ता सब तरफ लिखी हमने शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलना है मीलों मील शेर की शपथ है ये इरादों में स्टील शेर का वादा ये हौसलों से आसमां में उड़ेंगे हम जुड़े हैं धरती से हमेशा जुड़ेंगे हम नींव में देश की देखो हम इस बात भरे देश चढ़े देश बढ़े छाती चौड़ी हम करें शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलना है मीलों मील शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलते रहना मीलों मील शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलना है मीलों मील शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलते रहना मीलों मील दौड़ते हैं देश की रगों में हम खुले कदम सधे न पे तुले कदम दौड़ते हैं देश की रगों में हम खुले कदम सधे न पे तुले कदम सीने की आग से रोशनी है कि हमने उन्नति की रास्ता सब तरफ लिखी हमने शेर की शपथ है ये इरादों में स्टील शेर का वादा ये चलना है मीलों मील शेर की शपथ है ये इरादों में स्टील शेर का वादा ये हौसलों से आसमां में उड़ेंगे हम जुड़े हैं धरती से हमेशा जुड़ेंगे हम नींव में देश की देखो हम इस बात भरे देश चढ़े देश बढ़े बढ़े, छाती चौड़ी हम करें। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलते रहना मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलते रहना मीलों मील। दौड़ते हैं देश की रगों में हम, खुले कदम सधे न पे तुले कदम। दौड़ते हैं देश की रगों में हम, खुले कदम सधे न पे तुले कदम। सीने की आग से रोशनी है कि हमने, उन्नति की रास्ता सब तरफ लिखी हमने। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये हो। हौसलों से आसमां में उड़ेंगे हम, जुड़े हैं धरती से हमेशा जुड़ेंगे हम। नींव में देश की देखो हम इस बात भरे, देश चढ़े देश बढ़े, छाती चौड़ी हम करें। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलते रहना मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलते रहना मीलों मील। दौड़ते हैं देश की रगों में हम, खुले कदम सधे न पे तुले कदम। दौड़ते हैं देश की रगों में हम, खुले कदम सधे न पे तुले कदम। सीने की आग से रोशनी है कि हमने, उन्नति की रास्ता सब तरफ लिखी हमने। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये हो। हौसलों से आसमां में उड़ेंगे हम, जुड़े हैं धरती से हमेशा जुड़ेंगे हम। नींव में देश की देखो हम इस बात भरे, देश चढ़े देश बढ़े, छाती चौड़ी हम करें। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलते रहना मीलों मील। सेल की शपथ है ये, इरादों में स्टील। सेल का वादा ये, चलना है मीलों मील। सेल की शपथ है ये, देश की रगों में हम, खुले कदम सधे न पे तुले कदम, दौड़ते हैं देश की रगों में हम, खुले कदम सधे न पे तुले कदम, सीने की आग से रोशनी है कि हमने, उन्नति की दास्तां सब तरफ लिखी हमने, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये चलना है मीलों मील, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये हो, हौसलों से आसमां में उड़ेंगे हम, जुड़े हैं धरती से हमेशा जुड़ेंगे हम, नींव में देश की देखो हम इस बात भरे, देश चढ़े देश बढ़े छाती चौड़ी हम करें, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये चलना है मीलों मील, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये चलते रहना मीलों मील, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये चलना है मीलों मील, सेल की शपथ है ये इरादों में स्टील, सेल का वादा ये चलते रहना मीलों मील।
Welcome to a special video about single-use plastics.
SAIL, at the forefront of nation building. Steel Authority of India Limited, an organization that tests your mettle at every step, an employer that challenges you each and every day, surprises you each moment and teaches you something in every passing moment. A behemoth with a turnover of more than rupees 1 lakh crore, SAIL is a leader in the Indian steel industry, having a pan-India presence. Projects that had earlier remained unimaginable have been made possible with SAIL Steel, be it steel for the Statue of Unity or the thousands of kilometers of rail tracks connecting the country, the formidable INS Vikrant or the longest bridge in the country, Dola Sadia. We are known to have the best technical and managerial talent in the country. Men and women who are always ready to take on the different challenging assignments that they encounter with dedication and passion. SAIL's engineers in disciplines like mechanical, electrical, metallurgical, chemical, electronics, computer, IT, mining, etc. redefine steel making each day. The limits of technical knowledge and acumen of new recruits are tested time and again. Needless to say that the talent at SAIL always shines through. Every unit in SAIL is like a huge factory in itself, with captive power plants, foundries and huge shops, the giant scale of which is totally unimaginable. Many do not know that SAIL is also the largest iron ore miner among steel producing companies operating mining units spread across mineral-rich states of the country. Many would not even know that the quantity of the various byproducts generated at SAIL plants is so humongous that they are used as input materials in different chemical and fertilizer industries. The enterprise resource management projects such as SAP have been implemented in the company across its units, which has modernized and revolutionized the company's operations. These and similar systemic improvements are slowly leading us to the vision of Industry 4.0. SAIL handles what could be a logistics nightmare for others with effortless ease. Right from getting coal from Australia to supplying steel products to almost every district of the country. SAIL does this with smile and the contentment of contributing to the nation's growth. Steel Authority of India Limited. There is a little bit of SAIL in everybody's life. SAIL, at the forefront of nation building. Steel Authority of India Limited, an organization that tests your mettle at every step, an employer that challenges you each and every day, surprises you each moment and teaches you something in every passing moment. A behemoth with a turnover of more than rupees 1 lakh crore, SAIL is a leader in the Indian steel industry, having a pan-India presence. Projects that had earlier remained unimaginable have been made possible with SAIL Steel, be it steel for the Statue of Unity or the thousands of kilometers of rail tracks connecting the country, the formidable INS Vikrant or the longest bridge in the country, Dola Sadia. We are known to have the best technical and managerial talent in the country. Men and women who are always ready to take on the different challenging assignments that they encounter with dedication and passion. SAIL's engineers in disciplines like mechanical, electrical, metallurgical, chemical, electronics, computer, IT, mining, etc. redefine steel making each day. The limits of technical knowledge and acumen of new recruits are
our esteemed chief guest, respected on.
Thank you so very much.
We are now ready to begin our afternoon paper session, which promises to be an exciting and informative series of presentations. We have our eminent chairpersons here on the dais, Dr. Ravindranath M, ED MNHS BSP Bhilai, and Dr. Manoj Panigrahi, Additional CMO RSP Rourkela. I invite Dr. Bibi Karunamai and Dr. Manoj Panigrahi here today's afternoon. Let us start this long papers with a total time duration of 80 minutes, in which 8 minutes is allotted to the speaker for the presentation, out of which after 7 minutes, 1 buzzer, then again after 1 minute, 1 buzzer to mark to end the presentation, and 2 minutes for the interactive session. I may now request Dr. Jaita Sarkar, BSP Bhilai, to present the paper, topic of which is comparison of propofol and sevoflurane on post-operative cognitive function in patients undergoing general anesthesia.
Hello, it is a prestigious paper in this session. It's a competitive paper. I wish all the best to the participant. Thank you.
Thank you.
Respected chairpersons, honorable judges and members of the audience, a very good afternoon to all of you. My long paper is titled Comparison of Propofol and Sevoflurane on Postoperative Cognitive Functions in Patients Undergoing General Anesthesia. Anesthesia and surgery have been associated with cognitive disorders such as delirium and delayed neurocognitive recovery, the spectrum termed as postoperative cognitive dysfunction. It is known that 12% of previously cognitively well patients undergoing non-cardiac surgeries under anesthesia develop symptoms of cognitive dysfunction following surgery. Previous studies which have compared cognitive outcomes after total intravenous anesthesia and volatile agent-based anesthesia have yielded conflicting results. There is currently insufficient evidence to inform the choice of general anesthetic agent with respect to effect on neurocognitive recovery. Therefore, we conducted this study to compare the safety profiles of propofol, an intravenous anesthetic agent, and sevoflurane, a volatile anesthetic agent, with respect to cognitive parameters in the immediate postoperative periods following general anesthesia. The aim of the study, as previously mentioned, was to compare the effects of propofol and sevoflurane on postoperative cognitive functions. The primary endpoints were cognitive function scores at 424 and 48 postoperative hours, and number of subjects with decline in cognitive function during the same interval. Secondary outcomes included intraoperative hemodynamics, postoperative pain scores using the VAS scale, and postoperative complications. The study was time-bound, hospital-based, prospective, randomized, double-blind, and comparative. Study area, population, and duration were predefined. Patients were included if they met all of the following inclusion criteria. Patients were excluded in the presence of any one or more of the following exclusion criteria. Sample size calculation was based on a previous study published in the British Journal of Anesthesia. Minimum sample size was 38 in each group. Following institutional ethical committee approval, 100 patients were assessed for eligibility, out of which 6 were excluded due to various reasons, 4 refused to participate, and that left us with 90 patients who were randomized based on computer-generated random numbers. Into 2 groups, 45 were assigned to propofol group, henceforth referred to as group P, and 45 assigned to sevoflurane group, henceforth referred to as group S. 5 patients in each group were further excluded due to surgical cancellations, prolongations, and protocol deviation, and 40 patients were assessed post-operatively in each group. For individual study subjects following pre-anesthesia checkup and informed consent, patients were instructed about the study. Preoperative cognitive function scores were recorded, and subjects were kept fasting overnight. Subjects were reassured to alleviate anxieties, and no preoperative anxiolytic medication was administered. On the morning of surgery, once in the operating room, monitors were attached, baseline readings noted, IV lines secured, and patients were pre-medicated and pre-oxygenated, followed by induction of anesthesia. Induction of anesthesia was done in subjects of group B with injection propofol 2 to 2.5 milligram per kg intravenously, while patients of group S were induced with sevoflurane 6% and 100% oxygen. Now, following achievement of specific induction endpoints, trachea was intubated after the administration of muscle relaxant with appropriate size endotracheal tube. Anesthesia was maintained with a mixture of nitrous oxide and oxygen, and propofol infusion in patients of group B and sevoflurane inhaled in patients of group S. The maintenance doses of propofol and sevoflurane were adjusted to maintain bispectral index values between 40 and 60. In Intraoperatively, hemodynamic parameters, which included mean arterial pressures, heart rate, end-tidal carbon dioxide values, arterial oxygen saturation values, were continuously monitored and recorded at 15 minutes interval along with bispectral index values. At the end of surgery, subjects receive injection paracetamol 1 gram intravenously, which was repeated every 6 hours for post-operative analgesia. Neuromuscular blockade was pharmacologically reversed and trachea extubated. Subjects were then monitored for 1 hour in the post-anesthesia care unit for occurrence of defined adverse events, and subsequently, once stable, they were shifted to the wards where further post-operative assessment for pain using the VAS scale and cognitive function assessments using MOCA and MMSE scales were done at 4, 24 and 48 post-operative hours. Cognitive function assessment tools used for this study were the Montreal Cognitive Assessment Tool and the Mini-Mental State Examination Tool. Collected data included pre, intra and post-operative data. Recorded data was statistically analyzed for level of significance. The statistical analysis of collected data yielded the following results. Demographic profile, which consisted of age, gender and age physical status, was comparable between the two groups. Analysis of age distribution of subjects revealed that majority of study subjects were in the age group of 51 to 60 years, followed by the age group of 21 to 30 years. With a p-value of 0.11, the age distribution in both groups was statistically comparable. With a p-value of 0.45, educational qualification between the two study groups was also comparable. The presence of comorbidities, which included hypertension, hypothyroidism and diabetes, was statistically comparable between the two groups. Both groups were statistically matched with respect to surgical duration, diagnosis and treatment. Intraoperative hemodynamic data when analyzed also revealed similar characteristics. Intraoperative mean arterial pressures and heart rates continue to remain comparable between the study groups at all points of observation. Similarly, mean arterial oxygen saturation and end-tidal carbon dioxide values were also comparable between the study groups at all recorded intraoperative time points. No significant difference was noted between the BIS values of the two groups during the intraoperative period. Now coming to the primary objective parameters. This is a tabular representation of cognitive assessment scores using the MOCA scale during preoperative assessment and 4, 24 and 48 postoperative hours. At the fourth preoperative MOCA scores were comparable between the two groups. At the fourth postoperative hour, there was a significant decline in MOCA scores in both the groups. Furthermore, at 24 postoperative hours, MOCA scores in sevoflurane group continued to remain below preoperative baseline values, where those in the propofol group returned to preoperative levels. At 4th and 24th postoperative hour, the difference in MOCA scores between the two groups was also statistically significant. At the 48th postoperative hour, MOCA scores of both the groups had returned to preoperative baseline values and were comparable. This is a graphical representation of the previous data. This is the tabular representation of cognitive assessment scores using the MMSE tool during preoperative assessment and 424 and 48 postoperative hours, which is seen to follow the same pattern of significance as previously reported MOCA scores. Significant decline in MMSE scores was seen at the 4th and 24th postoperative hours in patients belonging to the sevoflurane group as compared to those in the propofol group, where significant decline was noted at the 4th postoperative hour only. Graphical representation of MMSE scores reflects the same trend. The number and percentage of patients with affected cognitive functions, that is, cognitive function scores using either the MOCA or the MMSE score below preoperative baseline values, was also recorded and analyzed. This data was also found to be significantly higher at the 4th and 24th postoperative hour in patients belonging to group S as compared to patients belonging to group P. This is a graphical representation of the previous data. A look at postoperative pain scores reveal comparable values at all points of observation. No defined complication was seen in either group. To summarize the findings of this study, all other observed parameters being comparable, cognitive function scores in the immediate postoperative period were significantly reduced in patients receiving sevoflurane-based general anesthesia as compared to those receiving propofol-based general anesthesia. To conclude, propofol-based general anesthesia has lesser effect on the early cognitive parameters as compared to sevoflurane-based anesthesia, and propofol compared to sevoflurane may be a better anesthetic agent to reduce the incidence of postoperative cognitive impairment in patients undergoing general anesthesia for surgery. These are some of the references used. Thank you for your patient hearing.
Thank you, madam, for completing the session in time. I allow questions from the audience.
Compared to sevoflurane may be a better anesthetic agent to reduce the incidence of postoperative cognitive impairment in patients.
I'm Dr. Abhijit Dan from Bokaro General Hospital.
Thank you for
Here.
your patient hearing.
So for post-op pain relief, you just used paracetamol infusion 6 hourly, that's about it?
Yes, we did VAS course at 424.
No, but what were the nature of surgeries? What was the nature of surgeries, Dr. Abhijit Dan?
The surgical categories included laparoscopic cholecystectomy, and there was laparoscopic hernia repair, IPOM, TEEP and TAPP. Then we had excision surgeries, small fibroadenoma excisions from the breast.
Okay, so you really think that one gram of paracetamol given every 6
6 hours, and we had used analgesic in the pre-medication also.
What analgesic?
We had given injection tramadol 2 milligram per kg intravenously.
So, do you really think that was adequate for maintaining post-operative?
We had monitored VAS course in the post-operative period.
Is that a standard practice in Bhilai then? Do I take?
We do VAS scoring. Yeah, VAS scoring is done for.
No, I'm not talking about VAS scoring. That means you don't use narcotics at all.
No, we use post-operative opioids, but since this was a study regarding cognitive functions and opioids may be affecting.
So that means you allowed your patients to suffer basically in the post-operative. You did allow your patients.
Our VAS scores did not reflect pain. The degree of pain as reflected by the VAS scores were like 0 to 3. So
I mean, over my years in practice, I don't agree with that statement.
We can allow another participant to ask question. Another participant may ask the question.
our VAS scores did not reflect pain. The degree of pain as reflected by the VAS scores were like 0 to 3. So.
Dr. Rishi Anand from Tata Main Hospital. Did you consider surgical duration?
Yes, surgical duration was considered. Our inclusion criteria had surgeries lasting for less than equal to 2 hours, and I had shown.
Both the groups were comparable for surgical duration?
Yes. I had shown the graph there.
Okay. Dr. Rishi Anand from
Thank
Tata
you.
Main Hospital.
Thank you, sir. Thank you.
Surgical duration?
Yes, surgical duration was considered. Our inclusion criteria had surgeries lasting for less than equal to 2 hours, and I had shown.
Both the groups were comparable for surgical duration?
Yes. I had shown the graph there.
Okay. Dr. Rishi Anand from Tata Main Hospital.
Thank you, sir. Thank you.
Surgical duration?
Yes, surgical duration was considered. Our inclusion criteria had surgeries lasting for less than equal to 2 hours, and I had shown.
Both the groups were comparable for surgical duration?
Yes. I had shown the graph there.
Thank you.
Thank you, sir. Thank you.
Surgical duration?
Yes, surgical duration was considered. Our inclusion criteria had surgeries lasting for less than equal to 2 hours, and I had shown.
Both the groups were comparable for surgical duration?
Yes. I had shown the graph there. Thank you, sir. Thank you. Yes, surgical duration was considered. Our inclusion criteria had surgeries lasting
of recurrence rate of oral cavity cancer in patients who were operated in the Department of Surgical Oncology at Tata Main Hospital. It is an ongoing observational study. Our study period was from 1st January 2018 to 30th June 2024. All the patients who were diagnosed with oral cavity cancer and operated in the Department of Surgical Oncology were included in the study. The tumors which were involving the masticator space, infratemporal fossa or the skull base, that is clinical P4B lesions, were excluded. The source of data are surgical register, operation theatre notes, case sheets, hospital online data, and the patients were visiting the TMS Surgical Oncology OPD. Statistical analysis was performed using the SPSS software and the Microsoft Excel. All the surgeries were performed under general anesthesia with nasal intubation. The surgeries done for the primary lesion were wide local excision, composite resection in which the tumor in the oral cavity was removed along with a part of mandible. Bite resection where there is removal of the tumor along with superior and inferior alveolus, maxillectomy and hemiglossectomy. The common neck dissections performed were modified radical neck dissection in which level 1 to 5 cervical lymph nodes were excised along with sternocleidomastoid muscle, preserving the internal jugular vein and spinal accessory nerve. The second group was MRND in which level 1 to 5 cervical lymph nodes were excised, preserving the sternocleidomastoid muscle, IJV and spinal accessory nerve. This was done mostly for CA tongue cases. Selective neck dissection in which level 1 to 3 cervical lymph nodes were excised. This is also known as prophylactic neck dissection and is done for clinically and radiologically N0 neck. Before 2020, the standard practice was excising the tumor with 1 centimeter margin. But after the availability of frozen section at our institute, the current standard practice is excising the primary tumor with a 1 centimeter margin, which is confirmed by frozen section. If the margin is reported close, that is less than 5 millimeter, then the margins are revised, and the patients with margins that were positive or close and final histopathology report were treated with adjuvant chemoradiation. These are the few intraoperative pictures where we can see the incision is being planned after nasal intubation. Here, a subplatysmal flap is raised and hemimandibulectomy performed. These are hemimandibulectomy specimens which are marked and sent for final histopathology. This is a bite resection specimen in which the tumor is removed along with a part of superior and inferior alveolus. Reconstruction is being done by pectoralis major myocutaneous flap. In this patient, there was a buccal mucosa malignancy with extensive involvement of the overlying skin. So the tumor was excised and a large defect was created which was reconstructed with a bipetal PMMC flap. Now coming to results, total 251 patients were included in the study. In 149 patients, they had a history of gutka chewing followed by pan and alcohol. 113 patients had a combination of habits. So tobacco history was found in 97.61% of patients and 6 patients did not have any history. So there is a correlation between tobacco history and occurrence of malignancy. Out of 251 patients, 250 patients had squamous cell carcinoma. Lower alveolus malignancy followed by 33 patients who had tongue malignancy and 13 had upper alveolus and hard palate malignancy. The commonest stage of presentation was stage 4A, 190 patients present in stage 4A and 25 patients in stage 3. Composite resection was the commonest surgery performed in 190 of our patients. It had one margin positivity. So there was a strong correlation of getting negative margin after implementation of frozen section. Two similar studies were conducted, one by Badola et al. In northern India and one by Lokhande et al. In western India. Badola et al. Had a sample size of 574 patients and the duration of study was 8 years. Lokhande et al. Had 1895 patients enrolled in the study and the duration was 10 years. Tobacco history was significant in all the 3 studies, and the age group commonly involved was 50 to 60 years. The common site involved was buccal mucosa in our study and Badola et al. Study. But in Lokhande et al. Study, tongue was the common subsite involved, followed by buccal mucosa. The commonest stage of presentation in all the studies was stage 4A, but in our part we received 75.69% of our patient in stage 4A. In our study, the recurrence rate was 4.7%, and in Badola et al. Study, it was 12%. The limitation of this study is, it is a single institute observational study. 15 patients were lost to follow-up, and 5-year overall survival could not be calculated because all of the patients have not reached that duration. So to conclude, squamous cell carcinoma is the most common type of oral cavity cancer in our study, and it is strongly related to tobacco chewing habit. Since most of the patients present in an advanced stage, and since oral cancer is a preventable malignancy, awareness regarding cessation of tobacco use and screening can be beneficial to the general population. In spite of having new modalities of radiation, surgery with negative margin still remains the treatment of choice for treatment of oral cavity cancer. Frozen section plays a very important and a vital role to achieve negative margin and is the current standard of care. Thank you.
Any question from the audience?
It was a good presentation and a good paper.
Thank
you. So, you think what are the screening methods that you will use to reduce this cancer prevention regarding what all measures the DMH is taking?
Ma'am, in our center we are conducting awareness program. Mostly it's not in the hospital based but also in the community. So there we are doing for the most important thing is early detection. So if we are screening the patient, those are the normal candidates. First of them we are counseling them about the tobacco cessation, and the screening which we are doing is the local examination. We examine the oral cavity properly to look for any non-healing ulcer, any neck swelling and all, and in that case we can find out.
You have camps for that?
Yeah, we do conduct camps amongst our company and as employees as well as in the community.
Okay.
Can I ask? A very good presentation.
Thank you, sir.
I have two questions. You have said limitation of study was 5 years survival rate you cannot carry out. But can you tell me what, if possible, what was the 2 year survival rate or 3 year survival rate?
Sir, actually in our, since we have taken a 5-year survival rate as an end point, so we are not able to calculate because most of our patients have not reached that state. But for 2 year to 3 year survival, it is around 65 to 63 to 65%. That was our calculation. But we will be coming forward with a long-term result, what is the overall survival and the disease-free survival. So it's around 65%.
Okay, thank you.
Thank you so much, ma'am. I will now request Dr. Bishwarup Mukherjee, ISCO Burnpur, to present timing of laparoscopic cholecystectomy in acute cholecystitis.
Both Mrs. Gupta and Mr. Mishra presented with features of acute cholecystitis confirmed by USG. Both were advised immediate admission. Mrs. Gupta deferred her admission since she could not leave her 2-year-old kid alone at home. Mr. Mishra, traveling from his remote village, was already symptomatic for more than 7 days. So what should be the surgical plan for either of them? Respected chairpersons, judges, esteemed delegates, seniors and my dear friends, my presentation for today will focus on the timing of laparoscopic cholecystectomy in acute cholecystitis. Can any time be the best time? The surgical approach to acute cholecystitis has never been static. From being listed as a contraindication to acute cholecystitis, being restricted within the so-called golden first 72 hours, then extended up to the first week, and finally up to 10 days of symptoms. Many lab surgeons still believe that for patients presenting in the second week or beyond, be safely treated conservatively till the 6th week for interval cholecystectomy. However, conservative treatment to interval cholecystectomy is not easy. Recurrent attacks and morbidity is common. Adherence to restricted lifestyle and food habits is difficult, and risk of complications remain. And interval surgery may be no less hazardous. The aim of my study was to compare the outcome of laparoscopic surgery in acute cholecystitis in cases presenting in the first week versus those presenting in the second week or later versus interval or planned cholecystectomy. This is a prospective study with the approval of ethical committee. They are conducted between Jan 2023 and December 2024 with analysis of pre, intra and post-operative data retrospectively. All patients with symptoms of acute cholecystitis confirmed by USG were included, even those with choledocholithiasis post-ERCP. Patients with associated moderate to severe gallstone pancreatitis, advanced organ comorbidities, ASA3 or more were excluded from the study. After a clinical diagnosis and a USG correlation, patients were advised immediate admission. Relevant tests, including an MRCP or a CT abdomen, was advised as deemed necessary. Perioperative antibiotics were started. All cases were recorded in the advanced 4K resolution video recording system installed at our OT. Operative time, blood loss, and operative findings were noted. In the postoperative period, introduction and tolerance to oral diet, intensity of pain by pain scoring, and duration of stay was noted. Patients were typically followed up at 1 week, 2 week, and SOS. During the period January 2023 and December 2024, total 152 cases were enrolled for laparoscopic cholecystectomy, 33 were males and 119 were females, age ranged from 20 to 83 years. Showing the gender distribution according to age, patients were retrospectively divided into 3 groups, Group A, Group B, and Group C as control, showing the distribution of the patients according to the timing of surgery. A significant number of patients, 43 patients, presented in Group B. The mean operative time, mean blood loss, and conversion to open procedure, the outcome and results were similar in all the 3 groups. In my personal experience, a difficult cholecystectomy in Group C is even more challenging than those cases in Group A and B. When the postoperative pain score via the numeric rating system was looked into, it was seen that Groups A and B had similar results. However, this was significantly less than in Group C. The other criteria showed similar values. There were no cases of bile duct injury during this period. However, one patient had a subhepatic biloma with a stone in lower end of CBD. She was treated by ERCP and stenting without drainage, underscoring the importance of pre-op MRCP screening by MRCP. Showing the distribution of the cases in Group A and B. Sorry, seems the video is not working. There are 3 cases I'll demonstrate here. First one is a female of 34 years, presented in the 3rd week of pain. She had an impending perforation, which is shown by the red circle. The second one is an GB lump with an empyema gallbladder, treated in the 2nd week by laparoscopic cholecystectomy. And third one is a female of 26 years, another GB lump with extensive adhesions. All 3 patients were treated successfully by laparoscopic cholecystectomy. There is a paucity of literally data to compare the outcome of surgery in the first week against those cases presenting in the second week up to week 6. However, a delay in presentation and hazards of conservative treatment prompted us to carry out this study. A landmark study, a multi-center randomized trial carried out and presented in 2013 by Carsten N. Eigat et al. They commented that immediate laparoscopic cholecystectomy should become therapy of choice for acute cholecystitis in operable patients. A more recent and relevant study, this is an original article that was published from AIIMS Bhopal and Apollo Hospitals Bhubaneswar in 2023. They commented that in a tertiary care setting with adequate surgical expertise, laparoscopic cholecystectomy can be safely performed with acute cholecystitis irrespective of the time of presentation. The limitations of my study include a single center, a single surgeon experience, a short time span, and a limited number of patients. Laparoscopic cholecystectomy in acute cholecystitis is often not an easy procedure, should not be attempted by beginners and those early in the learning curve. Experienced supervision is vital and conversion may be necessary in difficult cases. Some centers advocate the use of indocyanine green for delineation of biliary anatomy. We have this facility, but we do not use this routinely. Subtotal cholecystectomy is an option in difficult cases. Hemostasis may often prove challenging. Abdominal lavage and placement of drain may be judiciously chosen by the surgeon. For patients undergoing laparoscopic cholecystectomy in acute cholecystitis, everything appears to be in favor except for the difficult surgery for the surgeon. For the surgeon who is attempting lap surgery for the first time in acute cholecystitis, I will advise a cautious approach and resilience to brave the odds. So, in a tertiary care setting with adequate surgical expertise, laparoscopic cholecystectomy in acute cholecystitis is safe with morbidity, mortality, conversion rates, post-operative hospital stay, and outcome comparable to, if not better than, interval cholecystectomy. I will leave you all with the advantages summarized here: less morbidity, earlier return to work, reduced number of man days lost, and less financial burden on the organization. Thank you for patient hearing. Namaskar.
Yes.
Sir, I have started laparoscopic cholecystectomy from January 2023 and I have been recording all the cases. The first case I was showing, it was a case of impending perforation. But most of the cases I have encountered are pericholecystic abscesses. Actually, I have included those in GB lump because often when you try to dissect a GB lump, you may see there is a pus collection. Often there is leakage of pus from the empyema gallbladder. It's very difficult to distinguish, but I tell you that all these lump cases, they are potential for being
Sometimes the ultrasound findings are like that. They told it is a gangrenous cholecystitis and patient is stable. In that case, what will do? Whether we go for a cholecystectomy or plan for a interval one?
In any case of diagnostic doubt, we have always resorted to a CT scan.
Okay.
And if we have doubt about the biliary anatomy, we have gone in for the MRCP.
Okay.
If there is any doubt, then we do go in for a direct percutaneous cholecystomy drainage without surgery. But I can tell you, even in a case of impending gangrene, you should go in and do the surgery. It will save the life of the patient. If once the perforation, gallbladder perforates, and there is biliary peritonitis, it's very difficult to save those patients. They have a very stormy period in the ICU.
And in the pericholecystic abscess?
Pericholecystic abscess, we can go in for surgery under coverage of.
Thank you. Okay. Any questions? Second question.
I am Dr. Uma Devi from pulmonary medicine actually, but due to our experience in the back, what I want to ask you that the earlier interventional cholecystectomy lab or whatever it is, it was not done earlier because of the lack of expertise and lot of cases where there was most of the edema and not able to localize the gallbladder. Many times they have ruptured the bile ducts. So it went into bile peritonitis, where they have again gone into a open cholecystectomy. So just I want to have a throw light on that.
Ma'am, what I can tell you, as early as you can intervene, you will have a better surgical field. Because once you delay, the procedure is not under your control. So what we have seen with the better imaging systems that we have available at present, the most challenging part of this surgery is hemostasis. If you can control hemostasis and you can protect the bile duct, the rest of the surgery with patience and with determination falls in place.
Okay, thank you.
I usually use gauze for hemostasis and it helps me very much.
Earlier is better. Thank you.
Thank you, sir.
Thank you so much, sir. I may now request Dr. Samarpita Mandal, DSP Durgapur, to present comparison between air versus installation of 4% lignocaine in endotracheal tube cuff to evaluate post-activation sore throat and hoarseness, a randomized controlled trial.
Good afternoon, honorable judges and my dear colleagues. Today I will be presenting a comparison between air versus installation of 4% lignocaine in endotracheal tube cuff to evaluate post-extubation sore throat and hoarseness, a randomized controlled trial. Airway management with cuffed endotracheal intubation is very essential for general anesthesia. However, the phase of extubation is associated with many side effects like hypertension, tachycardia, agitation, coughing, sore throat, hoarseness, and dysphonia. Many studies have been performed to minimize post-extubation sore throat and hoarseness, like installation of lignocaine in endotracheal tube cuff. The endotracheal tube cuff is made of polyvinyl chloride and is semi-permeable membrane which allows small molecule to diffuse like lignocaine and exerts its local anesthetic effect over tracheal mucosa. However, there are not many studies on the efficacy of 4% lignocaine in alleviating sore throat and hoarseness. Hence, we conducted our study aiming to compare the incidence of sore throat and hoarseness between two groups after extubation from general anesthesia. Our primary objective was to compare the incidence of sore throat and hoarseness after 24 hours of extubation, and our secondary objective was to compare the pulse rate and blood pressure at 5, 30, and 60 minutes after extubation. At first, the ethical committee clearance and informed consent were obtained from all the patients. Then the study was conducted over a period of 2 years from July 2022 to June 2024 in DSP Main Hospital, in which we included ASA 1 and 2 patients aged between 18 to 55 years, posted for abdominal surgeries under general anesthesia with a surgical duration of 30 to 60 minutes. Some of my exclusion criteria are depicted in this chart. At first, the patient was randomized in two groups of 24 each. Basic parameters were attached and parameters recorded. Pre-medication was done with IV ranitidine, metoclopramide, and midazolam a night and 2 hours before surgery. At the time of induction, IV fentanyl, IV propofol, and atoquirium 0.5 milligram per kg was used, and then intubation was done with proper size endotracheal tube. In group A, 5 ml of air, and in group B, 5 ml 4% lignocaine were instilled in endotracheal tube cuff. This picture showing the parts of endotracheal tube and the endotracheal tube cuff preparation before intubation. This picture showing the normal anatomy of esophagus and trachea in an intubated patient. Then the cuff pressure was measured and maintained between 20 to 22 centimeters of water by cuff pressure gauge in all patients. The anesthesia was maintained with oxygen, nitrous, and sevoflurane, and atoquirium 0.15 milligram per kg was used as the IV maintenance dose, and extubation was done with neostigmine and glycopyrrolate according to the body weight. Airway suctioning was done during extubation in all patients. Then the incidence of sore throat and hoarseness were observed after 24 hours of extubation in all patients. pulse rate and blood pressure were also noted at 5, 30 and 60 minutes after extubation in all patients. This results showing the demographic data that were comparable between two groups. This results showing the incidence of sore throat and hoarseness were significantly less in group B, that is the lignocaine group. This data showing the pulse rate and blood pressure at 5, 30 and 60 minutes were comparable between two groups. All my study results are depicted in some bar diagrams. Postoperative sore throat is very common and occurs about 90% in all intubated patients. The main cause is overinflation of the cuff that compresses the tracheal capillaries, which leads to tracheal stenosis, ultimately causing in tracheal stenosis. Some other causes are intubation trauma, mucosal dehydration or edema, pharyngeal airway use, and endotracheal tube cuff size and design, and using of nitrous oxide as an inhalation agent. There are many measures tried to minimize post-extubation sore throat, like high volume, low pressure and smaller size endotracheal tube, inhalation of steroids, topical application of lubricant jellies, IV or intracuff lignocaine with or without alkalinization as a drug delivery system, and use of cuff pressure gauge to maintain the cuff pressure below 30 centimeters of water. Lignocaine acts on tracheal mucosa through diffusion. The cuff material is semi-permeable and diffusible to small molecules like lignocaine. The lignocaine exists from cuff to tracheal tissues via concentration gradient. After reaching the tracheal mucosa, lignocaine acts via blocking sodium channel and inhibiting nerve impulse conduction. Lignocaine also causes vasodilatation by releasing nitric oxide and contributes to the vasoactivity of this drug. Lignocaine also prevents nitrous oxide from trachea to diffuse back to endotracheal tube cuff, thus prevents cuff pressure from rising. There are some studies having similar results in the term of sore throat, hoarseness and hemodynamic parameters. Some studies having different results, like Hassan and Budania found no significant difference in sore throat and hoarseness, as they used only 2% lignocaine in their endotracheal tube cuff. Studies prove that the higher doses of lignocaine are required, around 200 to 500 milligram are required to produce a significant clinical effect on sore throat and hoarseness. On the other hand, Rao et al. Found significant changes in hemodynamic parameters as the duration of the surgery is well longer. The study shows that lignocaine diffuses only 1% over a period of 6 hours. For a significant change in hemodynamic parameters, the plasma lignocaine level should be 2.3 to 3 microgram per ml. So a longer duration of surgeries are required for significant hemodynamic parameters. There are some limitation on my study, like bronchoscopy finding after 2 days and 1 week may reveal more frequent tracheal mucosal damage, but bronchoscopy was not done in my study. And airway suctioning is also associated with postoperative sore throat, and it was also not standardized in my study. So I can conclude from my study that lignocaine 4% installation in endotracheal tube cuff significantly reduce the incidence of post-extubation morbidities like sore throat and hoarseness as compared to air. So take-home message from my study is installation of 4% lignocaine in endotracheal tube cuff is better inflating agent than air. So for a shorter duration of surgeries, 4% lignocaine should be instilled instead of air for better emergence from general anesthesia. These are my references. Thank you all for your patience.
Thank you, madam. Any question from the audience?
Excuse me.
Dr. Rishi Aman from Tata Main Hospital. You used air, a gas medium, and 4% lidocaine, a liquid medium. So why were you not considering using normal saline as inflating agent for control group instead of air? Because it is known that it is confounding factor.
Yes, that is a good question. We don't use, because air is readily available in everywhere. For liquid like sterile water, you are talking about sterile water.
You can use normal saline also.
Saline also. We did not use because basically we use every patient's air is basically used mainly in the endotracheal tube cup. So we can use, but in my study we use only air.
You are doing controlled study, so you could have standardized liquid medium for both groups, normal saline in one group and 4% lidocaine in one group, so that any confounding, because you could have ruled out liquid as a confounding factor, because it is known that
I can't hear you.
because it is known that using liquid agent in inflating as an inflating agent reduces the cuff pressure and maintain cuff pressure in lower range. So anyhow, it will reduce the sore throat.
Yes, I don't understand you. I can't hear. I can't hear.
Basically, whenever you are using liquid as an inflating agent for endotracheal cuff, it reduces the incidence of sore throat. It is a known fact and already published in many literature.
Yes.
So you could have easily used normal saline as a comparable group instead of air.
Basically we didn't thought about it because air is basically used in all patients. That's why we use air only in comparison with 4% lignocaine.
But you already have used 2%.
We didn't
Next question,
thought about
next candidate can ask a question. One more question. One more question.
I'm Dr. Vinita Divedi, Department of Anesthesia. I'm Dr. Vinita Divedi, Department of Anesthesia. This mechanism of sore throat after endotracheal intubation is the pressure.
Yes, mainly the pressure. Mainly the pressure. Overinflation.
You can use lignocaine before also. And there have been studies while giving IV lignocaine during post-operative before extubation, that also prevents coughing in those patients. So I don't know whether local 4% lignocaine, the dose actually is
Madam, the 4% lignocaine is higher. That's why we can use it in a shorter duration of surgeries. For longer duration, the systemic adverse effect may be there, but for shorter duration of surgeries, it is proved that it is effective. In my study also, we have a positive result.
How did you prove it? How did you prove it? How did you know that only 1% of lignocaine was absorbed?
Yes, there is many studies are there that lignocaine absorbed after diffusion because it is made of polyvinyl chloride and it is a semi-bicarbonate. It is proved, already proved.
Next candidate.
Thank you so much, ma'am. I may now request Dr. Anupama Sharma, BSL Bokaro, to present Artificial Intelligence in Ophthalmology.
Thank you so much. Very good afternoon to all of you. Honorable chairpersons, esteemed judges, respected seniors and colleagues. I am Dr. Anupama Sharma from Bokaro General Hospital, and today I am here with my topic, Artificial Intelligence in Ophthalmology, BGH Perspective. Excuse me, it's automatically changed. Slides are automatically changing. Sorry for the technical glitch.
Hello. Hello, there is some technical issue there. If anybody could attend it. Hello.
I hope it won't.
कुछ technical issue है वहाँ पर?
Dr. Kasi, please see to it. The slides are automatically moving.
Yeah. Without being slides, we automatically change. I don't want the slides to change automatically.
It is not under any presentation.
No, the slides will change by the... No, I'm not using it. This is just a pointer. I'm not using it. Okay.
Restart.
थोड़ी देर wait करिए. Sorry for the technical glitch. Honorable chairpersons, distinguished judges, respected seniors, and dear colleagues. I am Dr. Anupama Sharma from Bokaro General Hospital, and today I am here with my topic, Artificial Intelligence in Ophthalmology, BJ's Perspective. Artificial intelligence, it refers to the theory and development of computer systems that are capable of performing tasks which were traditionally associated with human intelligence. In fact, it has been one of the most influential information technological revolutions. Artificial intelligence has evolved from intelligence machine with problem-solving skills to machines which can learn and match patterns without being explicitly programmed, to the latest of all, the deep learning, which makes use of the deep neural networks. Deep learning is the latest and the most powerful AI tool. It uses a data-driven approach to teach a computer to solve a task by itself by giving inputs and the desired outputs as an examples. It uses multiple layers of convolutional neural networks or artificial neural networks mimicking the neurons of the human brain. In today's scenario, artificial intelligence is everywhere, ranging from voice assistants on our mobile phones to areas of advancements like healthcare, finance, education, and even automobiles. However, there are certain limitations for any medical AI system to be translated into clinical application. It has to have the validity, generalizability, and interpretability so that it can be applied to a wide range of population. It also needs to have the longevity and liability so that it can be used for the longer duration of time. In ophthalmology, diagnosis and therapeutic monitoring of many ocular diseases often rely heavily on image recognition, and AI becomes an important tool in recognizing these images. AI has been used and is being used in diagnosing and monitoring many diseases of anterior and complex diseases of posterior segment of the eye, as is highlighted in this image. Our problem statement was, in a busy OPD, many patients turn up for diabetic retinopathy and glaucoma screening, and we all know it has been the two most important causes of irreversible visual impairment, and their numbers are on rise worldwide. And in these cases, vision loss can be prevented if we diagnose them early and intervene timely. Based on this background, our research question was, can we use AI in industrial hospital for screening of diabetic retinopathy and glaucoma? We did a hospital database study over a period of 5 months from June to October 24 using non-mediatic handheld fundus camera, and we did fundus screening of 396 patients and compared it with the dilated clinical fundus evaluation. The study was conducted at Bokaro General Hospital with a due ethical approval from the Institutional Ethics Committee. We included the patients of diabetes and glaucoma suspect who came for screening and who gave the consent to participate in our study. The patient who had other ocular diseases, who had media opacities, or who denied to be the part of our study were excluded from our study. These are some of the images taken with the help of the non-mediatic handheld fundus camera. Here the very beautiful and clear images has been taken, and the areas of lesion has been highlighted by the AI algorithm of the device. However, the algorithm of the device could not classify the disease into the various grades of diabetic retinopathy, whether they were mild, moderate, or severe. Even the cases of proliferative diabetic retinopathy were diagnosed just as cases of diabetic retinopathy. In some of the cases, the drusen of the diabetic retinopathy, hard exudates of the diabetic retinopathy and drusens of the ARMD were not diagnosed properly, and the device gave an ambiguous results as whether they are diabetic retinopathy or AMD. In glaucoma, to diagnose them promptly, we need to evaluate optic nerve head on optic disc margin so that the structural damage and retinal nerve fiber loss could be picked up early. These are also the images which have been taken with the help of the same device. Here we can see the margins of the cup and disc has been very well delineated and picked up by the AI algorithm of the device. These are some more pictures where the device has also calculated the cup disc ratio and has suggested the need for further referral. In advanced cases of glaucoma, the device not only calculates the cup disc ratio, it also highlights the areas of retinal nerve fiber loss and highlights it into color maps. Coming to observation, Total number of patients screened were 396. Out of 214 patients of them were screened for diabetic retinopathy and 182 patients were screened for glaucoma. Demographically, they were clinically insignificant. Out of the 214 patients who were screened for diabetic retinopathy, 172 patients had diabetic retinopathy. Out of the 182 patients who were screened for glaucoma, 97 had them. And out of the 127 patients who had neither diabetic retinopathy and glaucoma, 47 patients were diagnosed as cases of age-related macular degeneration using the device. These are some of the pictures where the drusen of the ARMD has been identified and picked up, highlighted by the AI algorithm of the device. Coming to results, we compared the results with the clinical evaluation, and out of 172 patients who were positive for diabetic retinopathy, 170 cases were true positive, calculating the sensitivity and specificity as 98.84% and 85.71% respectively, with the accuracy of the test being 96.26%. For glaucoma suspects, out of the 97 patients who were diagnosed using the device, 92 were the true positive cases, calculating the sensitivity as 97.85%, specificity being 94.12%, and the accuracy of the test being 95.51%. Coming to discussion, Natarajan et al., they did a similar study using offline AI model, and they calculated the sensitivity and specificity of 100% and 88.4% respectively in diagnosing cases of referable diabetic retinopathy. In any grade of diabetic retinopathy, they found a sensitivity and specificity of 85.2% and 92% respectively. Similar results were obtained by Sosal et al. Another study using the cloud-based software, they found a sensitivity and specificity very much similar to that of our study results. For glaucomatous optic neuropathy, a study conducted by Sidhu et al. Using 975 fundus camera, they found a sensitivity and specificity of 83% and 80% respectively. Another study by Lee et al., they reported a deep learning system in detecting referable cases of glaucomatous optic neuropathy with sensitivity of 95.6% and specificity of 92%, which is similar to our study results. To conclude, AI algorithm of non-mediatic fundus camera can be used as a reliable tool for screening of patients in terms of diabetic retinopathy and glaucoma. These are all my references. Thank you so much.
Any question from the audience?
So, thank you for the question, sir. The patient who turned up for diabetic retinopathy screening, they were picked up for a duration.
How? What was the randomization? How did you select? What was the selector? Which group will go for AI and which group will go for?
So for all the patients who turned up for diabetic retinopathy screening from the medicine department, they were already diagnosed cases of diabetes, and they were referred to us for diabetic screening.
No, you are not getting my question.
Yes,
you have seen all the diabetic retinopathy patients.
Yeah.
Then you compared manual versus AI, na?
Yes, sir.
So how did you select who will go for AI and who will go for manual?
So we did both for them. We did AI, and also we did.
So they'll be biased definitely.
No, sir. And
But by the time you do manual, suppose you have done the AI first, you know what is the result.
yes,
So
sir, it
will
was a
that
blinded
not,
study.
Bias? Yeah.
So it was a blinded study.
Yes. Blinding was done or not?
Yeah. It was done, sir.
It was done.
Yes, sir.
Next question, please. Any question?
No, I haven't.
Any more question?
Okay.
Thank you.
Thank you so much.
Thank you so much, ma'am. I may now request Dr. Sujata Guttola, VSP Vishakhapatnam, to present the effect of maternal vitamin D deficiency and the risk of hyperbilirubinemia in term newborns.
esteemed judges, distinguished guests, and my dear fellow delegates, a very good afternoon. I, Dr. Sujata Guttala, on the behalf of Team RINL, sincerely express my gratitude to Team Rourkela for giving us this opportunity to present ourselves on AISMOC 2025. Thank you so much. Allow me to present my long paper today titled Maternal Vitamin D Deficiency and Neonatal Hyperbilirubinemia in Newborns, a Case Control Study, a correlation study. So vitamin D, as you are all aware, is a fat-soluble vitamin, but it has been considered as a prohormone. It is responsible for various biochemical reactions in our body, and it is also important and vital in the fetal-maternal well-being. The incidence of maternal vitamin D deficiency globally ranges from 40 to 80%. Around 60% of term-born neonates in the first 1 week of life present with neonatal jaundice, and 75% of these babies are physiological jaundice. Many studies have shown low maternal vitamin D levels has been related with many obstetrics complications, gestational complications, and also with neonatal complications. And to enumerate a few of the neonatal complications: small for gestational age babies, preterm births, irregularities in bone and teeth development, and high risk for infectious diseases. In the recent past, a few studies have showed there is a correlation between maternal vitamin D deficiency and physiological jaundice. So my study was aimed to observe the correlation of maternal vitamin D deficiency on the risk of hyperbilirubinemia in term newborns. It was a prospective cross-sectional study conducted in the Department of Obstetrics and Gynecology and Pediatrics at our center, conducted over a period of 2 years, and the maternal blood sample was collected for vitamin D levels at the time of delivery, and the babies were assessed for jaundice on day 3 to 5. Besides the medical history and medical examination, the 5 ml blood was collected for vitamin D levels, and the cutoff for deficiency definition was less than 20 nanograms per ml. In the newborns, they were evaluated for jaundice on the 3rd or 5th day of life, both clinically and serologically with a blood sample, and the bilirubin level cutoff was more than 15 milligrams per deciliter, which required phototherapy. In the inclusion criteria on the maternal aspect, all the mothers who delivered in the hospital and were more than 37 weeks of gestation were included in the study, and those who were excluded were ones with medical disorders, gestational problems, obstetric complications, and Rh negative incompatibility. In the newborn aspect, all exclusive breastfed babies only were included in the study, and birth asphyxia or meconium aspiration, dehydration, or formula-fed babies were excluded from the study. The average age of the mothers that we had studied was around 29 years, and the gestational age was around 37 weeks. The normal delivery women were 62%. On an evaluation of the educational status, we had noted around 59% of the women were graduates or higher. On overview of the maternal vitamin D levels, only 6% had sufficient levels, and more than around 94% had insufficient or deficient levels. When we matched the maternal vitamin D levels with the educational qualification of the mothers, we noted the higher the education, the lesser the incidence of vitamin D deficiency, and this was a significant correlation. Looking at the supplementation on our history taking, we noticed that 84% of the women had a vitamin D supplementation. Among these, on an average, 80% had low dose supplementation and 19% had high dose supplementation. Of the 100 women we had enrolled, only 85 babies were taken up for study because they were exclusively breastfed. The average birth weight of the babies was 3 kgs, and the average bilirubin levels was 12.81. Looking at the bilirubin levels, 15% of the babies had more than 15 milligrams per deciliter in the bilirubin levels. And then we correlated maternal vitamin D levels with the bilirubin levels of the baby, and we had noted an inversely correlation between both of them, and it was a significant correlation. Lower the maternal vitamin D levels, the higher the jaundice levels among the babies. So when I reviewed the literature, in a global review by the WHO in 2016, they had showed that overall incidence of the Southeast Asian mothers had a higher incidence of vitamin D deficiency, that was 87%, whereas the European and American counterparts was between 50 to 64%. Then we compared our study with the other studies that were done And we had noted that Zhuang et al. From China, which was a meta-analysis, had 88% of incidence of vitamin D deficiency. And my study corroborated with the Garg et al., an Indian study, and Zahra et al. From Iran, which was more than 90%. The global incidence of jaundice was highest among the Southeast Asian babies, which was around 30%, and the overall incidence globally was around 20%. Looking at the neonatal jaundice in the other studies, our study had corroborated with the Iranian study and the Turkish study, which are both Asian studies, around 12% in Iranian study and 17% in the Turkish study, and my study was 15%. Then there were some studies which had a correlation between maternal vitamin D levels or the baby's vitamin D levels along with bilirubin of the baby. So one study from Iran, which had a small sample size of 60, showed no correlation, whereas from China, by Huang et al., Alia Taba from Iran had showed that and other studies have showed that lower the maternal vitamin D levels or the lower the baby's vitamin D levels, higher the risk of neonatal jaundice, and all of them were a significant correlation like my study. Then we noticed a supplementation paradox in the study group, because in spite of 84% of the women receiving a vitamin D supplementation, only 6% had sufficient level. Many studies have shown the similar result, and most importantly was one study from Qatar which conducted over women of 365, and they was given supplementation from the second trimester onwards. In spite of supplementation, majority had remained deficit and the percentage was 67%. My sample size was small and the time frame was small, and it was interventional because we had to do bilirubin levels for all the babies. Conclusion, neonatal jaundice is multifactorial, and vitamin D could be one of the contributing factor in this risk. And the research of maternal vitamin D has showed there is an increased risk for neonatal jaundice in term babies, and the well-designed large RCTs are required to establish this causal relationship. Maternal education and awareness about vitamin D deficiency is mandatory, as we had seen in my study group, and high-dose supplementation may be required for pregnant mothers, and expert panel guidelines should come up with higher doses and liberal doses for mothers to ameliorate vitamin D deficiency. So my final take-home message is, maternal vitamin D deficiency predicts an increased risk for neonatal jaundice. Maternal education is very vital, and high-dose vitamin D supplementation should be considered to prevent vitamin D deficiency, especially in Southeast Asian mothers. Thank you.
Thank you, ma'am. Any question, please? Mike.
Thank you, ma'am. Thank you, ma'am. Yes, ma'am.
They give phototherapy.
Yes, ma'am.
So just I want to know that did you see retrospectively the children who had jaundice, neonatal jaundice as physiological, studying vice versa the mother's vitamin D?
No, we haven't done, ma'am, but there's literature there. They have reviewed the baby was having low maternal vitamin D, because all the studies which had a review of literature, they collected the cord sample of the babies to estimate the vitamin D levels of the baby, and they've seen some studies have been retrospective. With the baby had jaundice, they had low maternal vitamin, baby's vitamin D levels were low in the cord blood. So it meant mother was maternally.
So this is a new thought that, because this is not done as, because all the cases they usually give phototherapy and nobody does vitamin D deficiency in mother and child.
Yes,
good input.
Thank you, ma'am. Thank you.
Okay, one more question.
Hello. Myself, Dr. Prabdeep Kaur from BSP Hospital, Bhilai. I just wanted to ask, these were your unbooked cases of pregnancy or booked cases with your hospital?
Ma'am, I did not follow it up in a prospective manner. I went in a retrospective manner. So some were booked and some were not booked. So we had collected the sample.
At some point you said that those pregnant women were insufficiently, either were given vitamin D or they were given high doses.
Yes.
So I just wanted to know, because at our hospital we do vitamin D level for all pregnant women at the first instance when they are booked with us, and we give supplementation to them. So I just wanted to know this, whether they were unbooked or booked cases.
No.
They were not undergone any vitamin D level in their antenatal period?
No, ma'am. At our center, we don't, as of now, we don't do any vitamin D levels, but we give a vitamin D supplementation. But this study which I have conducted, It was a
Irrespective of the
retrospective. From their
levels.
medical records, I could retrieve what supplementation they have taken. I haven't intervened anywhere.
Okay. Next.
Thank you, sir.
Thank you so much, ma'am. I may now request Dr. Maya Bush, Rourkela Still Plan, to present, does fast food consumption affect the attention span of a child?
Shall I start? Good afternoon, everyone. Today I will be presenting an interesting study on the fast food consumption and attention span in children. To begin with, there has been a radical shift in the choice of food from healthy food to junk. Unfortunately, there has been a fivefold rise in last 20 years with rising online delivery platforms of Swiggy and Zomato. Attention span refers to the time an individual can concentrate undistracted, and there is a potential connection between unhealthy eating habits and cognitive development. Research problem exists globally. Data from 68 countries showing 50% of children and adolescents consuming fast food. The research question is, can fast food affect attention span in children? Keeping in mind the headlines hitting the newspaper of late and recent publications establishing link between mental health, junk food and television ads, with Indian Academy of Pediatrics coming up with guidelines on fast food consumption, we devised a study with the objective to determine the correlation of fast food consumption and attention span, with special emphasis to trend of food consumption, demographic factors and screen time. It was designed as a hospital-based cross-sectional study conducted from August 2022 to January 2024 in Department of Pediatrics, IGH Rourkela, wherein 124 children from 7 to 15 years with normal brain development were enrolled after consent and ethical committee approval. The sampling technique used was consecutive sampling. They met the inclusion and the exclusion criteria. Data was collected and analyzed in 3 parts. First part of proforma had demographic study variables such as name, age, sex, school, screen time in hours. The second part had a questionnaire on fast food about type of food, time of food, frequency per week consumption, place of food, and the preference of food. The third part, we used a pre-designed and validated score to assess the attention span in children, the ATTC, the Attention Control Scale. It's a self-reported questionnaire with 20 items scored on Likert scale from 1 to 4, that is never to always. It yielded 2 more scores of attention focusing and attention shifting derived from the sum of 9 items and 11 items respectively. Minimum score was 20 and the maximum score was 80. Study was conducted by using the above tools and interviewing the child and the parent. The statistics used were those of student t-test, z-test, chi-square test, Pearson correlation coefficient, p-value of less than 0.05 was considered significant. In the results, we got the mean age as 11.8 years, females being 57%, 57 being from government schools, with screen exposure being 2.4 hours, with 44% preferring ordered food, 74% consuming fast food in snacks itself, 32% consuming daily, and 46% source being street food. All values were statistically significant. The mean attention focusing score was 22, shifting score 31, and the total score was 54. Males had lower attention focusing, lower attention shifting score, and total attention score than females. The study found males having significant association with consumption of spicy, salted food, fried food, ready-to-eat food, sweetened food, whereas females had a significant association with the consumption of ready-to-eat food. Our study found a strong negative correlation between junk food consumption and attention shifting score. Also, the consumption of ready-to-eat food, sweetened food, and beverages had a strong negative correlation with both attention focusing and shifting scores. An interesting result found in our study was significant association of sweetened food consumption in children with screen time more than 2 hours, while in the same children, when attention focusing, shifting, and total scores were studied, they were not found to be significantly associated, suggesting screen time is not the only factor affecting attention span. To the best of my knowledge, this is the first study to use these scores to explore the impact of fast food on cognitive effect on children, with very few references in literature. Our study has highlighted newer perspectives. Kaur et al. In 2019 found minimal difference in age, sex, and school, whereas we found 11 to 13 years to be the predominant age group, with males consuming more of junk food, sweetened food, females having more of ready-to-eat food. Also, private school children showed significant beverage consumption. Geeta Mishra, Arya et al. Found 21% of children watching screen during dinner. We dig deeper and found 2 hours of screen time was associated with lower attention focusing and shifting scores. Zafir, Naeem, Mirza et al. In 2016 found significant enhanced cognition of effect of energy drinks, which was a contradiction. We found children with higher beverage consumption had lower scores. Waldrek et al. In 1994 found no significant impact on cognition with sweetened food consumption, while our study showed significant negative correlation with lower attention scores. So what was already known was association of non-communicable diseases such as diabetes, hypertension, cardiometabolic disease, and arthritis associated with fast food consumption. What we studied and found was significant negative correlation with consumption of all categories of food: junk food, ready-to-eat food, sweetened food, beverages, with lower attention focusing and shifting scores. In fast food consumption pattern, we found most children consume food as snacks, reported daily intake of fast food, with street food being the most popular choice. We found screen time of more than 2 hours was associated with sweetened food consumption with lower attention focusing scores. We delineated that a gender-specific habit showed males consuming more of junk and sweetened, females consuming more of ready-to-eat, males exhibiting lower attention scores. In short, we had a detailed and diversified fast food categories impacting cognitive health in children. The limitations of the study was it was hospital-based. We could not rule out family pressure and emotions. This study underscores the importance of healthier choices we could make, and we could enforce these in future meetings and conferences, whereas children and parents could be counseled. We can find strategies to promote digital well-being in children. We can introspect into the reasons for gender differences with the long-term health outcomes. And as pediatricians, we can form task force to ban the sweetened beverages in schools, at least locally. And last but not the least, we can replicate these scores in further study designs, such as longitudinal studies, to find psychosocial health issues in children. These are my references. This is the questionnaire used for attention score. Thank you.
Any question, please? Give the mic.
I just want to know one thing. Is what you said is you have taken children from the age group of 7 years and above.
7 years to 14 years were involved in the study.
Whatever we see in children regarding the attention deficit or the hyperactive disorder, or for autistic children, it is in the preschool age group when the children, parents come there. And this is something, which, and if a child, and you say that from before 7 years, all these children were normal.
No, I didn't.
They didn't have any issues of.
Yeah, they did not have any neurological abnormality. We ruled out autistic spectrum disorders. That was an exclusion criteria.
No attention deficit.
No attention deficit. We ruled out autistic spectrum.
Then what do you think is the thing, component in the diet or in fast food, which could have contributed to this?
Yes, sir. Studies have, there has been very less literature in this context. There has been studies which have shown that breakfast skipping can cause some mental health disturbances. Actually, the brain grows in 2 parts. Brain grows around 20% in the first year of age, and by 5 years of age, it grows 77%. And studies have shown that in the age group of 7 years, 14 years, and 12 years, the molecular component of food can impact the anterior executive system of the brain, causing mental health disturbances. That there can be attention span, what the study has shown, there can be significant variation in attention span, causing disturbances in learning, in memorizing, and in academic performances of children.
Accepted, but what we want is, suppose...
You can ask the next candidate should ask the question. See, this is not a discussion session. This is a pointed question related to the topic. We should maintain that, and this is a competitive session. So next question from the candidate. Any other candidate can ask one more question. This session is closed. Thank you all for participation. Thank you.
Thank you so much, ma'am. I may now request Dr. Ravindranath M., ED, M&HS BSP Vilai, to present a token of gratitude to our judges, Dr. Parthasarthi Lal and Dr. D.R. Mishra. I request Dr. Parthasarthi Lal and Dr. D.R. Mishra to join us and grace the dais. I may now request Dr. Ravindranath M. to present a token of gratitude to our judges, Dr. Parthasarthi Lal and Dr. D.R. Mishra. Thank you so much, sir. I may now request Dr. Manoj Panigrahi, Additional CMO RSP Rourkela, to present a token of gratitude to our judge, Dr. Sanjeev Mahanti. I request Dr. Sanjeev Mahanti to join us and grace the dais. Thank you so much, sir. I may now request Dr. Manoj Panigrahi, Additional CMO RSP Rourkela, to kindly present a token of appreciation to Dr. Ravindranath M, ED, M and HS BSP Bhilai. Thank you so much, everyone. I hope it was an informative session. Moving on towards the guest lecture. In this guest lecture, our time duration is 30 minutes, 25 minutes for the presentation, out of which after 20 minutes, one buzzer, then again after 5 minutes, one buzzer to mark to end the presentation, and 5 minutes for the interactive session. I may now request Dr. Gautam Das, Deputy CMO RSP, and Dr. Ruby Singh, Senior Consultant RSP Rourkela, to kindly chair the session and grace the dais.
and gynecologists are doing robotic surgery. Robot has three components. One is surgeon console, where the surgeon sits during the procedure and he controls the robotic arm. Second is the vision card. There is a monitor here in the vision card where the assistant surgeon and nurses can see the surgery. It has also place for insufflator and energy devices, and there is patient side card. It has 4 arms. Usually the second arm is used for camera, first and third arms are working arms, and fourth arm is used for assistance. So what happens during a robotic surgery? We make 8 mm incisions, make robotic ports, and then these robotics arms are attached to the robotic ports, and we do the surgery. This is a small video how it works. The surgeon is sitting on the robot and controlling the robotic arms. These are patient side card with robotic arms attached to the robotic ports, and the hand movement of the robotic surgeon in the surgeon console is translated into this movement of these arms. Here we are using 3 ports. The middle one is camera, and both right and left are working arms. This is the vision card where we can see the surgery. Da Vinci have some advanced technology and some advanced instruments, like these instruments have wristed articulation. So these instruments, strips move just like our wrist. Even it can move more than our wrist. So complex suturing or complex dissection or precise cutting can be done with these instruments. Here camera is 3D high definition camera, and it is controlled by the surgeon. So no cameraman is required. There are some instruments like force bipolar with dual grip, which can be used for holding the tissue and coagulation. This is firefly fluorescence imaging. Here an ICG, that is indocyanine green, is injected through IV route, and after some time when infrared rays are given, we can see the vascularity of the bowel or biliary anatomy can be assessed through this. This is a case of robotic anterior section where we have done colorectal anastomosis, and now with firefly we are seeing the vascularity of the bowel. The green color bowel here suggests that the vascularity of the colon we have anastomosis is good, so we can be assured that our anastomosis is safe. Nowadays, application of robotic surgery is almost in every surgical field, like general surgery, cardiothoracic surgery, colorectal surgery, bariatric surgery, urology, gynecology, and head and neck, that is transoral robotic surgery. This is a list of surgical procedures which can be done robotically. In our department, in general surgery, we are doing robotic surgery for inguinal hernia, ventral hernia, cholecystectomy, small bowel resection, Nissen fundoplication for hiatus hernia, rectal prolapse, rectopexy we are doing, and hallux cardiomyotomy for. This is a small video of left side inguinal hernia, that is direct inguinal hernia. This is robotic TAPP, that is transabdominal preperitoneal repair. Here we make a large preperitoneal space. This is the left side direct inguinal hernia. Here we are separating the sac from the cord structure, and once the cord is completely peritalized, then we will assess the defect. This is the pseudosac in direct hernia. It is cut to reduce the chances of seroma in post-op period. This is the direct defect. Here the defect is small, so it doesn't require suturing. Otherwise, if the defect is more than 5 centimeters, we usually suture and close this defect to decrease the chances of recurrence. After the large space is created, we place a 15 into 15 or 15 into 18 polypropylene mesh. Here we are fixing this mesh with a suture, and once it is fixed, the peritoneum Stomach is removed along with the greater omentum, lesser omentum, and lymph node station from 1 to 12. That is all the lymph nodes around the stomach and lymph nodes around the named vessels like left gastric artery, colon hepatic artery, pericolonlocal lymph nodes. And once the total specimen is taken out, we do right. Is clipped and all the lymph nodes around it are removed. This is the first part of the duodenum. It is mobilized from the head of the pancreas, and once it is completely mobilized, it is divided with a linear cutting stapler. There is station 5 lymph node, that is lymph nodes around the right gastric artery. Here I want to just show that we have to do anastomosis of the esophagus with the jejunum, which is esophagus is cut at the hiatus. So deep in the hiatus, doing anastomosis is very difficult with the laparoscopy, in fact even with open surgery, but it's very easy with the robotic surgery. So what are the advantages of robotic surgery to the patient? Robotic surgery has less pain and use of pain medication. Though we use 8 mm ports in robotic surgery and in laparoscopic surgery we use 5 mm ports, but still as most of the times robotic ports are fixed and it doesn't move, so there is less trauma to the parietal wall, so it causes less pain as compared to laparoscopic surgery. There is less bleeding and blood transfusion as the dissection is very precise, less scarring and lesser complication and reoperation, shorter recovery time and shorter hospital stay. Advantages of robotic surgery over laparoscopy are improved 3D visualization, magnification is excellent, better access to deeper organs. There is a process called motion scaling where we can set the robot in a scale of 4:1 or 3:1. That means the larger hand movements are translated into small finer movements in the robotic instruments. Wrist articulation, robotic instruments at 7 degree of freedom of movement. There is tremor filter. It is ergonomically intuitive, so it causes more comfort and less fatigue to surgeon. It also has teleproctoring. That means robot can be connected to a surgeon sitting on some other city from where he can monitor and mentor the surgery. So it is ideal for certain delicate or complex surgeries because it makes it easier for surgeons to avoid surrounding nerves and organs. There are certain myths in robotic surgery. Do the robot perform surgeries on their own? No, robot cannot perform surgery on its own. Surgeons only do the surgery. The second myth is the robot can malfunction during surgery and put patient's life at risk. No, robot is built with multiple safety features that prevent any malfunction from occurring, and the arms will lock in place. So there is no chance of complication like malfunctioning or any injury to the blood vessels or bowel. Previously, it was thought that undocking takes time during emergencies like bleeding, but nowadays robots are more user-friendly. It hardly takes 2 to 3 minutes to undock the robot. And the last one is cost. Yes, though the cost is more as compared to open surgery or laparoscopic surgery, but if we see the cost-benefit ratio, like less hospital stay, reoperation or complication, lesser complication, I think it's worth spending. So to conclude, robotic surgery has proven value in area of inaccessible conventional lab procedures. It has the potential to expand surgical treatment modalities beyond the limits of human ability. Thank you.
Any questions from audience?
What is the energy source you use in the robotic surgery? Is there any difference from the conventional laparoscopy surgery like harmonic?
Sir, we are using monopolar and bipolar cautery. Robotic has a system for harmonic and as well as ligature.
Sir, I have one question.
Sir.
What is the cost difference between a normal or laparoscopic surgery and surgery?
Sir, usually 1 to 1.5 lakh between laparoscopy. Because these instruments are disposable. We cannot use it for after usually 10 or 12 times. It will lock it automatically. But nowadays, there are some Indian robots where instruments can be used indefinitely.
Are the robotic surgery systems being made in India or they are imported from outside?
Most of them are made outside India, but now there are some companies like CNR, they are making in India.
Okay. So thank you for such an informative session. Many surgeons are here. I think you will inspire many young surgeons to take up a robotic surgery. The main restraining factor is the cost.
Yeah,
which
I agree,
many
sir.
hospitals and also the patients can't afford.
Sir.
Okay, sir. Thank you, sir.
Thank you, sir.
Thank you so much, sir. I will now request Dr. Gautam Das, Deputy CMO RSP Rourkela, to give a token of appreciation to Dr. Vikram Sharma. Thank you so much, sir. I will now request Dr. Singh, Senior Consultant RSP Rourkela, to kindly present a token of appreciation for Gautam Das, Deputy CMO RSP. Thank you so much, ma'am. I will now request Dr. Gautam Das, Deputy CMO RSP, to present a token of gratitude to Dr. Ruby Singh, Senior Consultant RSP Rourkela. Thank you so much, sir, and thank you everyone for this session. It's time for a chai break. Chai and refreshments are waiting. We'll reconvene in 15 minutes, so be sure you grab a cup of chai and recharge for the next session. Since we are having a chai break, I request all the delegates to be kindly present in the hall by 4:15 p.m. as we'll be starting our interesting debate session. Please join us for a refreshing cup of chai. Thank you.
Welcome to the 44th All Steel Medical Officers Conference, a proud tradition that continues to unite healthcare professionals from hospitals across the steel plant sector. Over the years, this conference has evolved a stone for knowledge sharing, collaboration, and innovation, with a steadfast commitment to the well-being of employees and their families. At its heart, this event is more than just a gathering. It's a celebration of our collective mission to provide exceptional, patient-centric care. By fostering dialogue and exchanging insights, the conference has played a pivotal role in enhancing the healthcare services delivered to those who are the backbone of the steel industry. In a rapidly advancing medical landscape, this conference ensures that our practitioners stay ahead of the curve through engaging sessions, workshops, discussions led by esteemed experts into the latest advances in medical science, technology, and patient care practices. Ongoing equips our hospitals with cutting-edge knowledge and to address both current challenges and future needs. Rooted in compassion and driven by innovation, The conference reflects our shared dedication to improving health outcomes and enriching lives. Together, we strengthen our commitment to excellence in service, ensuring the health and happiness of the workforce that drives the nation's progress. Let us join hands to inspire and contribute to a brighter future in healthcare. Here's to another enriching and impactful year together. Welcome to the 44th All India Steel Medical Officers Conference, a proud tradition that continues to unite healthcare professionals from hospitals across the steel plant sector. Over the years, this conference has evolved into a cornerstone for knowledge sharing, collaboration, and innovation, with a steadfast commitment to the well-being of employees and their families. At its heart, this event is more than just it's a celebration of our collective mission to provide exceptional, patient-centric care. By fostering dialogue and exchanging insights, the conference has played a pivotal role in enhancing the healthcare services delivered to those who are the backbone of the steel industry.
I request everyone to please be seated. I request everyone to join us in the auditorium. I request everyone to join us in the auditorium. I welcome everyone after a mini relaxation with a cup of chai. Now we have this debate session. With us we have two eminent chairpersons, Dr. B.B. Karunamay, CMO in charge, BSL Bokaro, and Dr. Jayant Acharya, CMO in charge, RSP Rourkela. I invite Dr. B.B. Karunamay and Dr. Jayant Acharya to grace the dais. We have the interesting topic, Idiot Syndrome, in which Dr. Sushant Sinha, CMO in charge, ISCO Burnpur, will be speaking for the topic, and Dr. Jitendra Sarangi, CMO VSP Vishakhapatnam, will be speaking against the topic. The time duration is 15 minutes, 4 minutes for the topic, 4 minutes against the topic, 2 minutes rebut the topic, and 2 minutes rebut against the topic. Thank you so much.
I request please everyone to come into the hall. We are starting the next session.
I request Dr. Sushant Sinha, CMO in charge, ISCO Burnpur, who will be speaking for the topic.
Very good afternoon to all. I think this debate is one of the very interesting topics in the Steel Medical Conference. And that too debate presented by the HOMs. So in that series, we are having a very good topic of idiot syndrome. For that, in pro part, Dr. Jayanta Sinha, CMO in charge, Banpur Hospital, is with us. So I request Dr. Sinha to go with his presentation. Dr. Sinha.
A very good afternoon to the chairpersons, delegates, esteemed judges, and my fellow speaker from Vizag, Dr. Sarangi. So we have a controversy on idiot syndrome, but what exactly is it? Well, it's an acronym for Internet-Derived Information Obstructing Treatment. It's a phenomena in which people either stop or alter treatment on the basis of information available online. It is not a formally recognized medical disorder, but may lead to potential health risks. It is also known as cyberchondria, or health anxiety in the digital age. It has a prevalence of around 30 to 40%, which means idiot syndrome is in, and it will stay no matter how much we debate. So we have a controversial topic, and as you know, controversy means a disagreement, often a public one, that involves different ideas and opinion about something as it affects or is important to many people. And so we'll debate and express different opinions. The reason why I'm in favor of it are far too many. To begin with, it's the right to knowledge. Everyone has a fundamental right to knowledge, and it forms the essence of a democratic society. Anxiety disorders. World Mental Health Survey estimates that the lifetime prevalence of ADs across different countries range from 3 to 19%, which is again under-detected and under-treated. And these are the people who are more prone to access health info online. Next is stress. Well, everyone is under stress in this fast-paced life, no matter at what level you work or you don't work. And stress is supposed to be the natural reaction of the body for changes or challenges, leading to physical, emotional, and behavioral responses. It can be of three types: acute, episodic, and chronic, and it is a chronic variety which leads to health issues. Literacy rate of India has gone up and is presently to the extent of 80%, and it is the literate people who desire immediate answers for health problems. Internet usage in India. In 2025 Jan, the internet penetration in India is close to 66%. The data, 52% is of 2024, and if you see the graphical representation, there has been a substantial increase in the internet usage. Presently, there are 954 million people who are accessing the net. And there has been a transition in the way we access the net. We started with desktops, moved into laptops, tablets, iPads, smartphones, and then smart TVs. Now, what internet does? It has a wealth of information on a wide range of medical conditions, treatment options, and self-care practices. And as you know, information is power. Moreover, it is convenient, and whatever is convenient, people will accept it. So you have a constellation of factors which lead to this idiot syndrome. As these factors will remain, so will the syndrome. It has distinct advantages as well. It has a vast array of health information which is quick and easy to access, efficiently helps people to select healthcare providers at little or no cost. There is a sense of empowerment to the people when they are interacting with healthcare professionals. And it also educates them for a shared decision making. So it will remain. Then what is to be done and what is the way forward? At all forums, what we need to say, we need to exercise caution. There needs to be guidance and counseling. When selecting websites, you need to exercise caution, and it is recommended to consult multiple sites for correct information. We need to address the patient anxieties. There should be collaborative decision making between the individuals and the professionals. develop educational programs and campaigns to promote health literacy and enhance telemedicine platforms. And finally, you need to tell them, consult your doctor. Hi. And finally, thank you, Namaste, and Jai Jagannath.
Thank you so much, sir. Now I request Dr. Jitendra Sarangi, CMO VSP Vishakhapatnam, who will be speaking against the topic idiot syndrome.
Not this one. Respected chairpersons and my dear colleagues, a very good afternoon to all of you. You have heard Dr. Sinha speaking about the usefulness of information that is gathered from internet that can aid a patient's treatment. I am here to say against it and how it affects the general public or the population when they try to get information from the internet and use it for themselves. Which one? Yeah, we all know that knowledge is wisdom, knowledge is power. We have been taught from our childhood to seek knowledge. And they say, Swadesya pujyate raja vidwan sarvatra pujyate. A king is worshipped in his land, whereas a wise person is worshipped all over. But we know that cannot knowledge about any subject just by looking at the internet or for Googling over 10 minutes. And half-baked knowledge is more dangerous than a person who is ignorant. The reason is, a person with ignorance will not be able to spread his knowledge to anyone, whereas a person with half-baked knowledge will share the misinformation with other people. I hope you recognize this person. I'll say, tell you a small anecdote about him. When I was studying in school in the year 1979, one day morning I was surprised to see my grandfather drinking his urine. I was perturbed. I thought he has gone mad. Because, in school we were taught that body excretes things which is not required for itself. But I found him drinking his own urine. When I inquired from him, he told that the Prime Minister of the country has said that a person of diabetes can be cured by urine therapy. And, many people in that time practiced this. It had come only in the newspaper and the television, radio during that time. And of late, till as of date, there is no scientific evidence that explains that urine therapy is effective in a patient of diabetes, and no one has been cured of it till now. In India, two things come very easily, from people. You ask anyone, medical advice and legal advice comes free to anyone and everyone. We all know, we have discussed about this. In fact, there was a presentation in this patient with gallbladder stone. If it is not treated and done accurately, can land up in acute pancreatitis or maybe sometimes with a perforation or acute cholecystitis. Similarly, persons with hernia can land up in strangulation. Similarly, patients with appendicitis, where they have been told by informed people to wait for treatment, can land up in an acute perforation, maybe with a peritonitis. And my gynecologist colleagues who are here, they would accept that many people, nowadays they come, see from the internet, take a tablet of hormone tablet and land up in emergency with either retained product of conception or with an incomplete abortions and land up, that's a significant health hazard on the health of the mother. Similarly, there is another case, whom we had seen. There was a patient of HLA-B27 with arthritis. We advised her to take an naproxen, looking at his parameters. She Googled from somewhere and then found that methotrexate is for one of the medication that she can use. She started using it every day instead of once in a week, and then landed up with a pancytopenia in our clinic. This is very common nowadays. People start Googling because they find it convenient to sit in the room, and instead of going to the doctor and standing in the queue in the clinics, they started Googling and taking the consultations over net or taking the doses of the drugs from the internet. This is one of the things which you would have heard recently when Navjot Kaur Singh Sidhu came and told that his wife, who was suffering from stage 4 breast cancer, got cured of taking a treatment by intermittent fasting and then a mixture of neem tulsi honey. However, he conveniently forgot to mention about the chemotherapy, radiotherapy, and the surgery underwent. And this sends a very bad, wrong signal, because many of the people, at least I have received 10, phone calls from my friends seeking if, it can be a cure for cancer. You all have seen this movie, Three Idiots, where an engineer tries to deliver a baby with a vacuum. I hope people do not try it, otherwise up in emergency, and which is a health hazard. Now, to add to this situation, there are drugs which are available in India over the counter, which is not there anyways, and people can get any drug, antibiotics over the counter, and that has led to the maximum number of antibiotic abuse in the country. WHO calls this infodemic. This is an epidemic of information which is shared, which is, and as Dr. Sushant has said, cyberchondria. People start feeling that they have got a disease condition even if they do not have the disease, by Googling over this net. And we all have experienced this syndrome of a medical students in third year when we go into the clinics to see the patients first and then go through the books and feel like we are having a disease. So whatever little information comes in the net, people starts with a fear. They go and Google in the net. They see that, they have got, they do not have any, they have a mistrust in the medical professional. They start Googling it, then land up in emergency with anxiety and depression. So, and many of the, sites, they publish fake content just for a sensational news and for advertisements and to gain ratings. So therefore, avoid self-shaming, practice relaxation techniques, challenge negative thoughts, and consult your doctor whenever you need. Like every coin, it has got two sides. So similarly, this topic has also got two sides. And after studying for 10 years and practicing for 30 years, we know how little we know about the medical subject of medicine. People trying and claiming that they know about the drug, about the medicine just by knowing about one or two drugs can only be called quacks. And spreading misinformation should be considered as a crime and should be punishable under the law. So don't get, influenced by this idiot syndrome. Rather consult a doctor when you are in need. Thank you.
Thank you so much, Dr. Sushant Sinha and Dr. Jitendra Sarangi. Now the house is open for questions.
Very nice presentation by both. Yes. So the rebuttal is remaining. So let Dr.
We
Sinha
have
sir,
2 minutes.
Dr. Sinha sir will review the points taken.
At least we have agreed on one point. Consult your doctor. Now, let me tell you of a situation. A non-medical person who is out of his headquarters in a remote area at the dead of night is having severe pain. What does he do? He will definitely, obviously consult the net, try to understand what should be the medication, and if he has the medication, he will take it. This is one. Since we have so many doctors over here, how many of us in our OPD clinics are able to give 15 to 20 minutes to a patient in the OPD to explain what is wrong with him, and if you are going to operate, what are the possible complications of the surgery? How many of us? I don't think very many. Thirdly, considering the cost of medicine, cost of treatment, cost of diagnostics, no matter how much we try, people will definitely access the net since it is available at any place and at any time. At the click of a mouse, at the drop of a hat, you have the information. And many of the doctors who have been presenting these papers, some of the data must have been taken from the net. That's what I believe, and that is true. So if you have the scope, if you have the chance, people will access the net for medical info. But what we need to stress upon is that I was saying, we need to tell them, we need to make them cautious that you can access the net, but you must be cautious, search multiple sites, be sure of the sites that you need to access. We need to have a collaborative decision making in our clinics, which we do not do, and the patient should leave the clinic satisfied with all the questions. That is probably not happening. So people will access the net no matter how much we debate, how much we say on this podium. Thank you.
Assessing the internet for information relating to any field can be done, but I think on the basis of medical treatment, people should not, experiment with their own health. As you have heard, the director of the NIT today morning speaking, that the information net says that with these symptoms, person can have a chance of developing a cancer in 90% of cases. If people start Googling and listening to that day in and day out, everyone will go mad. And that is what is called as the cyberchondria, when people feel that they have a disease when they don't have it. With minor symptoms, people start feeling that they have got a serious kind of a disease, because when you start Googling about a condition, and then it gives you a host lot of things. They do not know what is to be done. And I said, we have spent 10 years of rigorous studies in our graduate and postgraduate level to understand what is the disease, what is the anatomy, what is the physiology, what is the pathology, and what medication should be given. As I have said, you must, before taking any medication, a person should have a knowledge about the side effects of the drugs that are to be prescribed. Otherwise, you will land up in pancytopenia, or maybe in some other complications, as we had in one of our patients, or in some other conditions. So treatment is something which should not be handled by people. Whenever it is required, you must consult a doctor other than experimenting on yourself. Otherwise, you do not know when you will come and land up in the hospital in an emergency with a life-threatening situation. And as you have seen in many of these conditions, and we have been seeing in the presentations also, that there are many complications that can arise if we do not know about. And yesterday, in fact, in the communication thing, we have seen that in spite of reading all these things, still we commit mistakes in the ICU. We commit mistakes in the wards. We commit mistakes in the day-to-day activity. So, in spite of knowing about the things, when we commit these things, just imagine what will happen to people who do not know anything about and start treating themselves. And I leave it to your wise decision to take over whichever path you want to choose. Thank you.
In fact, I just want to add that in this period of AI, we have to accept that patients will be coming who have already Googled before they reach you. So we cannot escape from the people going to seeing the net and then treating themselves. We cannot escape from that. But the thing is, we have to adapt ourselves for now, how to balance this, the information and the reality. This is our duty to make people understand how to handle this information in a proper way so that they are safe. Because the person who is giving information on the other side is not responsible for whatever shit is happening with the patient. This is number one. And second is, sometimes internet also, it helps, because there are many good sites where you are able to connect with other patients with similar problems, and at least you should know, we can have a direct contact or direct talk to those patients and can share your whatever experiences, and maybe you can get some good information which can help you out. So these are the only two things which I like to say. Thank you.
Any questions? So if there is no question, then we can conclude the session.
Thank you so much, Dr. Sushant Sinha and Dr. Jitendra Sarangi. This was an end to the debate 3. Moving on with the debate 4, and the topic is intermittent fasting, myth or truth, in which Dr. Vinita Singh, GM Medical Services, Tata Steel Plant, will be speaking for the topic, and Dr. Sujit Kumar, CMO in charge, VISL Bhadravati, will be speaking against the topic. I request Dr. Vinita Singh and Dr. Sujit Kumar to be on the dais.
It's a slide changer pointer. You can do it from here also.
Yeah, this one, no? Thank you. Good evening, all. Intermittent fasting refers to restricted times of eating and fasting, and I speak for the motion. We are now third in the rank for obesity epidemic and would soon be reaching first if we don't work on it. Now, we often get these images on our reels. And why is it that it's so difficult to lose weight? And I'm curious to know before and after pictures where they stand today, because it is not easy to practice this, sorry. It is not easy to practice this. Diet cycle is vicious, so it goes into a cycle of gaining weight, then you do a diet, lose weight, and again, you tend to regain. And this is because of the difficulty we face in practicing this, eating less. Now, what is the maths of weight loss? And this is the assumption because of which most of these diet fads do not work, or we have been unsuccessful because US has done multiple research over the last 50 years to address their obesity issues. And what the popular misconception is that calorie deficit. So we have thought that if we eat less and or add on the exercise, that is exercise more, that alone would lead to weight loss, which is not entirely true. It does work, but there is a third angle to it, which is the hormone. I'll speak about it shortly. So what actually happens? There was a very famous US reality TV show, which is called The Biggest Loser, and they were monitoring people to see who loses weight at how much. And they found out that unexpectedly, they found people were even gaining weight. So what actually happened? When there is reduction in calorie intake, the body goes into adaptation mechanism, whereby it conserves energy, leading to less calorie output in terms of once the basal metabolic rate is low, you become lethargic, listless, tired, and so your activity will decrease, so your calorie deficit decreases. And on the other hand, you become more hungry. The study looked at increase in hunger hormone ghrelin and decrease in satiety leptin, leading to more hunger and more calorie in. And that explained why some patients, some of those participants actually even started gaining weight. So what does intermittent fasting actually do? You do not need to. And also historically, we are, our country, we practice this for ages, and it's now the Western world telling us to do what we were doing anyway for long. How does this work? Now, insulin is a hormone, so if you eat all day, you'll have insulin surges, and every time insulin is high in blood, it does what it is meant to be doing, which is maybe good or bad, but it is supposed to be increasing your fat storage and not reducing lipolysis. So in other words, the idea of weight loss, which is you actually want to reduce what fat you have, will not happen because it will not tap on the body store. Whereas with fasting, what happens is you have those hours of fasting. It could be 12, 16. You can choose what you want. And there's no insulin surge. The basal metabolic rate remains good and high. So fat store door opens and you tap the fat of the body. So this would then lead to weight loss. I hope it's a little clear. There's another slide to this. So what intermittent fasting does, is you have hours, 16 to 12 hours of less calorie intake. Your metabolic rate remains high and maintained during that hours because you're not having insulin spikes. And so there is low calorie in, high calorie out, which is fine, leads to calorie deficit. But this is added on by lower insulin level because of your fasting status. So your body fat store is mobilized, leading to weight loss, which did not entirely happen with calorie restriction alone. If you, just 1 minute. Yes. So just looking at all, there are many researchers, I'm just running through the slides to say that IF prevents development of diabetes, it reverses type 2 diabetes, it actually is anti-inflammatory. These are all research evidence. It keeps your heart strong because it keeps you in a parasympathetic overdrive. It also cures certain autoimmune diseases like type 1 diabetes, rheumatoid, SLE, and also helps your brain heal. Anti-cancer effect of fasting is also there. In IF has positive effects during cancer treatment as well. So I rest my case here and would love to hear my colleague as to why this is not better. And it is very flexible. You can choose 12 hours, 16 hours, 19 hours, 1 meal a day or 1 hour of meal. And this can be built up gradually, but make sure you have those hours where your insulin spike does not occur. And these are the broad takeaways. So I'll now listen to my colleague, Dr. Sujit. Yes.
उसी हैंग हो गया।
Got the topic. Presentation. Kaushik, screen. Good evening, everybody. Respected chairpersons. After having since morning 2 meals and 2 tea breaks, still we are debating about the intermittent fasting. Is this required? We'll see this. I am Dr. Sujit Kumar. Which is better, intermittent fasting or intermittent eating? In Sanskrit, they say it is not correct. Sharira madhyam khalu dharma sadhanam. That means body is the media for to achieve something in life. And why to punish the body? These are the three types of intermittent fasting Madam was telling, like 5:2 diet or 16/8 method or alternative fasting. Is this really required? Not at all. And these are all the intermittent side effects. Fasting like excessive hunger pangs, fatigue and low energy, headache, ranging from mild to severe, dizziness, digestive issues, constipation and bloating, irritability and other mood changes, bad breath. So nobody should come near to them. Sleep disturbances, dehydration or polyuria. Is intermittent fasting safe? In fact, many people are unable to complete intermittent fasting trials as demonstrated by the high dropout rate of intermittent fasting. Heightened risk of developing or exacerbating an eating disorder, a serious issue that should not be overlooked. While intermittent fasting is not itself an eating disorder, it can be considered a form of disordered eating. Placing restrictions around your eating and ignoring hunger cues can easily become a slippery slope into a disordered relationship with food or an eating disorder. So what our ancestors used to say, in the morning you have breakfast like a king, in the afternoon have lunch like a common man, in the night eat like a beggar. This is sufficient, no need for any fasting itself. And what the research says, a recent study published in JAMA Internal Medicine showed no differences in weight loss between those who fasted and the control group of consistent eaters. Most studies on intermittent fasting lack the longer-term research and larger sample sizes needed to support intermittent fasting as an effective and sustainable weight loss strategy. Studies have found that people who regularly fast more than 16 or 18 hours a day have higher risk of gallstones and need surgery. Is fasting hard on the heart? People who limited their eating window to less than 8 hours a day had almost double risk of dying from heart and circulatory diseases. Potential drawback, people with diabetes also run a risk of developing diabetic ketoacidosis. They may die of diabetic coma or death. For people with chronic diseases, little is known about the response to fasting and how their risk due to fasting are changed is uncertain and require studies to be conducted in these populations where elevated health risk exists. And what are the limitations? There are no systematic reviews and as such lacks the power to summarize all trials with statistical significance. Many of the randomized control trials failed to include the with diabetes patients. And these are the 4 Ds for healthy life. In Kannada we say Buddhi, sound mind, Niddhi, good sleep, Muddhi, that is balanced food, or Laddi, normal bowel habit. Without food we cannot have all these other 3s. And this is not just a joke. 2 eggs in the morning, whole eggs and not just egg white, 2 eggs in the evening, and things to do before a meal to prevent overeating. Don't miss meals. Intermittent fasting leads to feast or famine attitude that mistakenly leads to overeating. Stress reduction by engaging in regular exercise, practicing calming practices like yoga or meditation. Eat breakfast without fail. Eat every 4 hours. To conclude, there are no statistically significant studies to prove that intermittent fasting is beneficial. It cannot be practiced in diabetic, chronic diseases, old age, etc. I say, eat everything what you want, drink whatever you like, but know your limits. So intermittent fasting is a big myth. Don't go by it. Thank you.
Thank you. So my opponent said that there are side effects. Now these are transient and settle down with time. Just like when we start exercise, do we not get body aches, muscle aches, and the only way to get rid of it is to continue. So they're not serious at all. Safe, yes, our ancestors, even today, we have so many people doing fasting, and that is how we practice in age-old times. It was, 2 meals a day, and usually a night time would mean you don't cook or you don't eat. So it's been practiced for ages and it is safe. There is a study recently in New England Journal of Medicine in 2022, which actually looked at 139 candidates, and they put one group into calorie-restricted diet alone and the other group on intermittent fasting. And they saw at the end of 12 months, they saw 6.3 kg body weight loss in the calorie restricted alone, whereas the intermittent fasting group had 8 kg. So it is not entirely bad. However, the study was underpowered, and 139, you need a much larger sample size to say that it is not effective. So studies are good and they are fine, but they need to be, also have, for statistical significance, you have to have a larger size. Diabetes, yes, it is useful in delaying onset of diabetes. There's enough proof, and it does reverse type 2 diabetes. Why is then dieting not so successful? For years it's been a problem, and everybody struggles. And that's why I would suggest and I recommend that adding on this restricted time along with restricted food, would actually get you the actual results of having an optimal weight and a healthy nation. Thank you.
Just curious to know from this August gathering, how many people are practicing intermittent fasting or fasting? Nobody?
Dropout. Yes, I am dropout. Because all the 10 complications you had shown, it was there with me.
So everybody experiences in their lifetime what are the effects of fasting. A person cannot work. Any person's most productive time of the day is between 9 a.m. to 2 p.m. If you do not have anything in the morning, what will you do? What will happen to his productivity? Definitely it will come down. A person without having any food in the morning, what will he work? Alternate day fasting, how can we practice that? It's literally not possible. So it is not required. You think, I told you that you just know your diet. A person, in Kannada we say, ಊಟ ಬಲ್ಲವನಿಗೆ ರೋಗವಿಲ್ಲ ಮಾತು ಬಲ್ಲವನಿಗೆ ಜಗಳವಿಲ್ಲ. That means a person who knows how to talk, he will not quarrel or fight. A person who knows his diet, he doesn't have any disease. What is the requirement of the intermittent fasting? It is a misconcept. It is a myth. It's not at all required. That's all. You can decide.
So a very nice presentation by our two speakers regarding food. But very conflicting. Someone says eat, someone says don't eat. So what is the opinion of the audience? Is there any questions? So 2 questions are invited.
My question is for ma'am. Actually, I have 2 questions about intermittent fasting. Whether you follow or not, it's not question. When to follow? I mean, who are the subjects? Like a 10-year-old boy is obese. Then whether he should undergo this thing or not. Second thing is, if it is preventive or it is a curative one. That's the 2 questions.
Most even healthy people who are not obese could use it as a practice because it does delay the onset of diabetes. I practice intermittent fasting, but having read in this for this debate, I'm now more convinced than ever. So except diabetic patients, and there would be a small group of ill patients where they may not be subjected to this, but type 2 diabetes could practice, and majority of people can practice. See, it is not about all these programs do not sustain weight loss. And we have to accept obesity is a problem, epidemic in gynecologists, OPDs. Now young girls are coming obese. So, and we have to be realistic as well. जिस किसी को बोल देना अच्छे से खाओ और बस वजन घटाओ 5 किलो is not easy to do. So how do we help them achieve this is what I'm trying to put forward.
I understand,
and it does help
but
if you.
I want to know what age means. I am asking about the age that somebody is obese at adult age. That is a different. Somebody is obese at young age. I mean, in a 10-year or a 12-year boy is obese. Then in those cases,
10-year-old and all, it has to be adults I'm talking about.
Okay.
But yeah.
I am Dr. Rashekar from RNL, Vizag. Coming to the same question which he has raised. Madam, for both of you, is it applicable for the pediatric? Say in case of obese or in case of overweight, because the metabolism or the metabolic rate itself is completely different. Whether it is intermittent fasting, whether you go for it or not. Or the second thing which he said, because they eat every 2 to 4 hours, they are high metabolism. Second, if they eat also now, they are becoming obese and overweight.
You're asking me about childhood obesity?
Yeah.
Yeah.
Child,
So there was a paper earlier about how, lifestyle changes and childhood. So
next generation, the next generation that is what we are saying, that 1 in every maybe 10 cases they become overweight or obese by 2030.
Is a problem. Yeah, childhood obesity is a problem. The lifestyle we have adopted. In fact, when we were young in schools, you would see 80% of children are slim and trim and hardly 5 to 10%. Now the equation is other way around. So I'm not saying intermittent fasting for children. I'm not sure about that. But definitely as adults, we can have a lifestyle where it should be, healthy eating and exercising and some kind of time. We know that if parents follow a healthy diet and healthy times, the same can be applied to children. I don't see why not.
Thank you, madam. I think we have discussed all the things regarding the food. So the only point is we have to rationalize the eating, and that's why we can go ahead. So with this, the session is being declared closed.
Thank you so much. This was an end to our debate session. Thank you, Dr. Vinita Singh and Dr. Sujit Kumar. I may now request Dr. B.B. Karunamay, CMO in charge, BSL Bokaro, to kindly present a token of appreciation to Dr. Vinita Singh and to Dr. Sujit Kumar. Thank you so much, ma'am. Thank you so much, sir. I may now request Dr. Jayant Acharya, CMO in charge, RSP Rourkela, to present a token of appreciation to Dr. Sushant Sinha and to Dr. Jitendra Sarangi.
Chairperson, sir. Jayant Acharya,
Thank you so much, sir. I may now request Dr. Jayant Acharya, CMO in charge, RSP Rourkela, to present a token of appreciation to Dr. B.B. Karunamay, CMO in charge, BSL Bokaro. Moving ahead, I may now request Dr. B.B. Karunamay, CMO in charge, BSL Bokaro, to kindly present a token of appreciation to Dr. Jayant Acharya, CMO in charge, RSP Rourkela. Thank you everyone for this session. Moving on ahead, thank you so much everyone for this great session. Moving on ahead, let me introduce to our distinguished panelists. Our panelists will share their insights, experiences, and perspectives on the topic Violence Against Healthcare Workers, where the total time is 30 minutes, 6 plus 2 minutes per speaker, out of which after 5 minutes, one buzzer, then again after 1 minute, one buzzer to end the presentation, and 2 minutes for discussion. The moderator for this discussion is Dr. Pushpa Kumari, Rourkela Steel Plant. I may now request Dr. Indrani Chaudhary, Bokaro Steel City, to speak on different type of scenarios.
Good evening. It is the end of the day. Everybody is feeling very. My talk encourage you everyone because it is a very. ये नहीं आ रहा है. Change करो. Now it is coming. So my today's panel discussion topic is violence against healthcare worker. So why at all there is a need to discuss regarding violence against the healthcare worker? So these are the different topics will be covered by our different panelists. So I may request Dr. Adappa Santipriya to come to the desk. She will tell about the do's and don't. Dr. Indrani Chaudhary, you sit there. He will talk regarding different scenarios. And Dr. Sumit Mukherjee, he will tell about how to report a case of violence. Dr. Sumit. Please be seated there. Dr. Saubik Chatterjee, he will tell regarding what are the after effects of the health care worker. And Dr. Nivedita Mishra, she will tell about the legal aspects. Where is Dr. Nivedita? ये तुम्हारा नाम नहीं दिखाई दे रहा है. You sit there. So what is the need? I will give brief discussion regarding the topic, then it is dealt by our panelists, then we go for the question and answers. And if anybody has any questions, you can give me in a sheet so that I can discuss during our discussion. So what is the need of this discussion? Because as already discussed in the early morning, and our DIC also told that we are God on the earth. We are representing the God. So is it true? So this will justify. So violence against doctor in India is a growing problem. It is increasing day by day. In which way? Either it may verbal use or physical confrontation or even threat that will lead to even death of a doctor. So who are healthcare worker? So there are two types. One is direct and indirect. Direct, doctor, nurse, and indirect who assist. Then what is the workplace violence? In the medical field is defined as any action involving abuse during the course of duty posing a significant risk. So what is the prevalence? According to IMA, almost 75% doctors in their experience they have experienced violence at their work at some point of time. Again, according to our data of 2024, 60% of the respondents felt unsafe at the work. A study in the Kerala found that 65.5% doctors experienced violence. So this is the gravity of the situation. So there are few examples, like in 2019, Kolkata became epicentric. Similarly, in June 2021 and in July 21. So there is a repeated times doctors are often attacked and assaulted. So these are the examples: Dr. Seju Kumar Senapati, then Archana Sharma, who committed suicide, then Vandana Das, who is a house staff. She was attacked by one patient while she is examining a patient. Then the extreme end is when we witnessed a Kolkata rape case and murder. Then recent case of attack on the oncologist. So where may violence occur? The most common place of occurrence of violence is casualty, psychiatric ward, emergency room, waiting room, and geriatric room in order. So what are the risk factors? Why it is occurred? The risk factor for the physician or doctor and healthcare worker, and risk factor for the patients. So this is for the doctors. Long working hours, poor emergency, communication gap, these all factors are dealt by our next panelist. So these are the family members and the affected, say long waiting hours and perceived neglect. They feel that they are neglected. So what are the effect of the violence? The effect on the victim, effect on the organization, and effect as a whole on the society. These again discussed by our panelists. So while we are searching for how does you are aware, about 80 to 90% they are not aware how to report a case of violence. So the need of the hours. So we know how to report. So causes of underreporting, the fear of reprisal, time-consuming process, belief that reporting won't help. So there are certain causes. So code purple. What is code purple? Like code blue. Under NEBS hospital, there is different code. So according to code purple, whenever there is any violence, it triggers a code activated, emergency response team notified, area secured, response and de-escalation, threat neutralized, then there will be resolution, and we have to debrief and report. If you don't report, it will not work. So these are do's and don't, which is dealt by our panelists. Then coming to the end of that legal aspects. What is the importance of legal aspect? It is to protect the healthcare worker, to ensure safe environment to work our healthcare worker, and we need stringent punishment for the culprit. Otherwise, the moral of the health work will come down, and indirectly it will affect the society. Because if there is a healthy environment, healthy healthcare worker, it will directly reflect the society. Thank you. I will request our next speaker, first speaker, that is Indranil, to present his case.
Good evening all. Members of this august audience. It is with great trepidation that I am here to present my topic, violence against healthcare workers scenarios. My job has been made easier by Madam because she has already expressed in her slide what we are going to witness in a few slides from now. First of all, let us see. This content is a little disturbing. Audio.
An on-duty medical officer was beaten by locals inside a COVID care center in central Assam's Hojai district. A case has already been registered and one person has been brought to book. That's what the police have said. In a viral video, a medical officer during the afternoon shift was brutally beaten.
As you can see, it was a very disturbing video. We need not go into the gory details. Now, what is violence? It is a rough or injurious physical force of action which is unjust or unwarranted and against the rights or laws of the citizens. It's a global problem that affects all health workers and in different work settings. According to the WHO, about 62% of health workers have experienced workplace violence at some time or the other. Now, what are the common risk factors? As Madam has already elaborated, these are the common risk factors which result into violence, like working directly with volatile people, especially if such people are under the influence of drugs or alcohol, people who have a violent nature or are suffering from some psychotic illnesses, when the doctors or the healthcare workers are understaffed or are working alone, during transportation of patients, during meal times or during visiting hours, long waiting periods for services to be rendered, overcrowding and uncomfortable waiting areas. Now, healthcare settings, the different scenarios in which the workplace violence can occur are during times of high activity, during interaction with patients or attendants, during the transportation of patients, when the patient is involuntarily admitted, during billing processes, and following hospital rules. Now, what can go wrong during the times of admissions? It is a time of high activity. Like if you are explaining the grave prognosis to the patient's attendants, it will also involve the amount of the cost that might affect the patient's attendance. If an anaphylactic reaction occurs, or there are some unexpected consequences of treatment, or finally, if inadvertently death occurs, even if the patient party knows that the death is inevitable. During patient transportation or shifting, or patient healthcare workers can be assaulted when the service is denied or delayed, or the patient dies during the shifting process itself. In the billing section, not understanding billing procedures, claiming overcharging or unexpected charging, the inability to pay on the part of the patient's attendants, or the denial by hospital staff to treat the patients for not handing over the dead body for non-payment of dues. Certain hospital rules may go against the healthcare workers themselves, while like advance payment, like getting permission from the office for treatment to commence, prescribing medicines, appliances and materials to be purchased from the hospital only. Now types. What are the types of violence that can take place? It can happen in the form of offensive languages and abuses, threats of assault, physical assault, destruction of property or medical equipments, disrupting the hospital routine and the treatment of other patients, and even homicidal attacks. So, the message, of course, we are all healthcare workers over here. Obviously, this is a message that has to be distributed into the surroundings that don't harm your lifesavers. Thank you.
Do's and don'ts. Do's and don'ts. In the panel discussion. Yeah. Panel discussion. లేదు లేదు. A very good evening, everybody. My topic is do's and don'ts about violence against healthcare workers. Violence against healthcare workers is nowadays becoming a very serious problem in India. Hospitals, clinics, and other medical places are reporting more number of cases of verbal abuse and physical abuse. Mostly doctors and sisters often experience anger with the patients and their attendants. This situation not only harm the healthcare workers but also affects the functioning of the healthcare services. These are the factors that are responsible for triggering the situation of violence from the side of healthcare workers, and these are the factors contribute to violence from the side of patients and their family members. All these factors will create mistrust, confusion, and hostility towards medical staff. Overall underlying cause for violence is that patients are not getting required information from the doctors. This naturally creates anger, which leads to loss of public trust. These trust issues emerge as neglect, resulting in retaliation and revengeful assault towards medical personnel. This table indicates what we should do in scenario of violence. Generally, in India, most of the doctors never discuss regarding the diagnosis of the treatment to be adopted, details of the diagnosis, cost involved, and possible side effects. We, the doctors, should realize we may see hundreds of patients during our profession, but for a patient, it may be the only ones facing like this crisis. Hence, all healthcare workers should feel as if he or she is a patient that is suffering with a given disease. Then only the mindset of the patients visiting can be realized and understood. Hence, all healthcare workers should treat the patient with respect. They should respond well in the first visit itself. We should ensure human touch. We should empathize with the situation, and we should try to remain calm during tense situations. And we should always try to practice active listening. And we should always give priority to our own safety, our colleagues and co-workers. We should be able to recognize the signs of rising tension. Then only, and we should know when to call the help based on the situation and earlier experience. If any healthcare worker suffering, if he feels overwhelmed with his work, then he should call his co-workers for help. Working together can make handling the situation easier and safer. And violence not only affect the person involved, but also affect the colleagues around him. So be supportive during any incident. We should provide clear and honest information about the patient or treatment to reduce understandings. And immediately after an incident, affected healthcare workers should report any threats or abuse to management and should record a detailed document on the incident for legal and administrative follow-up. We should be confident with skills and we should participate in conflict resolution trainings. We should collaborate with hospital administration to improve safety measures and rebuild the public trust. We should stay professional and avoid personal confrontation, and we should know our rights and legal protections. We should not delay the referring cases to higher centers, and we should respond emergencies immediately, irrespective of entitled or non-entitled, rich or poor, or a case of emergency. Certain changes from the institution side also will reduce the incidence of violence. There should be a reception counter in every hospital, and it should be manned by very courteous, smiling, and helpful employees who can communicate properly with the patients and their attendants. If required, the people from help desk should accompany them to the required areas. In majority of cases, most of the violence is due to the behavior of the sub-staff. We need to train them properly and make them sympathetic towards the patient. Management also should conduct counseling classes and awareness programs to all the concerned, including doctors, emphasizing the importance of courteous behavior with the patients and their attendants, under any circumstances. This counseling classes also to be conducted to involved in the violence by explaining the stressful behavior of the healthcare environment, which may sometimes project as a apparent negligence. And all hospitals should always maintain fully equipped ambulance services with trained staff, and they should provide CCTV surveillance and emergency alarm. One thing we should remember that the patient's anger is not about us. Their intention is not to hurt us. It usually comes through his own stress and frustration. So we should not take it personally. Let us discuss what we should not do during the violence. We should not retaliate physically or verbally. We should not engage in arguments with aggressive individuals. We should not dismiss or belittle patients or family concerns, and we should not hide the critical information from patients. We should not allow too many attendants to interfere in the process of treatment, and we should not allow personal emotions to influence professional behavior. At the same time, we should not disregard the emotional impact on others. We should not respond with anger. It will escalate the conflict further. We should always stay calm, and it will diffuse the tension. If we argue, the situation will become worse. We should not overstep a personal safety, and we should not handle the situation alone. And we should not avoid participating in follow-up discussions to prevent future incidents. We should not ignore the warning signs, and we should not dismiss or minimize the situation. Such violent incidents should be tackled by the teamwork, where all the concerned should have discussions and deliberations time to time to make the hospital violence-free. By following the do's and don'ts outlined here, healthcare professionals can protect themselves and continue to provide quality care. Thank you.
So thank you very much. We have already know what are the do's and don'ts. Yesterday, we have a very good workshop on the communication. So we have to know how to communicate and what to communicate and when to communicate. Otherwise, we will land yourself in the edge. Suppose we have to reveal the truth, our certain factors. So do's and don'ts are very important. After knowing do's and don'ts, I will request Dr. Sobik to present how to report a case of violence. It is very important because most of our surveys done, 80 to 90% they don't know how to report, whether reporting is essential or not. So it is important.
Very good evening to all, my respected seniors and my colleagues. Today I'm going to discuss regarding the pattern, regarding the protocols of reporting of incidents of violence in the hospital or rather any healthcare establishments. Prevalence of violence in our country is very common, but the reporting is very less. It may be due to ignorance, it may be due to ignorance about the reporting procedures and the rules and regulations available for protecting the doctors. There are a few studies. One of the study is done by was done by Ruchi Garg, and she found that among doctors, it is the awareness about the reporting procedures is only 24.6%, whereas among nurses, it is a little bit of higher, that is 41.4%, and among the Group C employees, it is 10.4% only. Similar study was conducted by Chadarke et al. In that study, 80% of the respondents even reported, surprisingly, that they do not have any contact number whom to contact during an emergency situation. 70.2% respondents reported there is a lack of clear and confidential reporting system, and 20% of the respondents reported in their particular hospital there is no reporting system as such. And majority of the medical professionals, including doctors, nurses and paramedical staffs, have not received any kind of training to report such kind of incidents or violent episodes which is happening in the hospital. So this is a diagrammatic representation what I have said my last two slides. Now, what are the causes of underreporting? Already Madam has given briefly brief description about this slide. Mostly the causes of underreporting is fear of reprisal, fear of retaliation, blame, time-consuming procedure, lack of administrative support. These are the two important causes. And there is a belief that reporting won't going to help much. And perception that such type of violence is a part of occupation, that it may be occupational hazard. And if the violence in the form of threat, verbal abuse, in comparison when the violence is a form of physical abuse, chances of reporting are more. In case of verbal abuse, people are sometimes okay, they just leave the thing. Now, National Task Force has been formulated by Honorable Supreme Court after the heinous crime that happened last year at Arjikar Medical College. Supreme Court has taken cognizance, suo motu cognizance in this matter, and during the hearing process, they formed a national task force, and that national task force has assessed the entire situation scenario over the country and suggested few guidelines, and that guidelines has been sent to all the clinical establishment, including the government medical colleges, hospital, and the government establishments. And in their guideline, they suggested that there should be a distress call system, and that to be installed in the critical part of the hospital, that is emergency ward, in front of the general emergency, in OT, in ICU, where there is a possibility of such kind of incidences. And there will be a central panel or central control, and they will continuously monitor if any kind of feed or signal is coming to the system or not. And a standard operating procedure should be there for each and every hospital, and the doctors and the other staffs should be trained to maximize the utilization of this available support. Incidents of any kind of violence to be reported to the local police station within 1 hour, and FIR to be lodged within 6 hours, and this should be done by the head of the institute or by the nodal officer. As a part of the vision of the Government of India, One India, One Emergency number 112 has been operationalized, and this number can be used for reporting any kind of violence in the hospital, but it is a general number. They will channelize that complaint to the police administration and will take appropriate action. Now, each and every hospital should have incident reporting system. This comprehensive incident reporting system will help us to analyze the pitfalls or other difficulties due to which these incidences had happened. If incident reporting system works properly, then we will minimize the chances of violence in the healthcare system. And non-reporting of any incident should be dealt with very serious note, and accountability should be fixed. But we do not have any incident response form. In Western countries, they follow this protocol by writing the whole incidents under the following heading, that is location of the incident, date, time and length of the time, description of the violence that occurred, and who are the sufferers and who are the witness, and violent incidents caused by, that is who are the perpetrators. Lastly, a brief description about the whole incidents, whether it is physical, verbal abuse, any weapons is being used, or any physical injury is there. An injury report should be obviously there. And brief description about the cause of the violent incident. It may be due to dissatisfaction with the patient care, death of the patient, or these sort of things. And we can add some any additional comments. And this is a template I have given over here in the appendix B, that is incident response form. We can register our complaint in this fashion. Thank you.
Our next speaker is, he will tell about what are the after effect of the violence. Dr. Sobik.
Check, check.
Good afternoon. Everyone from the back to the front, good afternoon. I know you have a stomach full of lunch, good delicious lunch, but I request to have your ears for the next 6 minutes.
Any query regarding violence, the audience, they can give me in cheat. So I will discuss. I ask our panelists. In the meantime, you can give me. Laptop problem. Should I go for question and answer?
August 9, 2024, a day we will never forget, when an enraged mob took to the streets to capture the night. Yes, justice is half done and justice is still elusive. A very hearty good afternoon to one and all present here. As you all know, we are discussing violence against healthcare workers and its after effects. These are my contents. To start with, how do we define violence? We can define violence as anyone. It is something that follows an antecedent. And in this case, what is the antecedent? Anyone, what is the antecedent? A violent activity itself. Now, the most number of cases in India are non-reported. So what is the first after effect? That it is not reported. 70% of cases are not reported. And why is it so? Because people think it is a part and parcel of their life. They are unlucky enough, they are at the wrong time, wrong position, no action will be taken, stigmatization or inconvenient, shamed or labeled incompetent, additional harassment to their family by the abusers. Now what did Arnott all said? He said that if there is preventive measure in the institution, the number of reported cases for workplace violence increases. Coming to the effects, the timeline effects of violence can be divided into immediate, intermediate, or long term. Now in immediate, there is physical violence, like bruises, something severe as death, or something psychological, like stress or anxiety. In intermediate, sleep disturbances or lack of concentration, and in long term, we see post-traumatic stress disorders or a person's disillusionment with his work, tends to quit his job. Now, so what are the impacts of violence? As I said, it can be physical, it can be mental, come in mental, post-traumatic stress disorder, sleeping cycle disturbances. It can be behavioral, like a person becomes impulsive, socially seclusive, and also lack of empathy. Now, sexual, often when sexual angle is involved in violence, there is miscarriages, unintended pregnancy, or sometime due to forced copulation, there might be even death. Now, in most of the cases, it is very difficult for the victim to start a family in future. And financial. Why financial? Because if there is a relationship between the victim and the user, mostly also indirectly, there is a resource constraint. So there is an indirect effect. When there is a attrition of workers from hospital or other places, it affects the economy. Now there are different levels of violence. It may affect healthcare workers, on the system, or on the family members. Now on the healthcare workers, they experience demoralization, depression, loss of self-esteem, or ineptitude. There is also post-traumatic stress disorder, sleeping cycle disturbances. Now Kaur et al. In one of its studies said that 52% of reported cases of violence have lack of self-esteem and shame. There is also alcohol and substance abuse, fear of life or anxiety, injury, suicide, or death. Now, for healthcare professionals, seeking mental health service is not feasible because of lack of resources and stigmatization. Coming to the effect on families, there is emotional, physical, social, and financial isolation, secondary traumatization from family, friends, and society. Trauma impacts differently upon specific family members, how it will affect the son or the husband, and how it will affect the parents will be different, and negative responses towards the society and life at large. Effect on the healthcare system. There is a decline in the quality of care delivered. A number of studies have reported a reduction in quality of care and an increased risk of medical errors resulting from workplace violence. Increased absenteeism, health workers' decision to leave the field, Loss of staff has been linked to workplace violence in multiple studies. Also, number of health services available to the general public will be limited because of lack of resources, increased healthcare costs due to resource constraint. Equal access to primary healthcare would be threatened, and there will be increased referral. These are the 10-point plan to address violence and aggression. Plan, do, and check. This is how you can mitigate and prevent violent activities, and I'm sure subsequent speaker will definitely shed some light on this. These are my references. I'm thanking you with this informative slide where it is said the effects can better be managed by a good work-life balance. So we should all practice a good work-life balance. Thank you once again for your patient hearing, and Jai Jagannath.
Thank you for the very impressive talk. Next, my last speaker, she will speak regarding a legal aspect, which is not clear. Do we need a central law or not? She will clear that.
आज पेन ड्राइव में डाला था, आज पेन ड्राइव में डाला था आज पेन ड्राइव में डाला Good evening, everyone. So, going to the past, more than 130 years ago, there was a writing in Journal of American Medical Association that no physician, however conscientious or careful, can tell what day or hour he may not be the object of some undeserved attack, malicious accusation, blackmail, or suit for damages. So it is as old as that. Coming to the present, we have all heard about all the horrific incidents at the Arjikar Medical College, and then in Andhra Pradesh, in Agartala, several incidents. So they highlight this harsh reality that violence is more prevalent in public health facilities and disproportionately affects younger and female professionals especially. So there was a call for legal protection. Over the years, the healthcare community has consistently called for laws which are robust enough to deter such violence. But unfortunately, there is no central law which exists to safeguard healthcare workers nationwide. Different states, to be 19 or even more states, have got varying provisions for this, and this lack of uniformity meant that protection is actually inconsistent. So when the epidemic came, COVID-19, Indian government, they laid down the Epidemic Diseases Amendment Act. Under this, different specific duration of imprisonment and fine were fixed. And there were multiple posters like this to support the healthcare workers and to avoid violence against them. There was a cabinet decision that discrimination, harassment, and physical violence against healthcare service personnel and damage to property during epidemics is punishable under this act. And later on, slightly near about that period, there was a bill which was proposed to the Parliament, the Healthcare Service Personnel and Clinical Establishment Act, which had a clear definition of violence, and everything was prepared, but however, it was rejected by the Ministry of Home Affairs then, stating that passing the bill would set an improper precedent for other fraternities to demand exclusive protection based on their professions. So here I have compared all the three aspects. The one was the Epidemic Diseases Act, where the punishment for violence is up to a certain limit, and then the Healthcare Service Personnel Act, where the proposed bill was there, where the period of confinement was increased up to 5 years and the amount of fine was increased up to 5 lakh rupees. But look at the old Indian Penal Code Act, which the states which do not have any specific act fall under this law. That is, anyone causing any harm to others or to another person, the states will fall under that law. The fine up to only rupees 1,000 or imprisonment up to 1 year. And whenever there is grievous harm, the punishment is more, 7 years in Epidemic Disease Act and up to 10 years in the proposed bill. But in that old Indian Penal Code Act, even for grievous act, it is a fine and punishment up to 7 years. And damage to property, accordingly, different limits were fixed. This was for protection of healthcare service personnel. So coming to the state laws, several states have then, since there is no central law, several states have passed legislation to protect their healthcare service personnel. These are the states. So all of the state acts prohibit any act of violence against healthcare service person and any damage to property in healthcare service institutions. They have fixed imprisonment up to 3 years and a fine of up to 50,000 rupees only. In Tamil Nadu, the maximum prison sentence may be up to 10 years. So currently in 25 Indian states and union territories, they have the Medicare Service Persons and Medicare Service Institutions Act of 2008, which has undergone amendment, coming to a fine of 50,000 and 3 years imprisonment. But 4 states and 5 union territories, they lack any kind of law against violence against healthcare workers. So what is the problem in enacting a central law? Because a central law is not been enacted because public health is a state subject and it is primarily a public health related issue. While this list allows for a central law, but then the central government has not prioritized this issue, leaving it to the states to manage. So coming to the individual states, like in Maharashtra, they have filed a public interest litigation because out of 157 violent incidents, only 77 were reported, 71 were charge-sheeted, 2 only were decided and none of them were convicted. So you can look at the very miserable state of affairs. And this PIL mentions several precedents and requests the High Court to exercise its power. So this was the document of the lawyer who has been given to look at this document, and he wanted time, the government wanted time to introduce a new legislation, and this was 3 years back and nothing has happened since. So, but Kerala is little advanced in this matter. Following the incident of Vandana Das, who was stabbed by 11 times by a drunk school teacher, they formed this resulting Kerala Healthcare Service Persons and Healthcare Service Institution Act of 2023. It is one of the strongest state laws. It extends protection to a wide range of healthcare workers, where the High Court has directed that an FIR has to be filed within 1 hour. It's like the golden hour where we have treatment for heart attack or stroke. It is same thing like a golden hour, and this is a cognizable and non-bailable offense, and expedite delivery of justice by stipulating that within 60 days of filing FIR, the investigation has to be complete and the victim has to be examined on consecutive days, and special session courts with special prosecutor has to be there. In Karnataka also, no legal action was there, and they also passed this bill in 2024, which is even better than the Kerala Act. So these are the loopholes have to be closed. And this journal has suggested in 2017 that we can make a no treatment list for all such patients and their family members, like a no flying list, which is active in the aviation sector, and barring emergency treatment, they have to be referred to the government hospitals. So it is an urgent problem requiring attention from all societal stakeholders. It's just not a medical fraternity issue, but weakens the whole of health system and affects the quality of services. Thank you.
Thank you very much. Now we go for the question session. So I think public has no questions. So I'm waiting for any questions. So I will ask some question to our panelists. most common scenario at your place? You belong to Bokaro? So what is the most common?
The most common scenario that we face, I'm in the Department of Pediatrics, I'm heading the Department of Pediatrics. So it is naturally a very sensitive area. And most of the times, the thing is, when we are explaining the disease process to the patient's attendants, the first thing that happens is disbelief. If the disease is, according to them, incurable, then the first thing that happens to the response that we get is disbelief.
You are a pediatrician, so you are talking. But most of the case is emergency room.
Yeah, also this is what I'm saying, from the pediatrician's point of view, as well as from the emergency doctor's point of view. The first point of entry is in the casualty or the emergency department in any hospital. So the first reaction that is of disbelief, followed by then disagreements and anger.
So why there is a disbelief?
Disbelief ki
What is
aapne
the
ye
commonest reason of that disbelief?
commonest reason is they have the different sense of the perception of the patients, attendants, is might be differing from that of the doctors.
Okay, thank you. So most important, don't for the doctor. Doctor, hello? You have to shortcut the answer because you have already narrated.
Okay.
So out of that, don't, which is most important for a doctor.
Sir, madam, all are important, all are equal only.
So out of that,
what I prefer, for any violence, the root cause or a triggering point is the improper and
so
aggressive.
don't confront. Be quiet. That is my answer.
For any violence,
It will prevent
the
you further
yeah.
litigation and
Sir,
anything.
the
So it
root-
is out of the most important.
The out of
Then
most
how
import-
to act and respond to a violence.
Sir, madam, for any violence, the triggering point or root cause is the improper and aggressive behavior of the that concern. So we the healthcare workers should not
nahi aa
talk
raha hai,
aggressively with the patients and their attendants under any circumstance, and should not undermine the concerns. That is the main important. We
Okay,
should
thank
not
you.
do that.
So any difference between act and reaction and respond? So there is a huge difference between act, react and respond. So we should not react. We have to respond. So this is a big difference. So during this violence,
Yeah.
we have to be calm and calmly respond. Thank you
yeah.
very much. So what are the most important causes of the underreporting, Dr. Sumit?
Mostly,
Out of, you have narrated all causes. So out of that, which is most important underlying cause of the report? Is it
mostly the
unawareness-
administrative inertia and long time consuming procedure.
procedure?
These are the,
And also there is no reporting form. There is no
Yeah.
reporting system also there.
exactly.
And they are not aware how to report.
These
So-
things are mostly important for underreporting.
Okay, thank you. So recent guidelines for the reporting violence.
According to the guideline of the National Task
So
Force,
there is no guideline.
yeah,
So we have to follow. Sure, sure. So most common after was already told. Then need of central law, it is already explained by her. So we will finish as is lack of time. I conclude my session. Thank you very much. Thank you to every panelist. Okay, thank you. So actually I want to say how does Karnataka Act differ from the Kerala? Because Karnataka, they have told, we have, she has not Kerala, इसको बोल देती clear पे. बोल दे क्या?
Thank you so much, ma'am. I may now request Dr. A. Shanti Priya to present the token of appreciation to Dr. Pushpa Kumari. I may now request I may request Dr. Pushpa Kumari to present the token of appreciation to Dr. Indranil Chaudhary, to Dr. A. Shanti Priya, to Dr. A. Shanti Priya, to Dr. Sumit Mukherjee, to Dr. Saubik Chatterjee, and to Dr. Nivedita Mishra. And this was an end to our informative panel discussion. Thank you so much, everyone. Let's continue the conversation, and I welcome everyone for the symposium on the topic pain management. We have two eminent chairpersons, Dr. Raj Ranjan Kumar, CMO in charge, DSP Durgapur, and Dr. Sujit Kumar, CMO in charge, VISL Bhadravati. I invite Dr. Saubik and Dr. Sujit to grace the dais. I invite Dr. Sujit Kumar and Dr. Saubik to grace the dais. Time duration for the symposium is 45 minutes, 8 minutes for each speaker, out of which after 7 minutes, 1 buzzer, then again after 1 minute, 1 buzzer to mark to end the presentation, and 2 minutes for discussion. I request all the speakers to kindly grace the dais. Dr. Sikha Agarwal, BSP Bhilai, Dr. Uday Kumar Das, ISCO Burnpur, Dr. Manoranjan Samantrai, RSP Rourkela, Dr. Avijit Dam, BSL Bokaro. I request all the speakers to kindly grace the dais.
Hello.
Thank you so much. I may now request Dr. Sikha Agarwal, Bhilai, to present the topic, Approach to Patient Care.
Respected chairpersons, faculties and delegates, a very good evening to all. The topic of symposium is pain management, and I am going to speak about approach to patient care. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There are 4 types of pain: nociceptive pain, neuropathic pain, nociplastic pain, and mixed pain. Nociceptive pain is due to tissue injury. Neuropathic pain is due to any nerve injury or disease of the nerve. Nociplastic pain is due to altered perception of the central nervous system. Mixed pain, there can be both tissue injury or nerve injury. Now, how do we approach a patient with pain? There is something called as patient-based approach, where P stands for patient perception, where we have to listen to all the complaints of the patient properly. A stands for assessment, where we have to assess clinically the patient and form a diagnosis. T stands for tailored approach, where we have to form an individual tailored treatment plan for each patient. I stands for interactive evaluation, where we have to regularly follow up the patient for the treatment. E stands for educating the patient and the caregivers about the treatment. N for the non-pharmacological approach, where we have to consider non-pharmacological approaches like exercises along with the medical management during the first line of treatment. T stands for team approach, where we have to involve all the multi-speciality along with the pain physician. Now, perception of pain. First, we have to listen to the perception of pain, where some patients like old age, patients which are sleep deprived, obese patients can have altered pain perception. They can have low pain thresholds. Also, patients who have negative experiences in life can have low pain threshold. So, we have to listen to the perception of pain properly and believe the patient. Even if there are no organic injury in the lab tests or investigations are normal, we should not blame the patient that something is not wrong. Then assessment, assess the pain, where is the pain, when the pain started, what is the quality and intensity of pain, why any aggravating or relieving factors associated with pain. Quantitative assessment of pain, where we can assess the degree of pain by numeric rating scale or visual analog score, where 0 is no pain and 10 means worst pain possible. Features specific to neuropathic pain are allodynia, hyperalgesia, numbness, tingling, burning. Now this is qualitative assessment of pain, the Leeds assessment of questionnaire, where the patient answers the questions, and if a score is more than 12, it is likely towards neuropathic pain. This is pain detect tool, similar questionnaire for the assessment of neuropathic pain. After history, next is examination. We have to take the vitals, examine the gait, posture, cranial nerve examination, motor, sensory reflexes, myofascial examination, spine, neck examination, and then coming to specific joints. Low backache is the commonest pain symptom when in a pain clinic. This is the algorithm for the evaluation of low back pain. Then this is the algorithm for evaluation of neck pain, for shoulder pain. For chronic headache, first we have to rule out the red flags symptoms like thunderclap, headache, fever, papilledema, and then we can follow the algorithm. Fibromyalgia is a lesser known but a common cause of generalized pain. This is the diagnostic criteria and the symptom severity score. Chronic regional pain syndrome, again, is a central cause of pain where we have sensory, vasomotor, pseudomotor, motor clinical features. These are the investigations which can be done for evaluation of pain. Functional MRI is a research tool to evaluate the brain centers associated with pain processing, where specific centers will be highlighted due to increased blood supply during pain. 60% of the patients suffering from chronic pain will have mental illnesses requiring treatment. Routine screening for depression is must. There is something called as the pain cycle. Anger, anxiety, because of pain there will be anger, anxiety, which will cause decreased mood, again depression, and that will again increase the pain perception. Due to pain, the patient will avoid activity and there will again be increased pain. Now, after formulating all the clinical features, we have to formulate a diagnosis and follow a tailored approach for the patient, involving the pharmacological treatment, physical therapy, behavioral therapy, minimally invasive interventions, and surgical intervention. Usually, minimally invasive interventions and surgical interventions are reserved for last. Now, this is the WHO guide, 3-step ladder, where the first step is non-opioids, second weaker opioids, third step is stronger opioids. A fourth step of minimally invasive procedure has been added, which can be added at any point of the step. After treatment initiation, we have to regularly evaluate for the treatment effectiveness, telemedicine is a good option for the evaluation. Next is patient education. We have to educate the patient as well as the patient's relatives about the other factors which can affect pain, like sleep, nutrition, exercise, stress, physical life, flare-ups, medication. Next is non-pharmacological approach. Alternative therapies like acupuncture, physical exercise, tai chi, yoga, aqua aerobics, music therapy, pet therapy, these are all can be considered along with medical management at the starting of the treatment. Finally, team approach. We have to involve all the specialists, orthopedic surgeons, neurophysicians, psychiatrists, dietitians, rehabilitation doctor, rheumatologist, pain physician for the multidisciplinary treatment of the patient. Despite of all these multimodal approaches, pain still remains one of the most distressing symptoms for the patient. Thank you.
Now, house is open for question. One question, please.
If there are no questions, thank you, Dr. Shikha Agarwal.
Thank you, sir.
Then we'll move on to the second speaker. I call upon Dr. Uday Kumar Das, ISCO Burnpur. Now he is presenting on medical management of the pain.
Very good evening, respected chairpersons, senior delegates, and friends. We all know the pain is a complex subjective experience impacting physical, emotional, and social well-being. According to an estimate, chronic pain alone affects more people than diabetes, cancer, heart disease combined, and it exerts a substantial socio-economic burden worldwide. Now, it doesn't affect only the healthcare system, but society at large, as individuals having pains are associated with increased rate of utilization of healthcare resources with decreased rate of productivity. Broadly, pain can be categorized depending upon the etiology into nociceptive, neuropathic, and nociplastic pain. That has already been written by the previous speakers. The WHO analytic letters, this is widely recognized framework providing a stepwise approach for pain management depending on the intensity of the pain. Non-steroidal anti-inflammatory drugs are very effective in mild to moderate inflammatory pain, have ceiling effect, and long-term use are associated with gastrointestinal, cardiovascular, renal, and hepatic complications. Opioids play a very significant role in the moderate to severe pain management. It affects quality of life, but major deterrents are its common side effects like dependence, addiction, tolerance, constipation, pruritus, respiratory depression, etc. Following opioid crisis and subsequent public health hazards, stricter guidelines have been placed for the use of opioids. The Center for Disease Control and Prevention guidelines recommends that opioids should be used only if the expected benefit outweighs the risk at the lowest effective doses and for the shortest expected duration to treat the pain severe enough to require opioids. The common adjuvant, this is also called co-analgesic, recommended for the management of pains are tricyclic antidepressant like amitriptyline and nortriptyline, serotonin, norepinephrine reuptake inhibitors like duloxetine, venlafaxine, anticonvulsants like gabapentinoids, carbamazepine, sodium valproate, corticosteroid, topical agents, magnesium sulfate, calcitonin, biphosphonate, and cannabinoids, etc. Based on the systemic review and meta-analysis of multiple clinical trials, the common treatment approach include that systemic and topical NSAIDs are efficacious for nociceptive pain, whether pain is acute or chronic. SNRI, TCA, and gabapentinoids are recommended as first-line treatment for neuropathic and nociplastic pain. Capsaicin patches, lidocaine patches, and weak opioids like tramadol, hydrocodone, and codeine were recommended as a second-line treatment. And third-line treatment includes the strong opioids like fentanyl, morphine, etc. Now, coming to the novel pharmacological agent targeting pains. calcitonin gene-related peptides, a neuropeptide released in response to tissue injury and inflammation, and it plays important role in pathophysiology of migraine and other chronic pain syndromes. Monoclonal antibodies against the CGRP and oral iranumab, tremanajunab, galcanezumab, etc., and oral gepants like abrogepant, remigepant have shown better safety profile and efficacy in the migraine preventions. Transient receptor potential vanilloid 1. The drug targeting TRPV1 has two major disadvantages. First, it decreases the sensitivity to noxious stimuli. This can lead to accidental burn, and it also increases the body temperature. So after failure of multiple agents targeting TRPV1 receptors, modality-specific antagonists have been developed, which is in phase 2 clinical trials. Now, voltage-gated sodium channels, particularly NAV 1.7, 1.8, and 1.9 present in peripheral neurons, and these are being targeted for pain management. Vixotriazine, NAV 1.7 blockers is in phase 3 trial for the trigeminal neuralgia and phase 2 trial for the erythromelalgia. The adverse effect reported is anosmia, as these channels is also expressed in the olfactory nerve. Suzetrigine has recently got the US FDA approval for chronic acute pain in adults. Quinapide, again, NAV 1.7 and 1.8 blockers is in topical formulation under clinical phase 2 trials for the post-hepatic neuralgia. Voltage-dependent calcium channel. These are responsible for release of neurotransmitters from the vesicles into the synaptic cleft. The commonly used therapeutic agents are gabapentinoids. Giconotide, a synthetic derivative of omega-conitoxin, a peptide from the conistin velum, is under investigation for use as an intrathecally for severe pain management, for whom other treatments have failed. Opioid receptor-like ones. The drug acting on opioid receptor-like ones are associated with the decreased opioid-related side effects which happens with the conventional opioids. Sabranopredol is a low-selective oral 1 agonist, currently in phase 2 trials. It also has a reduced risk of respiratory depressions. Nerve growth factor inhibitors. This combines with the tyrosine kinase A receptor present on the sensory neurons and increases the activity of TRPV1 and voltage-gated sodium channels. The humanized anti-NGF antibodies developed are tanezumab and fasinumab. They are under various stages of clinical trials for chronic low back pain and osteoarthritis. The major safety concern reported is that it can lead to rapid progression of osteoarthritis, leading to joint damage. Cannabinoid receptors. The CB2 receptors present in immune systems and peripheral organs, and it is devoid of the psychomimetic effect and abuse potential of CB1 receptors. So olorinab, a highly potent CB2 agonist, has completed phase 2 trials for the treatment of visceral pain, and kedalinab, another potent and highly selective CB2 agonist, has shown analgesic and anti-inflammatory effects in phase 1 trial. N-methyl deaspartate receptors. This receptor is involved in the chronic pain pathology. Ketamine in low dose has been found to be very effective in treating the refractory chronic pain. Though its analgesic effects are very short-lived, but its anti-anxietic and antidepressant effect can last even for weeks. In burn injury, it also decreases the wind-up phenomenon and secondary hyperalgesia. It also decreases the opioid-induced hyperalgesia. Glycine and agonist to NMDA receptors, which is devoid of any psychomimetic effect of ketamines. So the glycine antagonists are being developed for neuropathic and inflammatory pain. Nanoparticle technology, these are a promising approach in pain management, and these are very small size particles, 1 to 100 nanometer in diameters, with unique physical and biochemical properties, and it is being used for targeted drug delivery, improved drug efficacy, control and sustained release formulation, and of course, it has a reduced off-target effect because it is delivered at the site of actions. So the key principle involved in pain management, the selection of pain management can be complex, and it requires consideration of patient-specific factors like comorbidities, previous pain treatment, and psychological factors. A step up or down the ladder based on the patient pain intensity and response to therapy, and of course, medication do not come without risk. So, patient frequently need to be evaluated for adverse drug effect. My key take-home message is effective pain management requires a multifaceted approach. Combining pharmacological, non-pharmacological, and interventional method is often helpful. Pain should be treated not as a symptom, but as an experience affecting the whole person. Thank you very much. Pain also is pain for patients are in need, and maintaining positive attitude in negative situation is the key. Thank you.
Thank you. Good deliberation. House is open for question. One question, please.
If there are no questions, Dr. Uday Kumar Das, very good presentation. Thank you very much. Now I call upon Dr. Manoranjan Samantre to present his topic on interventional management.
Respected chairpersons and the delegates, extremely sorry for the delay and the technical glitch. So I'll talk briefly on this interventional pain management. It is for chronic pain. Chronic pain is a pain that persists beyond a period of 6 months or beyond the time of normal healing. In suppose a injury occurs, pain occurs for 3 to 5 days like that. But if it persists more than 1 month due to some type of modulations, then it will cause as chronic pain. The interventions is never intended for the acute pain. So what is this interventional? It's diagnose and to treat. It's not only to treat. Sometimes these interventions help in diagnosing these cases. They are minimally invasive, non-surgical, and target specific. And it comes in between the pharmacological management and the surgical management of the disease. So what can we do in these interventions? We can inject steroids into joints in the epidural space. We can target the medial branch of the DRG. We can inject ozone, radiofrequency ablation of the medial branch. Recently, cooled radiofrequency. We can implant spinal cord stimulator, may go for sympathectomy, and PRP therapy and prolotherapy. So first of all, we should know when not to do these cases. The red flag. It's in trauma, tumor, tuberculosis, and infection. Those are not the persons for this interventional management. Tuberculosis may produce sinus, infection may spread, tumor may bleed, and trauma absolutely it needs surgery. So where to do these interventions? It always needs a operation theater. We should never go for these interventions outside the OR with monitoring, anesthesia workstation, resuscitation equipments. Obviously, this consent, patient IV line, and documentation are necessary. All these things are necessary because of these complications. Subarachnoid spread is life-threatening. Hematoma in the epidural space, damage to the nerves, and intravascular injection of the interventional drugs. Those things may be fatal. Of course, the incidence is quite low in expert hands. And now I'll come to this back pain, which is the most frequent one. We have to identify the pain generator. It may be disc, it may be facet joint, it may be nerve root. In disc, it is the pain at rest. In facet joint, it's a pain on movement. And in nerve root, it is associated with tingling and numbness. Other differential diagnoses are also there. Sarcoileitis, coccydynia, and piriformis syndrome. They may also mimic this back pain. So this is the most common patients who come to the pain clinic. In this nucleus pulposus protrudes through the disc and compresses the nerve root to produce pressure pain. And if it is ruptured, it is highly inflammatory and causes inflammation of the nerve root and pain. Here, we can target the nerve root and inject this epidural, inject the steroids under this fluoroscopy guidance or ultrasound guidance by confirming through the dyes and may relieve the pain. And in facet joint arthropathy also, we can go to the facet joint, inject the dye, confirm the joint, inject steroids, and the pain will be relieved from 3 to 5 months in those cases. And this radiofrequency ablation of the medial branch, now recently this pulled radiofrequency, they just partially damage the medial branch of the DRG, which causes the modulation of pain, means enhancement of the pain. So that's why by that we can relieve the pain. And in resistant cases of this failed back syndrome, we can introduce this spinal cord stimulator in the epidural space in the failure cases. And in compression fracture of the vertebral body, we can go for this vertebroplasty. It's a little bit invasive operation, injecting this cement into the body of the vertebra, which relieves the pain permanently. Now we'll come to this. These are the injected procedures, and this is regenerative medicine. Means we will enhance the growth of cartilage, enhance the relieve the pain by injecting this dextrose, platelet-rich plasma, mesenchymal stem cells, bone marrow, and adipose tissue. Out of which this PRP and dextrose are quite commonly used. So where you can use this? Knee osteoarthritis, rotator cuff tears, patellar tendinopathy, plantar fasciitis, and chronic lateral epicondylitis. This platelet-rich plasma, they activate, they are taken from the patient, platelet is removed from the by centrifuge, add thrombin or calcium chloride, which releases the 70% of the growth factors within 10 minutes. And that thing, if it injected into these degenerated joints, may induce growth of the cartilage and relieve the pain subsequently. For elbow and ankle, we need 3 ml. For 3 ml platelet, we need around 10 to 20 ml blood, and in knee shoulder, 7 to 10 ml. For that, we need around 40 to 50 ml blood. It's patient's own blood. We add thrombin, release the growth factors, and promote the growth. Most efficacious concentration is 1.5 lakhs. And thing is that these are all the different interventions, but thing is that the management is always multimodal. Psychoprophylaxis, behavioral cognitive therapy, some analgesics, and evaluation and follow-up. Those things are very necessary in case of for the management. Thank you.
House is open for any question, please.
PRP, actually all these interventions, that depends on the response of the patient. Suppose in one patient it may act for three months, and in some patients it's for 6 months. But these interventions are repeated. And one thing is that this PRP may not act in all the patients. As this is quite safe to inject patient's own thing, it's never a failure, means there is no complication associated with it. And many times the relief is 70%, many times the relief is 50%, it's like that. So actually these injections, they are given in old age patients. And in those cases where the knee replacement is not possible due to some other reasons, in those cases it helps to prevent some kind of pain, but it should be also associated to some lighter degree of analgesic requirements are also there. It is repeated. All the patients, those are coming from 2014 to me, that till now they are coming every 6 months. And they can avoid the operation, and they are well going now.
Thank you, Dr. Manoranjan. Now I call the next speaker, Dr. Abhijit Dam from BSL Bokaro on holistic care of the pain management.
Namaskar, सभी को. And in over my almost 30 years of practice of medicine, I have realized one thing, and that is a sloka from the Brahma Vishnu Upanishad, which goes that man evang manushyanam karanam bandho mokshapya. The mind, it is the mind and mind alone which is the cause of our bondage and our liberation. I prefer to go by this definition. Pain is what the patient says hurts. अगर patient कहता है मुझे दर्द है, तो है. In spite of your best efforts, in spite of whatever you have done, if the patient still goes back and says कि मुझे दर्द है, तो है. Period. When physicians deconstruct suffering to its physical dimensions while ignoring the psychological and spiritual pain, they not only fail to relieve suffering, but compound it. Because bodies do not suffer. The person within the body suffers. So as you look at this picture, it is not only about that old tree out there in the picture. There are clouds, there are grass, the whole landscape. And that is what makes the picture complete. I have many gurus. She was one of our guru. And she taught me the platinum rule. She used to come to our my pain clinic and she never used to look up at me. तो एक दिन मैंने सोचा कि पक्का आज तो छोड़ूंगा नहीं इसको. So I got this box of chocolates for her. You can see there is a large tumor in her in the right lower part of her humerus. And I had to wait for nearly half an hour. आधा घंटा बाद उसने अपनी आंखें उठा के मेरी तरफ देखा. And believe me, those were the most beautiful eyes that I've ever seen in my life. And when I asked her कि क्या क्या दिक्कत है तुम्हें, कहाँ दर्द हो रहा है, and then she told me, जब मैं अपनी माँ को देखती हूँ मेरे लिए रोते हुए, तब मुझे बहुत बुरा लगता है. And all the while, I like a fool, I used to think that maybe it is her own physical pain. So it is all about the patient, what the patient wants, and that is the platinum rule. So we need to change our perception as to what the patient needs, not what we think that the patient needs. This was one more guru of mine. After this cancerous growth, he lost his job. His wife refused to sleep with him. His little daughter would have a look at him and run away. He attempted suicide twice. तो इसको कैसे treat करेंगे? By pharmacotherapy, interventional pain management, that would help him. What would help him is the onion, प्याज. अब प्याज को याद रखिए. प्याज तो सभी लोग छिलते हैं ना. So we remove the layers, we peel off the layers. So the first layer is the layer of nociception. He had constant pain aggravated by chewing. Second layer, that the affective component. He was feeling bad, he couldn't sleep, he couldn't eat, he used to feel irritable. Then the social layer, he couldn't work, he lost his work, right? He couldn't play with his children. And then the behavioral, the next layer, he attempted suicide twice, was angry at others, he used to fight with his wife. Because if you can't cut the, अगर प्याज ठीक से नहीं कटता है ना, तो खुद के आंखों में आंसू आ जाता है. And that is what treating pain in its totality is like. So if you look at the, I'll just run through this. There is something called a lateral pain system in the brain, which is concerned with localization of the pain, localization, intensity, type of pain. And then the medial pain system, which is concerned with the affective part, the emotional part of the pain. Now, if you destroy the lateral part of the pain system, then it does not eliminate But if you destroy the medial part of the pain system, it eliminates pain, which means that it is the affective part of the pain which is more important. So this is something called this is something which is called total pain. Dame Cicely Saunders had coined this term. So I'll just give you an example of social pain. Like this gentleman, just have a look at his face. He used to ride a rickshaw. He was a rickshaw puller. And then he had a growth, he had an ulcer on his arm, malignant ulcer. And some very clever surgeon decided to amputate his whole arm. But if you look at his axilla, already there are mets. So this is what we don't want to happen, because there is suffering now, social suffering. It is seldom a medical man has true religious views, because there is too much pride in the intellect. And I'll give you an example of religious pain now. This gentleman, C.A. Lung, and he used to be so scared. That is his wife in that orange sari. He used to be so scared that कि उसकी wife जब bathroom जाती थी, he used to insist कि दरवाजा खुला रखना. And then we kept on inquiring gradually and gradually we peeled the onion. And तब पता चला उसका एक बेटा था. बेटा बाप को छोड़ के चला गया था. Now this gentleman was afraid कि मैं जब मरूंगा तो मेरा मुख अग्नि कौन करेगा? Because in Hinduism it is the son who does the मुख अग्नि. So that was his pain, his religious pain. Now I'll give you an example of spiritual pain. This lady with these huge tumors, we treated her. She accepted all this, कि ये तो मेरा किस्मत, this is my fate, ये मेरा कर्म का फल है. She was perfectly fine with all that. But then she still had suffering. So we went on inquiring. We found out कि वो एक बगीचा लगाई थी. She lived in a village, एक vegetable garden लगाई थी. And हर दोपहर को she used to sit there in a चारपाई with stones. पत्थर लेके बैठती थी क्योंकि वहाँ बंदर आते थे सब्जी खाने. So she used to drive away the monkeys. उसका चिंता था कि मैं जब मर जाऊंगी तो ये बंदर को कौन भगाएगा? Because that garden was her spirituality. So we asked her Bahu to reassure her that koi baat nahi, I will take care of the bandar. And then she was happy. Well, thank you for your kind attention.
Good deliberation, very informative. House is open for any question?
If there are no questions, thank you, Dr. Abhijit Dham. I thank all the speakers for their nice presentation. It was a very good informative topic. Pain management is very essential in anybody's life. Thank you, everybody. Now we conclude the session.
Thank you, sir. I may now request Dr. Raj Ranjan Kumar, CMO in charge DSP Durgapur, to present a token of appreciation to Dr. Shikha Agarwal and Dr. Uday Kumar Das. Thank you, sir. I may now request Dr. Sujit Kumar, CMO in charge VISL Bhadravati, to present a token of appreciation to Dr. Manoranjan Samantrai and Dr. Abhijit Dham. I may now request Dr. Raj Ranjan Kumar, to present a token of appreciation to Dr. Sujit Kumar. I may now request Dr. Sujit Kumar to present a token of gratitude to Dr. Raj Ranjan Kumar. By this, we come to the end of this session. It's a pleasure to host you tonight at Roadkla Club with a special dinner. You all are honored to join us for an evening of fine dining, entertainment, and a great company. May this evening bring us joy, laughter, and a deeper connection with one another. We are grateful for your blessings we share and the friendship we cherish. Thank you.
तेरा बात